Good morning, everyone, and welcome to Bug Day. For those of you who don't know me, my name is Lynette Siragusa, and I am the CEO of Shared Health, as well as the Vice Dean of Education at the Rady Faculty of Health Sciences. I will begin today by acknowledging that health services across Manitoba are provided in facilities located on the original lands of First Nations, Inuit, and on the homeland of the Red River Métis Nation. Shared Health and the Health Sciences Centre respects that First Nations treaties were made on these territories, and we acknowledge the harms and mistakes that have been made. We dedicate ourselves to collaborate in partnership with First Nations, Inuit, and Red River Métis in the spirit of reconciliation. I am very happy to be here with you for the 27th annual Bug Day. This event is the largest interdisciplinary accredited education event in Manitoba. We have a great lineup of speakers ready to present today. The organization committee has done a fantastic job again this year in bringing together an amazing group of speakers for Bug Day. The health system's appreciation for our colleagues in the field of infection prevention and control has always been present, but having recently been through the pandemic, the importance and the understanding of their contributions has certainly grown over the past several years. On behalf of Shared Health, I want to thank each of you and your respective teams for joining us today. I also want to thank all of you for your expertise and your ongoing commitment to providing safe healthcare for the people of Manitoba. At this time, I would like to introduce you to an individual who has provided expert guidance and leadership in the area of infection prevention and control for many years. He is the Medical Director of Infection Prevention and Control for the Winnipeg Regional Health Authority. He is a professor of medicine and a specialist in internal medicine and infectious diseases at the University of Manitoba. He is a driving force behind bringing the experts in each year to share their knowledge at Bug Day. And most importantly, he is also our moderator for today's proceedings. Please welcome Dr. John Emble. Over to you, John.
Thank you. Thank you, Lynette. And greetings, everyone. As you heard, I'm John Emble. I'm the moderator for today, and welcome to the 27th anniversary of Bug Day. 2,200 registrants participating, and we hope that you have a great program. A few housekeeping things. For those of you who want to collect continuing professional development credits, you must register. It is absolutely critical. If you don't register by 4 o'clock today, there will be no continuing professional development credits. You can upload questions using Slido, and it's going to be #BUG 2023. And you need to allow about 14 days for the attendance certificates to be ready. Any questions? Upload them to Slido, and hopefully the program will go flawlessly. I'd like to introduce our first speaker, who will deliver the first presentation of the day, Dr. Armel Villalobos, all the way from Mexico, now living in Winnipeg. Armel is a specialist in infectious diseases with a specific interest in the immunocompromised host. Armel is based at the Health Sciences Centre, University of Manitoba campus, and Armel's presentation is entitled "The Immunocompromised Host, A Call to Action." Armel, please take it away.
Thank you. Thank you for the kind introduction. My name is Armel Villalobos, and today I'm going to talk about the relevance of immunocompromised individuals and all the more relevant points for their management. So I have nothing to disclose. And first of all, we're going to start with the definition of what an immunocompromised patient is. An immunocompromised individual is a patient who does not have the ability to respond normally to an infection because of an impaired or weakened immune system. So it has been documented that immunocompromised hosts have the risk of developing more severe infections. Also, they're more likely to end up in the hospital if they develop one. And there's also a significant association with high mortality comparing to the immunocompetent individuals. So it's a common thing to think that immunosuppression is an uncommon condition, really applying to rare genetic disorders, HIV infection, cancer, or chemotherapy, or transplant individuals. However, this is no longer the case. Immunosuppression is now common in the treatment of inflammatory and autoimmune disorders. Therefore, now the list of contemporary immunosuppressants keeps growing and growing all the time. We have from the well-known to all of us, the corticosteroids, who are immunosuppressive molecules, to more sophisticated immunosuppressive drugs such as JAK inhibitors, interleucin inhibitors, TNF, B-cell and T-cell inhibitors, to some others. So that only means that young, vibrant, healthy colleague that is sitting next to your cafeteria, that is exercising in your gym, or that is sitting next to you right now could be immunocompromised and can be at high risk of infections. So when we say immunocompromised hosts, really the range of infections that of underlying disease that should be considered is quite broad. That includes solid organ transplant recipients and also bone marrow transplant recipients, liquid malignancies such as leukemia, and solid malignancies as all the breast, colon, lung cancer, for example. All these individuals are receiving exogenous immunosuppression, particularly those with an autoimmune disease, primary immunodeficiencies, and people living with HIV, among many, many others. So with all of that, now the current statistics tells us that about 1 in 50 people globally are immunocompromised. And that is due to either a primary disease or a consequence of immunosuppressive medication. And that sort of lines up with the statistics. They are a little bit more local. In 2021, JAMA did actually a survey trying to ask adults if they were on any immunosuppressive drugs or therapy. Sorry. So to our surprise, about 2.8 of people were actually in some drug-induced immunosuppression. And that lines up with global statistics representing that about 3% of the population is immunocompromised. And as we would expect, the most frequent immunosuppressive drug was oral corticosteroids. So how do I differ immunocompromised individuals from the general patient population? So when we speak about infections, it's really an interaction between how virulent, aggressive, and the nature of the organism that is causing the infection on its own, but also host factors, and it's very different who is the host, and we can have the same pathogen that can affect a host very differently depending on their individual risk. And we learned about that through COVID. When we in COVID, we saw that it was not the same that an elderly individual would catch COVID compared to a healthy young patient, or even a toddler or a small baby. So even the same organism can behave very differently in different hosts. COVID is a good example, and we have very good data of the impact of immunocompromised patients have. Over 40% of those who were hospitalized with breakthrough infections after vaccination were immunocompromised. So also, as we know, the infection fatality in the immunocompromised patients was 50% higher than the general population. And not even considering that, even if how aggressive the disease is now has decreased and there has been a decrease in mortality, patients who are immunocompromised can remain unwell for longer periods of time. Catching COVID can have several implications on them, including decreasing their immunosuppression, risk of rejection, also not able to receive their chemotherapies, have interruptions in their treatment. So even catching an infection without being severe or fatal can have significant implications for them. So some of the principles of of immunocompromise is that recognizing infections in immunocompromised individuals is often more challenging than in those with normal immune function. And that's basically a combination of factors, including that signs and symptoms of infection are frequently less pronounced in this population of patients. So we can have concealed clinical presentations and unexpected atypical symptoms that we don't really see in healthy individuals. We can also have simultaneous or concurrent infections, and then we would expect to find only one organism, and we can have multiple organisms causing infection at the same time. We can also happen that due to the atypical presentation, we can diagnose them like really late in the stage of the infection. We can have an implication in the prognosis, or the opposite. They can also progress really fast, and when we find them, they already have a complication ahead. Also, the management of these patients is quite challenging, because the medications that we use can have adverse events with some of the medications that they are on already. So they can be interactions. Usually we have to do adjustment in their baseline medications. Also, they can have fever all related to infections. Sometimes patients with autoimmune disorders can really have activity of their underlying disease and manifest only as fever. So even the presence of fever does not necessarily mean that they are going through an infection. There's also a well-limited tolerance to established infections, and therefore the patients, if they are debilitated, malnourished, fragile, neutropenic, they are really gonna get sick really quickly. And of course, even though if you do the right thing, use the right drugs, do all the adjustments, find the etiology of the infection, we still have a range where the therapy that we give can be ineffective. And that can be due to all the host factors, that some patients are just so deeply immunocompromised that are not able to really recover from infections. So the first question is, how can I assess the level of immunocompromise of my patient? So unfortunately, there's really not a test or an assay that we can accurately use to measure the risk of infection of our patient. What we do know is that not all immunocompromised patients are the same. And there is a term that we commonly use that is called the net state of immunosuppression. The net state of immunosuppression is a series of factors that when present, they contribute to the appearance of infections. So really, these patients require an individual assessment to understand really the degree of immunocompromise that they have. And all this complex interaction of factors is really what gives us the net state of immunosuppression. That includes the dose, the duration, and the sequence of immunosuppressive drugs that they have used, the previous treatments, including chemotherapy, antibiotics, if they have mucocutaneous integrity, if they have neutropenia or lymphopenia, if they have a primary immunodeficiency to begin with, or an immunodeficiency that goes in hand with their underlying disease. Also, if they have a metabolic disease, like uremia, malnutrition, diabetes, or consumption of alcohol. And we can also have patients that have immunomodulatory viruses that immunosuppress them even more. And whenever we have particularly transplant patients who had a recent episode of rejection, that only reflects that the patient was recently immunosuppressed even more, and therefore they might be more immunocompromised of what he was. So all this combination of factors can really give us an idea of how immunocompromised the patient is. And it makes sense when we have a transplant patient, we don't only have transplanted individuals, we can have a transplanted individual who also had diabetes, who also is malnourished, who also had a rejection episode a month ago. And therefore, all these factors should be taken into consideration. So just to give a few examples, when we say a liver transplant recipient, we can have, for example, a 70-year-old gentleman who had liver cirrhosis for 7 years, probably debilitated and malnourished after that. He had multiple admissions, so he's colonized and even colonized with multiple multi-drug resistant organisms, and also have chronic kidney disease. On the other hand, we can also have a liver transplant recipient who is 19 years old, but was previously healthy and developed acute hepatic failure, so he had to be transplanted. And on the other hand, we can have a 42-year-old who had a bone marrow transplant when he was a kid. And back then he had an invasive fungal infection. And now he's really fresh after transplant and he received that 2 weeks ago. So when we say liver transplant recipients, we can have a wide variety of clinical history and relevant medical conditions. So who is more immunocompromised than who? So I will say that probably this individual will be more immunocompromised than this, and probably this at the end. However, this is quite unpredictable because any of them can develop rejection, can require more immunosuppressive drugs, or can develop a severe infection, and that is unpredictable. So therefore, it's always the degree of immunocompromise is something that is very dynamic and dependable on the current situation and history of the patient. So there are a few molecules that we can do to have a rough idea and measure the net state of immunosuppression. That includes serum immunoglobulins, which can be useful in certain chronic conditions and in certain patients who have history of hypogammaglobulinemia. We can also measure certain complement factors whenever we suspect deficiency. We can also find in the CBC two very, very important keys, which is the total neutrophil count and the total lymphocyte count. Total lymphocyte count is very relevant because in general, the presence of lymphopenia has been associated with the severity of infections. And we know that a host that is lymphopenic in general, they can have a bad prognosis for certain viral infections. And in the case of people who are living with HIV, we can also measure CD4 and CD8 to have a rough idea of how immunocompromised they are. So also depending on the type of immunodeficiency is going to be the abnormalities that we're going to see and therefore the infectious consequences. So for patients who have a B cell deficiency, we know that most likely they're going to have absent or reduced follicles on germinal centers of lymphoid organs, and that is going to translate into reduced levels of serum levels of immunoglobulins, again, causing hypogammaglobulinemia and decreasing the humoral response. And therefore, these patients in general, they are in risk of bacterial infections, enteric bacterial, and some viral infections. On the other hand, T cell deficiency is going to manifest as really an effective T cell response and proliferation of certain cells, and therefore more commonly patients who have a T cell deficiency, they're going to have viral or fungal infections like Pneumocystis jirovecii, certain bacteria, fungi, and other viruses like CMV and EBV. So B cell deficiency is more associated to bacteria, T cell more to fungi and virus. The reality is that many of our patients have a B cell and T cell deficiency simultaneously. And finally, those who have innate immune deficiency is really variable depending on what they have, but it's common to see a combination of both, either having pyogenic bacterial infections or recurrent herpes, for example, as viral infections. And they're very common to have respiratory infections, sinusitis, UTIs, all sort of infections. So the second question is, how can I assess the risk of infection in my immunocompromised patient? So this is very relevant because in order to understand our patient and try to predict what type of infections they can have and how can we manage them, we have to look back. We have to look back into their history and trying to see what they were exposed before, the medical conditions that they have, so we can really move forward. And by that, I mean that by looking at the past, we should ask them where were they born, where they have lived for prolonged periods of time or short periods of time, their travel history, if they have gone to endemic areas where we can find endemic mycosis or exposure to mosquitoes, for example. What exactly do they do? It's not the same if they work as a teacher in a kindergarten, if they working as a guard in prison. So the job and the exposure that they have every day is very, very important. Also, the history of previous infections. Many of these patients have been sick for quite a while, and they have chronic diseases that have exposed them to infections before. So really, whenever we are assessing them, the first question that we should ask ourselves is this a recurrence of the same issue that he has had? What type of infections did he had in the past? Did he had infections due to multi-drug resistant organisms? Were they malnourished? Were they consuming alcohol or drugs, for example? We should also look into the vaccination status, and because certain diseases can put them on risk of invasive infections if they're not properly vaccinated. So that's something that we should always look for. Also, some of these patients, because we know the risk that they have, they can be on prophylaxis, either antifungals, antimicrobials, or antivirals, and therefore try to review the prophylaxis that they are receiving and try to assess the likelihood of that they could have a breakthrough infection even while they are on prophylaxis, or the opposite, realizing that they are in a high risk of certain infection and that they were not receiving prophylaxis, and therefore it's more clear what their current risk is. Also, it's very important to ask them about the recent history of immunosuppression. What is the current status? When did they receive chemo? If there have been any significant changes in their doses, if they have introduced a recent medication, or the opposite, if they haven't been able to take their drugs, if they haven't been able to receive their chemo. So really understanding the recent immunosuppression is very important. Also, it's very common to see in infectious etiologies that a lot of people, like around the immunocompromised patient, can be sick too. So always ask them if there's somebody sick at home, exactly what do they do, who do they talk to, if they were exposed to a lot of individuals, if anybody was sick or got sick by eating the same things, and also the environment. If their house is going through renovations, if they have been exposed to dust recently. So all of this, trying to understand the patient, what does he do, how exactly does he live, is really important. Also, for the management of certain infections, we need to know the serologies that the patient had, meaning what have they been exposed to before and what is the risk of reactivating new infections. So with all of this, really taking a look into the past medical history of the patient, we can move forward and really assess and understand what is the status of his underlying disease. Is he scheduled to receive chemo? Does he still need to be immunosuppressed? Does he have an active malignancy that hasn't received any treatment and can contribute to a bad prognosis of an infection? We should also ask work as a team and ask some of the other doctors caring for that patient, what is the future of his immunosuppression? Are we going to be able to delay the chemo or decrease the immunosuppressive drugs, and try to understand what exactly it has to go hand to hand with the management of the infection so the patient can be adequately treated. Also, it's gonna help us to establish new strategies for future prophylaxis and vaccination strategies if they haven't been vaccinated, and knowing what has to be updated. Also, it's gonna give us a rough idea of what antibiotics we can use empirically to begin with, so we can cover in a safe manner all the previous organisms that the patient has had. And also is gonna allow us to know which test we should send to begin with. And that is very important because due to the big range of infections that they can have and the simultaneous infection that they can experience, it's very important to know which test has to be sent and really have microbiology support through the diagnosis of these diseases. So just to speak briefly about some of the most relevant immunocompromised conditions, in many of these diseases, we can actually predict and we can actually understand what type of infections they can present. In the case of solid organ transplant recipients, meaning kidney, liver, lung, heart transplant individuals, There is a timeline for infectious complications post-transplant that was described by Dr. Fishman a few years ago. And basically, right after the individual had a solid organ transplant, the first month after the transplant, what we're going to see are really nosocomial infections and infections that are related to the surgery. So in the case of kidney transplant, for example, it's common to see urinary tract infections. In the case of liver transplant, it's common to see wound infections, surgical wound infections, bacteremias, also intra-abdominal abscesses. We can see line-related infections and all these type of infections that are related really to a surgical procedure and being in the hospital for a prolonged period of time. During this time, we can also see donor-derived infections, meaning that the donor that donated their organ could have a latent infection or an active infection while they donated the organ, and therefore that infection can be passed or acquired by the organ recipient. Therefore, we should also, again, we should anticipate to what were the risks, what if the donor had any infection that was described before, and really remain vigilant of any donor-derived infection. Then in the second period, which is a month to 6 months post-transplant, really what we're going to see is opportunistic infections and reactivations of latent infections that the organ recipient had. So for example, if they were exposed to TB, if we don't give any preventive therapy for latent TB, it's more likely to reactivate in the first 6 months post-transplant. If they have, for example, recurrent herpes infection before, most likely is going to come back. We can also see certain opportunistic infections such as PJP, for example, in patients who had hepatitis B or hepatitis C. This is a period where they can replicate the virus again and have viremia due to these viruses. They can also have certain opportunistic and very individual infections due to the immunocompromised history. For example, BK infection, CMV, EBV. So we see a lot of reactivation during this period. And finally, after 6 months post-transplant, really what we see is that the period of deepest immunocompromise in general has passed, not for all the patients, but for most of them. And therefore, after 6 months post-transplant, generally what we see is community-acquired infections. So we can see pneumonia, we can see certain fungal infections, and also we are still dealing with the reactivation of certain infections such as CMV, HSV, EBV, and some others. So really, when we have a transplant patient, the first question that we should ask ourselves is, where is my patient after the transplant? In which stages is, so we can anticipate to what type of infections they can present. In the case of stem cell transplant, the bone marrow transplant, the timeline is different. During the day 0 to day plus 30, which is called the pre-engraftment, as you can see, what we're going to see is individuals who are neutropenic, who are likely to have barrier breakdown, who are going to have also T cell and B cell deficiency, and possibly functional asplenia. So if you see in this first period, what are we going to see? Mainly bacterial infections due to gram-negative and gram-positive during this period of deep neutropenia. We can also see the beginning of certain invasive fungal infections such as Candida and Aspergillus, and we can also see reactivation of certain viruses, particularly herpes simplex, which is a risk that is present for the first 100 days post bone marrow transplant. Then when we move into the intermediate period, who is the post-engraftment period, that means day plus 30 to plus 100, these patients still have a T cell and B cell deficiency. They can start having acute GVHD. That means that because they develop graft versus host disease, they have to be immunosuppressed even more. So as you can see, the critical time of neutropenia has passed. Therefore, the likelihood of having a bacterial infection decreases. we see a little bit more of a risk of fungal infection depending on how immunocompromised they are during this period. And again, we start seeing multiple viruses. We can start seeing CMV, HHV6, respiratory viruses, enteric viruses, and EBV2. And finally, in the late phase, which is more than 100 days post-transplant, these patients are still in their way to reconstitute their immune system, so they can still have B cell and T cell deficiency. They can still have chronic GVHD, and meaning chronic immunosuppression, and they can still have functional asplenia. During this late period, we can also see again certain bacterial infection. Again, there is a risk of pneumocystis jirovecii here. And really in the late period, what predominates is viral infections, meaning herpes simplex, CMV, varicella zoster, PTLD due to Epstein-Barr, and some others. So really by understanding and knowing what to expect, we can also anticipate to which prophylaxis they should receive and where is the right time to start them and the duration that they must have. In the case of people who are living with HIV, probably the most important guide that we have is the CD4 count. And even though it's really useful, it's not absolute, but it's quite useful to understand the degree of immunosuppression that the patient can have. And the principle is really that as the CD4 count decreases, the risk of opportunistic infection and complex infection increases, and also the likelihood of having complications due to the treatment and having more severe clinical pictures. So in people who are living with HIV who have around 500 CD4s or even a little bit less than that, we can start seeing TB. It's very important for people who are living with HIV really do TB screening. Is that one of the most common infections causes of death in people who are living HIV worldwide. So we should think about TB at all times, regardless of the CD4 count. Also, we can see oropharyngeal candidiasis, salmonellosis is quite common, primary salmonella in blood, reactivation of zoster, reactivation of herpes simplex. And as the CD4 count decrease, when we reach less than 200, we can see the risk of pneumocystis jirovecii pneumonia, also herpes simplex again, and zoster, and some other organisms causing chronic or subacute diarrhea, such as Isospora and Cryptosporidium. Less than 100 CD4 count is really the patients that are deeply immunocompromised. During this period, we can see toxoplasma, cryptococcal meningitis, progressive multifocal leukoencephalopathy, and CMV, the infection or disease. So these patients are deeply immunocompromised, and it's going to take them a while, even if we start them on therapy, to recover the CD4 count and really reconstitute. And even for patients who have less than 50 CD4 counts, we can see reactivation of CMV. We can see Mycobacterium avium complex infection, a very severe infection that we can see in these individuals, and again, toxoplasma. And of course, by the time that they are less than 50 CD4 counts, we can really see any of the above, plus the ones that are in that group. Another patient group or population of patients that is quite predictable is patients who have asplenia. So patients that we know had either a splenectomy or functional asplenia, they are in risk of certain infections that we should know so we can prevent them. So typically for bacteria, they are in risk of encapsulated bacteria, which includes strep pneumonia, Haemophilus influenzae, and Neisseria meningitidis. And these three organisms have very good vaccines. So we should be aware of this risk and really vaccinate these individuals. They also have the risk of more severe Capnocytophagus species invasive infections and Bordetella infections. And regarding parasites, there has also been described a high risk of malaria and babesia. A very interesting autoimmune disease is actually lupus. So lupus is really an autoimmune disorder, and infections in lupus patients can vary widely, including opportunistic and really common infections just with the typical presentations. We know in different cohorts that the patients who have lupus have a risk of infections, an overall risk between 10 to 25%. And there are a few risk factors that are specific for lupus for developing an infection. And that those include high disease activity, which is expected. If you have a disease activity, most likely you're going to be immunosuppressed, and therefore that can increase your risk of infections. Also, a specific immune dysregulation that they have. They can have drug-induced immunodeficiency, and they can even have, on top of that, organ failure. They can have chronic kidney disease, or they can have some other failure. Also, it's quite challenging to diagnose active infections in patients with lupus. If you think about a patient with lupus having fever, lymphadenopathy, unexplained confusion, pulmonary infiltrates, skin or mucosal injuries, and even coagulation disorders, both of these symptoms and all of them can be due either to an infection or to activity of the disease. So it's really difficult sometimes to understand the overlap that all these symptoms can be due to both causes, infectious and non-infectious. And in patients that have lupus, the impact of this invasive infections is quite severe, as we can see in different cohorts that have been published about infections in patients who are living with lupus. We can see that the percentage of diseases due to infections is significant. It can range between 5%, but as you can see, most of the cohorts are above 25% of that related to infections. So the implications of infections in this group of patients is very significant. And what is their individual risk? Well, they have different immunodeficiencies in different points of their immune system. So in the innate immunity, they can have reduced IL-8 production by neutrophils. They can have reduced TNF production. They can have reduced complement and functional asthenia. In cellular immunity, which is going to help us defend from infections, they can be lymphopenic, or they can have a normal lymphocyte count but T cell dysfunction too. They have also a reduced number of function and natural killer, which are very relevant for particularly for fungal infections. And they also can have hypogammaglobulinemia in humoral immunity, and then have a decreased production of immunoglobulins. And that is relevant because, for example, if we vaccinate these patients and they have a decrease in their humoral immunity, they might not seroconvert, or they might not develop an antibody response after being vaccinated. And what are the infections that can affect this population of patients? It varies, but they're mainly bacterial infections. And more commonly, Streptococcus pneumonia is quite common in lupus. It's actually one entity that can be quite aggressive in them. They don't only present pneumonia or meningitis, but they present invasive pneumococcal infections. And if we speak about a prevalence of invasive pneumococcal infections of 15.6 for 100,000 people in the population, patients who are living with lupus have a rate of 201 per 100,000. So it's a significant risk, and therefore these patients should be vaccinated, and we should keep it in the back of our mind as a risk factor and describe infection in this population of patients. And also salmonella. Primary salmonella, invasive salmonellosis, and certain complications is quite common also in patients with lupus. We should expect also viral infections such as herpes zoster, herpes simplex. Sometimes, and depending on the immunosuppressive drug that they are receiving, they can also have reactivation of CMV. Also, human papillomavirus, which is these patients that are immunocompromised, they don't only have the risk of having chronic or severe infections, but also certain malignancies, particularly those malignancies that are linked to human papillomavirus. So if possible, they should be vaccinated too. And lastly, fungal infections, predominantly Candida, either as invasive or non-invasive forms, and also Pneumocystis jirovecii, depending on the immunosuppressive regimen that they have. So moving on to rheumatoid arthritis. So rheumatoid arthritis has a relative risk well described of infections compared to a matched cohort of patients of 1.7. So they have a high risk of developing infections, and they also have an increased overall mortality compared to immunocompetent individuals. And why is that? It's really due to multifactorial immunosuppression that includes the dysregulation that they normally have of neutrophil activation, also T cell repertoire contraction that they have, and reduced T cell proliferative capacity. On top of that, we know that rheumatoid arthritis patients can also have other comorbidities. They can have COPD, they can have diabetes, chronic kidney disease. So on top of that, they have other factors that put them on risk of invasive infections. And the treatment, as we know, is extremely good nowadays. However, they come with a cost of increasing the risk of infectious complications. And some of the drugs that are commonly used in rheumatoid arthritis is disease-modifying antirheumatic drugs, also certain biologics, and sometimes some steroids too. And there's also not only systemic immunosuppression, but it has been described also that they have a local degree of immunosuppression in the synovial, causing inflammation and infiltrations of certain cells. So what type of infections do rheumatoid arthritis patients have? Particularly and more frequently, musculoskeletal infections. So we see myositis, cellulitis, septic arthritis, or osteomyelitis. This is a very useful predictive infection score that has been described and include multiple variables that the patients could potentially have and see if they have an infection or not. That includes previous infections, also if they have had extra-articular manifestations of RA, ESR, use of steroids, and some other comorbidities. This score can be useful for clinical use, and also these patients have a high risk of mycobacterial infections in chronic presentations. And then just describing and talking very superficial about certain drugs, we have nowadays a group of immunosuppressive drugs that are called TNF inhibitors that includes adalimumab, etanercept, which is used frequently for rheumatoid arthritis. We also have infliximab that is commonly used for Crohn's disease. And really TNF inhibitors, we should think about reactivation of TB when we think about those drugs. So these patients, they have to be screened for TB before they start any of these drugs. Most of the TB that they present, around half of the cases, is extrapulmonary disease. So that comes with significant implications. Multiple drugs, multiple interactions with other drugs, probably having to stop their immunosuppressive drugs for a while. And cases of extrapulmonary TB and disseminated TB have to be treated for many, many months. So if we know that people who are on TNF inhibitors have the risk of reactivation of TB, we should be aggressive in all the preventive measures that we can do to identify which of these patients are either in risk of acquiring TB in their daily life or who have been exposed and could reactivate in the future. They also have a moderate risk for bacterial infections. Legionella has been described in patients who are receiving TNF inhibitors. Also, zoster, although is controversial with information that is contradictive, and certain opportunistic infections, but they are still rare. We also have another drug that is called eculizumab, which is an anti-C5, which is a complement protein that plays a key role in the immune system response. In these patients that are receiving eculizumab, they can receive it for many, many indications, but basically they have a risk of Neisseria meningitidis. They can either present bacteremias or meningitis. So this described risk also makes us think that before they receive eculizumab, they should really be vaccinated against meningococcus with the vaccine A and B 2 weeks before they receive eculizumab, and then every 3 years. And also, again, we have to ask them, what do you do? Is he a college student? Does he work in the military? So they, even though they are vaccinated, they can understand the risk that they have and the possibility of being in contact with Neisseria meningitidis. And of course, in any patient that is receiving eculizumab and comes in with fever or neurological symptoms or purpura, we should definitely have a high suspicion of invasive meningococcal infection. So moving to the last part of the presentation, what can I do to protect my immunocompromised patient from infections? What are the interventions that have been useful in this population of patients? So I will summarize it as three. The first one is strategies for safe living. So trying to just tell them what are the risks and what they do, understanding our patient, who is he, what does he do in his daily life, and giving them some guidance can have very, very important impact in their daily life. Patient education has been associated in immunocompromised individuals to either less hospitalization, less death due to infectious complications, and really have a very link and with our patients. Patients who understand their disease are patients that have been empowered and therefore that they trust in their healthcare providers too. Also, before a few years ago, all these immunocompromised patients have a really high mortality due to infections. That has decreased over time, basically due to two things. One, antimicrobial prophylaxis. As you know, knowing and understanding the infectious complications allow us to anticipate to them and really give them all the support that they need. And the second intervention is vaccination. So these three interventions can have a significant impact in protecting our patients. So talking about strategies for safe living, first of all, before they are immunosuppressed, there's a few things that we should do with our patients. The first one is they should have a dentist appointment. It's very, very unfortunate to see patients that are deeply immunocompromised and have poor dentition. So if we know that they're going to receive or they're going to start receiving chemo or any immunosuppressive drug, if possible, they should try to go to the dentist. Also, we should screen them for MRSA colonization, and not only knowing that they are MRSA colonized, but actively doing decolonization. And in certain scenarios, it is recommended to screen them every 6 months. So be on top of that too. We should also do certain screening, including STBBI, again, looking for hepatitis B, hepatitis C that can reactivate really quickly on immunosuppressive drugs. Screen them for TB, either doing a TST or a NIGRA. And also depending on our patient, if he has traveled to Arizona, we will screen them for coccidioides, for example. If they have traveled to Kenora or even northern Manitoba, we would screen them for blastomyces. If they were born outside of Canada in certain endemic regions, or that they were commonly barefoot, we should screen them for strongyloides serology. So really assess their individual risk and trying to predict what they could have been exposed in the past. And finally, update their vaccination scheme before they are immunosuppressed. So once they are immunosuppressed, we should remember that most common infections are acquired through direct contact. So reminding them that they should wash their hands with soap and water, hygienic hand glove or sanitizer is an acceptable alternative. We should really tell them that if they have contact with soil, moss, grass, or do some type of gardening, first of all, patients who are deeply immunocompromised, they should be discouraged to do that during the period of deep immunosuppression. But as things settle down, they should wear a mask, they should wear gloves, and they should wash their hands even after removing the gloves. Also, we should tell them to avoid going outside barefoot since they can have contact with certain parasites. They should wash their hands before they prepare food and before eating. Also, after touching and after cleaning up animals and pets. Also, after gardening, touching plants or soil. After changing diapers, and if they have a baby that is sick with a gastrointestinal infection, it's recommended that somebody else does the diaper changes and cleaning and not the immunocompromised host if possible. Also, after touching secretions, blowing their nose, coughing, they should wash their hands too. And after touching items that have contact with human or animal feces, such as bedpans, toilets, litter boxes, and some others. To prevent respiratory infections, we should try to tell them to avoid having contact with any other people who are having respiratory illness, or if it's, sometimes it's possible to avoid it, they should both wear masks, the individual that is sick and our immunocompromised patient. And now in the current era, try to avoid public areas continuously is really not a realistic recommendation. They should exercise caution, especially if they get more immunosuppressed or if we are in a season where we have more viruses circulating. They should also avoid tobacco smoke, which increases the risk of any respiratory infection. Try to avoid marijuana smoking. And this is really because marijuana can have aspergillus, can have gram-negative bacteria, such as salmonella, for example. It can be colonized with multi-drug resistant organisms. Therefore, if they're gonna consume marijuana products, they should do eatables, but not really smoking it, because invasive fungal infections have been associated with marijuana use. Also, try to avoid active contact with active TB cases, and that includes really high risk exposure activities. Again, people who work in shelters, who work in prisons, who are healthcare workers, they should be very aware that they can acquire TB if they work in those high risk activities. And then, if possible, avoid occupational risks such as animal care, construction that can also put them in risk of inhaling conidias and different fungi, including mucor, rhizopus, aspergillus, and some others. Try to avoid working in gardening, landscaping, and farming. And if they have to work in any of them, again, we have to go through them all the precautions that they should do. I'll try to avoid dusty construction sites and also areas with high mold spore concentrations. So if they are going through demolitions or if they're doing big renovations, knowing that immunocompromised patients can inhale spores and develop a fungal infection. And also try to avoid bird droppings, chicken coops, caves, like any of those that can put them in risk of endemic mycosis. Water safety is very important. They should not drink water directly from lakes or from rivers. They can acquire Giardia or Cryptosporidium, for example. They should also be careful about swallowing water from recreational activities such as swimming, natural waters, hotel or motel pools, or theme park water rides. So they should be careful with those during the periods of deep immunosuppression. Also, we should know that hot tubs can put at risk of folliculitis, particularly due to Pseudomonas, also Legionella and Mycobacteria, non-tuberculous Mycobacteria infections. So they should be careful with those. And if they go into the water to swim, they should always clean any abrasion, cut, or any type of open wound that they have in their skin after having contact with the ocean or fresh water. Any open wound can be the entrance site for Vibrio vulnificus, particularly in patients who are living with cirrhosis, Mycobacterium marinum, and Aeromonas. And very important, food safety. They should be careful with unpasteurized milk, either for enterobacteria, including Salmonella, but also in Listeria, but also due to Mycobacterium bovis and other forms of Mycobacteria infection. They should try to avoid cheeses with unpasteurized milk again, avoid raw and uncooked eggs for the risk of Salmonella, avoid eating raw and uncooked either meat for risk of E. coli, poultry, and fish, particularly fish. They should be really, really careful, not only with bacteria, but also they can acquire tapeworms and toxoplasma. So try to avoid raw food. Also try avoiding any food that is prepared by someone that has a recent diarrheal illness, as they can pass the infection to our immunocompromised patients. And regarding pet ownership, a lot of our immunocompromised patients have questions about this. The only recommendation is that while they are in a period of deep immunosuppression, they should avoid cleaning bird cages, bird feeders, litter boxes, and even handling animal feces. They should avoid animal bites, scratches, and not really pet stray animals. Make sure that the areas near the home are free of raccoon latrines, and wear gloves always to clean aquarium. And depending on what type of pet our immunocompromised patient wants, it comes always with a risk that we should be aware of. For example, reptiles and amphibians, they have a high risk of salmonella, such as certain cats, young cats, and ducks, and some other chicks, kittens, and some others. Also, rodents can transmit either parasites, bacterial infections such as rickettsia, and also certain viruses like hantavirus and lymphocytic choriomeningitis virus. So just take this into consideration. Finally, we should also tell them about the risk of mosquito-borne infections, particularly here during the summer. We are in an area with a high incidence of West Nile virus. So they should try to avoid, even when they're traveling to endemic areas of dengue, chikungunya, Zika virus, avoid going out at dawn or dusk, and always try to use insect repellents such as DET. Also try to avoid wearing very colorful clothes. Use long sleeve shirts and pants. Try to spray their clothes with permectin directly into all the gear and clothing, a backpack, and camping stuff. And also in certain cases, if they're gonna travel to areas where they have active malaria, we should recommend specific prophylaxis. So all these recommendations about safe living, we really want our immunocompromised patients to thrive. It's not about prohibition. It's not about telling them everything that they can do. It's really about explaining them and calculate their life and calculate the risk that they can be exposed to. So it's not about denying or prohibiting activities, because we know that inevitably there's risk of infections, they are present, and they're going to keep expanding as we allow them to do more activities. So the key is really detailed patient education to prevent and reduce some of this risk, not really asking them not to do certain things. We also, the second point was antimicrobial prophylaxis. Particularly, we're worried about Pneumocystis jirovecii pneumonia, which it has been described that has a mortality up to 30% in patients that are non-HIV patients. And it's a subacute pneumonia that presents a dyspnea, hypoxemia, and be quite aggressive in certain immunocompromised patients. And it can present as ground glass with changes that they're quite discreet and they're not very impressive to begin with. So to prevent Pneumocystis jirovecii, there are certain recommendations of who should be on prophylaxis. Of course, it's really an individualized decision. However, certain recommendations are focused on patients who have primary immunodeficiencies, not all of them, only some of them. Patients who are going through the diagnosis of acute lymphocytic leukemia, solid organ transplant recipients, they should receive it for at least 6 months. Some of centers do it lifelong, depending on the incidence that they have of Pneumocystis jirovecii. Also, allogeneic stem cell transplant should receive it during the engraftment and continuing as long as they are receiving immunosuppressive drugs. Certain patients with autologous stem cell transplant, not all of them. And probably the most important indication is being exposed to or receiving corticosteroids that are equivalent to more than 20 milligrams of prednisone for at least 1 month, and that they also have an immunocompromised state. For example, that they have lupus and they're receiving 20 milligrams of prednisone for more than 4 weeks, they should be on prophylaxis. So that is a common indication of Pneumocystis jirovecii prophylaxis. Regarding antiviral prophylaxis, again, we can use acyclovir or valacyclovir, and it's really, again, an individualized decision. We should consider the degree of immunosuppression that that patient is going to have and which drugs he's going to receive. If they have had previous history of HSV or BCV, is a patient that has recurrent herpes infections to begin with, they should be on prophylaxis while they are immunosuppressed. And also to have some guidance, we can also do serologies to see if they have been exposed to herpes simplex. And if they have, then that will give a little bit more gravity to the decision of whether they should be prophylaxed or not. And finally, a very common question that I receive is who should be vaccinated? So to make it simple, immunocompromised individuals should not receive any vaccine that is live attenuated. So that includes the live attenuated varicella vaccine, MMR, also BCG, smallpox, There's a oral Salmonella typhi vaccine that is live attenuated. They cannot receive that. There's also a cholera vaccine that is also live attenuated, anthrax vaccine, and yellow fever. So many of our immunocompromised patients that want to travel, they should have a waiver letter that they can be really vaccinated for yellow fever. Then the vaccines that they can receive and they should receive are inactivated vaccines. That includes the adult inactivated influenza vaccine. Particularly for immunocompromised patients, we use the high dose influenza vaccine. Also hepatitis A, hepatitis B, any type of tetanus vaccine, such as DTaP, Tdap, or TB. Inactivated polio they can receive, H influenza, and the different vaccines for strep pneumonia, including conjugate or polysaccharide. Meningococcal vaccine, they can receive rabies. Papillomavirus, they should be vaccinated again, since there's a link between immunocompromise and malignancies due to HPV. And also, they can receive the inactivated subunit varicella vaccine. The name is Shingrix. And also the COVID-19 vaccine and the RSV vaccine that we have now available is inactivated too, and they should receive it. So the conclusion is that the spectrum of immune deficiencies is difficult to quantify. We should focus on the prevention of infections in immunocompromised individuals. Patient education can really lead to better health outcomes with lower readmission dates and patient empowerment. And remember that the population of immunocompromised patients is only going to continue to increase over the years. So thank you very much, and thank you to all the organizers for the kind invitation.
Thank you, Armel. Outstanding presentation, and it answered innumerable questions that we all have. We have a number of questions on Slido, but I've got a couple of crazy questions for you, and one of them is a philosophical question. On one of the slides, you had screening before a person becomes immunocompromised, screening for nasal carriage of MRSA. The question for you, and it's a philosophical question, if we're going to screen for MRSA, we should really be screening for all staph aureus, both methicillin susceptible and resistant. Our problem locally is that we have a high prevalence of MRSA colonization. The other question for you, what happens if you're unsuccessful in decolonizing the patient and the toxicity of the medications that are given for decolonization? Are we going to withhold someone's biologic therapy because we couldn't get them decolonized? I'm not sure about the nature of that recommendation. Any thoughts?
Yeah, so that's an excellent point. To be honest, there is not that I'm aware of any information publishing in immunocompromised individuals in the benefit of screening for MSSA. However, I agree with you. I guess that the nature of the bacteria, either MSSA or MRSA, behave very similarly, like clinically. So it is a very good question that unfortunately hasn't really been answered. If we should, screen for MSSA and MRSA, I think it has it makes sense. I'm just not sure that has been done in the past and should be useful. So MRSA decolonization is relevant, but it's not relevant for all our immunocompromised patients, right? They don't have the same risk of MRSA disseminated infection. So, for example, somebody who has a permanent line, a port cath, a catheter, I will be more aggressive in trying to decolonize them. Initially, the protocol is with mupirocin, local mupirocin, and also using gel and soap of chlorhexidine. In certain patients, where there is a good percentage, particularly in those who have primary immunodeficiencies, even you decolonize and they get colonized again, sometimes you can use a single dose of trimethoprim sulfamethoxazole. And I will be very aggressive in trying to decolonize them in those patients who have had recurrent MRSA or MSSA infections, like atypical dermatitis, for example, or have, again, primary immunodeficiencies. I would also be very aggressive in patients who are on dialysis and have a constant line. They have contact with an external system, and they have a line in place. And for the others, I probably wouldn't be as aggressive depending on what they are receiving.
Thank you, Armel. A crazy question for you. What about hot tubs? Are communal hot tubs more dangerous than home hot tubs? Or is the hot tub just a place that immunocompromised hosts should avoid?
Yeah, like I think that public hot tubs is definitely a high risk, not only for Pseudomonas mycobacterial, but also for acquiring even some viruses. Since, as we know, public hot tubs could have the risk of also having some materials for other humans, like feces, urine, and some others. So definitely, the recommendation would do only private and in their own house of hot tubs. And it also is related to maintenance, right? Like if they clean up the hot tub really well and they keep it in good shape, it's safe to do it. But the problem is that they have to be diligent, right? Keeping it clean, keeping the water chlorated, and use it only private hot tubs.
Thank you, Ramel. Outstanding presentation. Anyone who has any questions, feel free to forward them to, you can send them to me, I can forward them to Armel. So we're going to shift gears. Thank you, Armel. Look
Thank
forward
you.
to seeing you at Bug Day again. So we're now going to shift gears and move to Dr. Barry LaValle. Barry is a member of the Manitoba medical community that has been, and I don't mean this out of disrespect, has been around forever. Barry's seen it all, done it all, and now he's the Chief Executive Officer of, and I apologize because I'm likely going to butcher this, Him-Ino-Wayin, which is an organization focusing on restructuring of healthcare and delivery of healthcare for Indigenous persons in Manitoba. One of the priorities of this organization is harm reduction, and it's something about which Barry is very passionate. Barry, over to you.
Can you hear me?
Hi, yes, we can.
Okay, great. Good morning, everybody. And thank you for this opportunity to share a little bit of information. My name is Barry LaValle. I'm the Chief Executive Officer for Kiiwetinoka-Innumenor-Yawin, which is a Cree phrase that means Northern People's Wellness. This organization, which is incorporated, really started in about 1870, 1875, 1880, all through today, and reflects the aspirations of Northern Cree, and in this case for about 23 sovereign communities in Northern Manitoba, to aspire to taking control of mostly federally funded programs in community. And really the intention of Kiiwetinoka-Innumenor-Yawin is to transform healthcare systems, not take on current approaches, but really to assume control over the federal government in Manitoba for Northern Manitoba. There's another organization called Southern Chiefs Organizations that's doing similar work for about 30 plus First Nations communities in Southern Manitoba. During the pandemic, of course, we stepped on board to give Brent and all of their systems a bit of a hand to articulate needs for First Nations and communities, as well as those living outside of the communities. And so we're about 2 years behind, like most people. And so at this point in time, what we're doing is we're looking at to embark sooner than later on legal transfers of authority about First Nations healthcare systems. We do fairly extensive work with the province of Manitoba as well, looking at different innovations. So what I'm going to speak to you for a few minutes today really is kind of the response, partly with the stress of the pandemic, but really what I'm going to share with you is that prior to the pandemic, most of us knew, all of us, including our medical community, et cetera, and social services community, that the link between poverty, colonization, and coping, using either drugs or alcohol was an ongoing issue. And the communities over the 30 years or so had engaged in many different kind of endeavors to try and support people to live in a bit of a healthier way. The pandemic amplified this process, and we saw quite devastating results in a number of communities during the pandemic and post-pandemic in terms of loss of lives and community disintegration and a great deal of stress on our chief and councils and our other leaders trying to engage in harm reduction activities and addictions activities to support members. And with the varying drugs that are used, including crystal meth, it was very problematic because most communities have a deficit of supports. During the pandemic, we engaged with the provincial government to get monies for us to use harm reduction methods and do an educational kind of platform with our communities and try and convince people that maybe using a bit of alcohol or using alternatives to medications for drugs was actually a reasonable thing to allow people who are quite active to have a quieter life and a more predictable life. And so we worked also with the province, which had a real deficit and lack of resources in northern Manitoba and really none in First Nations communities, and to try and orchestrate kind of a team-based approach to say we need resources and all of those kinds of things. So I'm just going to talk with you a few minutes about some innovations that occurred in response to the crisis, to the chronic crisis, I might add. So we established a managed alcohol program in one of our northern communities because the young men, especially testing positive for COVID, had no memory. And the only thing we could think about doing is putting maybe metaphorically a dome over the community and taking people out in a severe respiratory disease and exiting them down to Winnipeg. But what we did was we established a managed alcohol program within 10 days and using a 20% sherry wine as a BID dosing, depending on how it would be calculated. And we stabilized up to 25 people who were the most at risk with chronic alcohol use. 3 died from liver disease, and that was from previous damage done from the damaging the liver from the years before, and they were in their 30s. But importantly to understand is that when people are actually on a managed alcohol program, 50% of the people, now you got to look at the stat, okay, 50% of the participants went back to work on a BID dosing of 20% sherry wine. Now I'm talking about dads taking care of their kids. I'm talking about counselors, security guards. And so the people who were actually banging on the door of the nursing station, 2, 3, 4 in the morning, looking for care, were the ones now being security guards and screening people and sorting people out. And in my mind, in the community's mind, and we did make a film documenting that was quite a success. And currently, we have about 2 communities in the north that we've established people on opiate agonist therapy. in conjunction with some partnerships, but we initiated that. And so we have about 120 to up to 120 people in two smaller communities on opiate agonist therapy. And you have to imagine when you apply those theories or those applications, people's lives become perceptibly quieter and more predictable. So you have less engagement, one would imagine, with child family services. Kids get to school, kids are eating, kids are safer, people are safer. And people, we found in that particular group, started going for their diabetes checks, pap smears. They're going back to the primary care system before it disintegrated, really. And so we're starting to take care of themselves. But one of the innovations that we looked at was really the use of kiosks. So it's a new technology relatively. I think there's some activity in Philadelphia as well as Vancouver, for those of you who know that. We're going to be looking at using different kiosks here in Winnipeg for actually prescribing Dilaudid to a group of people who can't use opiate agonist therapy and are high risk of dying. But that's an ongoing project. But the kiosks, we have 8 kiosks, and that was in partnership with Dispension Inc. from Eastern Manitoba, and then we got about $500,000, or they did, from Indigenous Services Canada to develop these kiosks. There's two kinds. There's ones that can deliver medications or harm reduction supplies using a Palmer reading. And there's a process to use this with community. And the other one has more of they look like kind of boxes that you gain access to, and you can actually put alcohol in there. You could put all kinds of things, but really the kiosk is really for having people be more independent and taking care of the medications. Indeed, we can use these kiosks for people who are diabetic or require, short-term medications. The partnership for the use of the kiosks certainly is our communities, our community leaders, as well as a pharmacy and a prescriber. And most of the time, what you're looking at with the kiosks, and they're still very, very preliminary, is community supports, really called land-based activities. And these are kind of mostly young people who do support within the community. They provide services, psychological support to people who are having a challenge using alcohol or any other drug. And so we've been establishing, communities have been establishing that for a while now. One of the strengths of the kiosk use, and we have a couple here in Winnipeg, if you look on Logan Avenue at the toilets there, where we do some activities, we have 2 kiosks in there. And we have a kiosk in southern Manitoba, in Churchill, and different areas. It was very difficult, or primarily what we wanted to do was to get these into our communities, but you need Wi-Fi and those kinds of technology. So that was certainly a limit. How much time do I have, John?
15 minutes. So you've got 3 minutes left, Barry.
All right. So the kiosks at this point in time, I can't say they're successful, because the difficulty in putting the kiosks to task is organizing them, is getting Wi-Fi, is ensuring that the governance systems like the City of Winnipeg, our tribal councils, will actually adopt them in processes. So they're going to be successful. They'll be for 1 year. We have about 6 months left, and we're going to do a formative evaluation. But I'm going to tell you that on one of our sites, Nidinamac, and that's in downtown Winnipeg, people who live on a street are really shy to share their information, even a Palmer reading. So we spend a lot of time supporting people who are quite scared to think that the government is taking information. So there are some challenges, but the important thing is to understand about how Indigenous harm reduction works is that it's community engagement, it's relationally based activities. And so there are different sites around here. And another time, what I'll do is I'll give you, maybe in 6 months or so, I'll give you an update on kind of what the evaluation has shown. Now, just one quickly, the other thing is really looking at when people are actually supported in harm reduction, especially for Indigenous people, recognizing that colonization is at the root cause, land-based activities really have to fill up a person's heart, if you imagine, for about 50, maybe 60, 70, 80%. Just taking somebody off of medication just doesn't cut it. And so we're doing lots of activities around the north, and communities are doing independent activities to keep their community members in the community, and for us to start the support at that level rather than sending people out of the community down to Winnipeg, where it's not really been successful. Thank you very much.
Barry, thank you. Don't go away. We'll have 2 more speakers, and then we'll have 15 minutes of questions and answers that will address all of the 3 topics in this session. The next presenter is Dr. Patricia Garcia, who is a professor at the School of Public Health at Cayetano Heredia University in Lima, Peru. She's an adjunct professor of global health at the University of Washington in Seattle, and a former head of the National Institute of Health of Peru and former Minister of Health in Peru. And Dr. Garcia's presentation is entitled Controlling Human Papillomavirus, Closing the Gaps in the Screening and Treatment of Cervical Cancer Through Self-Sampling. This should be a very interesting presentation. Dr. Garcia.
Hello. First of all, thank you so much for the invitation to share with you what we are doing here in Peru. Actually, my presentation is going to be a little bit different, because what I will be talking about is how to do implementation research, and how can we use technology as a catalyst for changes. So let's start. Let's see if this works. There we go. So I come from Peru, in Latin America, and in Peru, unfortunately, a woman dies every 5 hours due to cervical cancer. So every day, at least 12 new women are diagnosed with this type of cancer. And for every 2 women that are diagnosed, 1 dies. And that is because women are coming very late to be seen at the services. IHME data from 2019 shows us that cervical cancer is the first cause of death in women in reproductive age. And the cases are really concentrated in the most vulnerable regions and populations. I don't know if you have ever visited Peru, but we have a coast, we have the Andes, and we have the jungle. And so we have indigenous women, for example, from the Andes or from the jungle that suffer this type of problem in a much more higher prevalence. Most women are diagnosed or treated in advanced stages. And the problem is that although pap smears are given for free in the health services, women with abnormal pap smears are usually lost to follow-up, or women fear to go to health services. However, science has shown us that HPV, this virus, human papillomavirus, is the causative agent of cervical cancer, and that brings us some hope to do something different. So there are new ways to detect the presence of HPV, which can help us to detect the problem before cancer occurs. And those are the new molecular tests that can detect the presence of HPV in the vagina and in the cervix. But the most important thing is that the sampling can be done by the women by themselves in the comfort of her home, so they can do self-sampling. There is a lot of data nowadays that the use of self-collected HPV test has similar sensitivity to the sample collected by a doctor or other trained professional. So that means that we have a test that can really empower women to take their health in their hands. Furthermore, self-sampling is fast, is minimally invasive, and due to its great acceptability, it can favor really increased coverage. So taking that into consideration, with funding from Grand Challenges Canada, we started working this new concept of HPV screening to improve women's life. And actually, the objective of this first study that we call HOPE was to try to involve women from the community, identify them, and train them so they could become champions and can reach other women, offer them and distributing HPV kits for self-sampling in their communities. So once the sample was collected, usually at home, it could be taken to the health center where we had these boxes that look like mailboxes or like blockbuster boxes where women could leave their samples 24 hours. I mean, it could be open 24/7. Then we created a system with motorcycles to collect the samples and take it to a central laboratory where they were tested. The results were given by cell phone, and the women will, only the positive ones will come to the health center to be treated, and the result will be healthier women, early detection, and better prognosis. So we call, as I said, this new model, the HOPE model. So this is how it looks. I mean, it's this is the test, and the women had to put the tests in these envelopes. And we also created a platform, an electronic, a informatic platform to follow up the whole process from the moment we prepare the kits into giving it to the women. We identified women at the markets, at the schools, at the health centers, everywhere, and we have volunteer women that were trained. And these women also created these bags that you can see there because they said that the interactions were better with women in the markets. And when they opened these bags, you could see the inside of the women and they could explain to the women how to take the tests. These women went everywhere in this area. We did this in the east part of Lima, which is mainly a city in the desert. So these were the mailboxes where women could leave their samples 24/7. And what did we learn in this first phase? First, this study, which was just a proof of concept, was planned for 200 women, but actually we got a donation of tests and we were able to screen more than 2,100 women. 2/3 of the women never had a pap smear before, and we found an HPV prevalence of 12.5. And actually, that means that we really improved coverage. Women that never had a pap wanted to have the test, this molecular test. Women love self-sampling, and they love to learn from other women. And we empower the women that were called the HOPE ladies, really empower themselves within their communities talking about health. The collection sites available 24/7 were critical. The technology was very much appreciated. Women really liked the idea of having a molecular test and the use of cell phones. But the challenge was how to ensure that every positive woman received treatment and follow-up. And so we decided to start looking if there were other technologies that we could use to try to redesign the care system so we can bring the system closer to the women. The same way that we were bringing screening closer into the community, can we bring the management closer to the women? So that's why we decided to work in an area where we have the most vulnerable women in the Andean region. Cajamarca is called the Switzerland of Peru. It's a beautiful place, but also it has a lot of poverty. So we decided to work here. And first of all, the idea was to introduce new technologies to catalyze health systems redesign. And I was lucky enough to meet people from Duke University who were working on new technologies. So we decided to introduce self-sampling that empower women, and also this pocket colposcope, okay, that allowed to look at the cervix, but also to transmit the images into the cloud so somebody else could look at the images at the same time that we are exploring or we are examining the women. So we decided to create this concept of the improved VIA. This is visual inspection with acetic acid of the cervix. And we call it improved because the idea was to have a midwife, a professional midwife, examining the patient, but having an expert in another part, it could be in Lima, far away, that could help, okay? And we call this tele-VIA, the professional midwife to do better diagnosis. So we could have this remote connection with experts and we could have quality control. But we needed to add some type of treatment because if the woman was found to have a lesion that could be treated, so they need some type of treatment. And this is the new devices that are recommended by WHO, the thermocoagulators, that had not been introduced in my country, and in several countries are not using it yet, but it's much better than cryotherapy because it doesn't need any, I mean, it works on batteries, it doesn't need CO2, and it's very safer. And the idea was to assure adequate management at the first level and the references to other facilities if needed. So the whole concept was trying to, and look at the yellow at the bottom, do HPV self-sampling at the community. So look for women knocking the doors in their houses, going to the markets as we did before, but this is in the Andean region. And then if women was positive, to send them to primary health centers where we have personnel that is trained that could see them and triage them to be treated, and only the women that didn't have criteria for thermocoagulation be sent to the second level, that are hospitals that have doctors, or if the women had advanced lesions, to go to the third level. But the idea was to have a pyramid, so most of the women will be managed close to home. We included a patient navigator. That is a concept that we have never been included in our country, and we use an informatics platform. So we started working with the regional government of Cajamarca to plan together the intervention, meetings with the women from the community so they could understand and could be part of the solution. And this is part of community engagement. And we plan, actually, this whole study was supposed to be started in 2020. And as the previous presenter, everything was stopped. And we were just during the pandemic planning things. And so a project that was going to be 3 years, we have to do it in only 1 year, actually, in 2022. So we started by doing some advocacy in the community. We trained trainers in the community also, so they could help us to move on this whole concept. We trained health workers on HPV testing. Everybody had to learn about it. We trained the midwives and general practitioners so they could know how to use the thermocoagulator, the pocket colposcope, this enhanced VIA, and the tele-VIA. And then we trained the second level, the OBGYNs, so they could do LEAP and they understand what this was about, and then training the third level. So we went from training and doing advocacy from the community all the way to training the experts at the hospital. And of course, with the patient navigator and the information platform. So what you can see on one side is one community women teaching in a market, another women how to take the test and how to put it in the tube. Then you can see some providers that are learning how to use the pocket colposcope, how the images could be seen in the cell phone and how this will be transferred into a computer. You can see that at the bottom, where the experts will be seen and will be sending recommendations to the midwife in Cajamarca. The women waiting to be seen, and here you can see some midwives already doing the procedures. Here is the group of experts that we trained also that are seeing the lesions at real time, so they could give recommendations to the midwife on the other side. So actually, we kind of like ran during the year, and we were able to collect more than 4,000 women had self-collected samples. We found a much higher prevalence than before, about 14.3%, and 97% of the women went to their appointment at the primary health clinic at the first level. And the most important thing is that almost 80% completed the treatment at the first level. So we were able to really move the positive ones and treat them closer to their home. There were 2% of the women that are still waiting to be treated because they were they got pregnant in those few weeks that took them to get managed or to get treated. And we have about 15% of the women that were referred to the second level and 4% to the third level. So actually, this pyramid that we wanted to have, trying to move all the care closer to the women, was achieved, really. And so far, 87% of the HPV positive women have completed their treatment at health establishments, which means from level 1 to the third level. And if we compare what was happening before, then less than 10% of the women was really follow up with pap smears. I think we have achieved a very important number. WHO recommends that at least 90% of the HPV positive women should be treated. So we're very close there. So what goes next? Well, now we're struggling, but it is quite important when you work on these to work on sustainability and scale up. So we're continue working with the local government. We're trying to see what are the policies, the funding. We're trying to give them technical support. And we have grown from 4 health centers and 1 network into 4 more networks within this region of Cajamarca, far away. So we're working with the government. The government has already bought the HPV test, and we are continuing seeing how can we increase that percentage, doing some qualitative work and working together with the government. And we think that this is not going to happen only this year, but the following years. So finally, technologies are quite important, and we can use technology and community engagement. And we are aiming to assure empowerment of women, competence of the system, integration, continuity, and completeness of care. Thank you so much. But the most important thing, we think that with all these things, we can assure equity and we can reach with technology the most vulnerable women. Thanks, John, for the invitation.
Thank you very much. That was truly outstanding. Hopefully we can do something similar in Canada, certainly in Manitoba.
Hope so. I hope so.
Too. Okay, next we'll turn our attention to new therapies for management of sepsis, given by Dr. Ryan Zarechansky. Ryan is someone who needs no introduction. He's been to Bug Day many times. Ryan is a hematologist and critical care physician, and Ryan has led and is leading numerous international clinical trials evaluating adjunctive therapies in sepsis and in COVID. And Ryan also led a number of COVID clinical trials locally in Manitoba during the COVID pandemic. So Ryan, over to you.
Can you hear me okay, John?
You're good to go.
Okay, excellent. You can hear me?
Perfectly.
Wonderful. Okay, I'm going to share my screen. Okay, can you just confirm you can see that slide?
Perfectly.
Wonderful. Thank you so much, John, for this invitation to speak here today and for organizing this incredible event. I mean, it's just a scale that is just unparalleled, and you deserve so much congratulations for bringing this together year after year. I'm going to talk about new therapies for sepsis. These are some disclosures related to grant funding that is not related to this talk per se. Consider this case, please. A 68-year-old female, 4-day history of fever, increasing shortness of breath, confusion, no urine output now for a day, bit hypotensive when she presents, heart rate's a bit high, 86% on room air. You look at the chest X-ray, it's got a right upper lobe pneumonia, some right lower lobe pneumonia too. Is this what my mom would have called double pneumonia? I'm not sure, but anyway, but it's definitely a pneumonia. And how would you treat this? And so at the end of this talk, we'll bring everyone up to speed with regard to the current definitions of sepsis and what constitute initial therapy, and then we'll talk about a little bit about corticosteroids in therapy in sepsis as a adjunctive or novel treatment, and then some really emerging treatments for sepsis. Okay, sepsis is a big deal, right? It's one of the most common causes of global mortality, over 50 million cases each year around the world. It's one of the most, if not the most common preventative cause of death. And if you have it, you can have short-term but long-term consequences. What is sepsis? So we're not, I don't mean just infection, I mean sepsis. And sepsis really is a term that defines organ dysfunction that's been dysregulated because of the infection. And so you have a host response to the infection. That host response is inflammatory, it's coagulopathic, it's initially adaptive and can become maladaptive. And it really defines the sepsis is defined by the organ dysfunction that's in response to the host. And it represents a progression. You get a bit of infection, then you get sepsis, and then you get septic shock where blood pressure falls. The most common cause of sepsis is infection. There are some like small print non-infectious stuff like pancreatitis and burns, but when we really talk about the incipient causes of sepsis, it's the majority of which are infection for sure. And the common sites of infection are on the screen there, like pneumonia, UTIs, the most common by far, abdominal sources after that. You know, it's most important that we recognize sepsis first of all. Okay, novel therapies are great, but let's just make sure we recognize this. And this is like an acronym that is like convenient and simple. It's not sensitive or specific, but it's really more sensitive than anything. And so if you have these, you should think about sepsis: slurred speech, extreme shivering, not passing urine, shortness of breath or breathlessness, you know, feelings of, you know, doom, mottled skin. And so if you have some of these, if your patient has some of these, think about sepsis. If you're a scorer and you like scores, there's a couple scores that you can calculate to help you ascertain or figure out the probability that the person could have sepsis or not. Do they have a dysregulated host response to infection? That's what we want to know. Are they at high risk of death? If they are, if you are worried about sepsis, this is an emergency, okay? Time is lives in sepsis, and we resuscitate, we give antimicrobial therapy, we cut out the infection or source control if it's appropriate and if it's possible. And we try to prevent future infections. Within the first hour to 3 hours, we figure out, okay, what are the goals of therapy for this patient? Can identify the source of infection with culture or test. What antibiotic should I give? Tailored if it's localized, broader if they're critically ill. And resuscitate the patient, get them out of shock if they are in shock, if they have low blood pressure. And then like John Emble in particular identifies this with regard to source control. Like if you have a source of infection, remove, debride, drain, wash, you know, amputate if necessary. Non-controlled infections are associated with high mortality, and you should do this as quickly as possible. Okay, what is sepsis? And how do we diagnose it? Get us on the same page. How do we treat it? Well, these are the tenets of treatment, and the bolded one is really the only like pharmacotherapeutic. Source control is important though, I might add. But you know, we really have one type of drug, antimicrobials, to treat infection. And so despite this, the mortality is high. The mortality ranges a lot depending on how sick you are. If you're on the ward, if you're at home, you know, cellulitis versus on the ward, with pneumonia versus in the ICU, with, you know, ARDS or multi-organ failure, the mortality changes a lot. It ranges a lot. But regardless of where you are, there's a mortality rate associated with sepsis despite antimicrobial therapy. And so we've kind of accepted that. And we've like, hey, we'll give antimicrobial therapy. But the patient is still at high risk of dying. And we have to recognize this, and we ought to do better. Like the corollary is cancer. Like, you know, we're kind of like done with cancer treatment if we can cure the cancer. And in this case, in sepsis, there's a lot of cases where the outcome is bad despite giving the therapies on the screen, including antimicrobial therapies. And often often a patient's death is not due to uncontrolled infection, but it's due to this host response, this dysregulated immune response to the infection that really contributes to mortality and morbidity. Okay, and so so what do we do about this? Like, are there other therapies beyond antimicrobials? Well, you know, like COVID was terrible, but COVID really opened our eyes. We knew this at first, but we were kind of like squinting at the issue. But it really made us aware of adjunctive or ancillary therapies for someone with sepsis, due to COVID in this case, that could work in addition to specific antiviral. So the one on the red, remdesivir, is an antiviral at the end, which is a little bit fine print on this slide because I don't want to get into specific treatments for specific pathogens, but we do give this in COVID. We didn't know if it worked at first for COVID, by the way. It was an a viral, really created for other reasons, and repurposed for COVID. But it does work, and we do give it to hospitalized patients who are not critically ill. But one of the first therapies in COVID that we got onto was steroids, like corticosteroids, and not anabolic steroids, but corticosteroids. And we recognized through really great clinical trials, large clinical trials, that if you're on oxygen, if you're sick enough to require oxygen, then steroids, particularly dexamethasone, but other corticosteroids as well, can reduce your progression to critical illness, can reduce your mortality. I had the privilege of leading multinational trials of therapeutic dose heparin. So these are people who are sick in hospital on oxygen, but without clots. And we showed that if you are not critically ill, but in hospital, therapeutic dose heparin, in the absence of blood clots, so you like treating a blood clot without one there, reduces your progression of critical illness and mortality. And now this is a standard of care around the world. Other therapies that are like adjunctive, so not targeting the specific pathogen, but are other therapies that are used in COVID, or tocilizumab, an IL-6 receptor antagonist, and this reduces inflammation. And in people that are rapidly progressing on the ward despite other treatments like dexamethasone and oxygen, we give this to reduce inflammation, and it reduces the progression of critical illness and mortality as well. So we got onto the fact that the other therapies could exist. Okay, so that's COVID. Is it behind us? It's more behind than ahead, I think. But it really got us onto adjunctive or other therapies in addition to antimicrobials. And so what about in non-COVID sepsis? And this is still the majority of sepsis, the 50 million cases around the world. And so where do steroids and other medications fit in? So I'm going to talk about steroids, vitamin C, therapeutic dose heparin again, and plasma exchange as potentially novel and adjunctive therapies. Okay, steroids. Okay, this has been going on for a long time. This debate is really old. But our concept, our thought around whether we should use it or not is always being nuanced. And I'm going to provide the sort of current state of the art of steroids in non-COVID sepsis. So let's talk about septic shock first. So septic shock is if your blood pressure is fallen and you need like some vasopressors or kind of life support therapies. And the rationale here is that if we give steroids, we might overcome critical illness related corticosteroid insufficiency, where the adrenals, don't work as well, or you're not able to respond to the cortisol as much as you should. And could you reduce inflammation a little bit? And we do use this, and we use it in refractory shock. So when vasopressors are needed despite fluid resuscitation, we give hydrocortisone, a kind of a weakish kind of steroid. And we are pretty convinced from a lot of randomized control trials, and there's some meta-analyses references at the end. There's a lot of them, trials that is. And it reduces the duration of shock. So you stay on vasopressors less. That means you might go to the ward more. You are mechanically ventilated less. There's a bit of like small adverse events like hypernatremia and controlling blood sugar, which we think we can do well, and maybe a bit of weakness that could occur after. But we're convinced of the reduction of shock. The mortality reduction is a little bit more uncertain, but we think there's a small and consistent mortality effect in the trials. So we give this routinely in the ICUs for refractory septic shock.
3 minutes.
What about pardon me?
3 minutes left.
Oh yes, okay. What about my timer says 4 minutes, John. But anyway, okay. But and so what about community acquired pneumonia when you're not in shock, when you're on the ward now? Well, let's take a lesson from severe pneumonia in the ICU. And so recently this year in the New England Journal of Medicine, there was a landmark RCT that came out that randomized patients to hydrocortisone or usual care for severe pneumonia and saw a reduction in mortality in patients with severe pneumonia. This is going to change the way we treat severe pneumonia in the ICU for sure. And so most of sepsis, though, is still on the ward, and community-acquired pneumonia is the most common cause of hospital admission. And should steroids be given on the ward? And is this a new therapy? This is a really great question. And we're submitting a grant to study this now. And more randomized trials are definitely needed before we extend the therapy, extends corticosteroids used in septic shock. Now will be used in severe pneumonia to the ward. What about vitamin C? The rationale here is that it could reduce inflammation and oxidative stress. There are several randomized control trials. It's cheap and easy, but it doesn't work. And so people had enthusiasm to use this, and you may have been one of them, but your enthusiasm should be pretty curbed now, and it's not recommended. What about therapeutic dose heparin? Well, just to remind everyone that therapeutic heparin has clear benefits when given to non-critically ill hospitalized patients with COVID-19. The rationale is that CAP, or community-acquired pneumonia pathogens, does activate immunothrombosis, so heighten your immune system, put you at higher risk of blood clots, and causes organ failure. And heparins are blood thinners. They have anti-inflammatory properties, and they're antimicrobial. To know if therapeutic dose heparin might work in non-critically ill patients, we are leading and have launched a large international trial. Manitoba is at the forefront of this, and we have just started a trial in 57 sites in 3 countries, expecting to enroll 3,000 to 4,000 patients. And the trial will be open in about 2 weeks, I think, at HSE, St. Boniface, and Grace Hospital on the wards. If you're at a hospital that can do clinical research and you want to participate, come reach out to me, because this trial is open to everyone who wants to participate. Lastly, I just talked about plasma exchange a little bit. So plasma exchange is where we kind of like, it's like dialysis a little bit, where we remove the blood, take out the plasma, and put in fresh plasma. So with dialysis, we're removing other small molecules, but in this case, it's the whole plasma. And the rationale here is that sepsis is complicated. There's lots of injurious mediators, things that are beneficial for us, like anticoagulation and immunoglobulins can go down. And the notion is that we remove injurious substances, bacterial toxins, inflammatory mediators, and we replace things that we need, like anticoagulants and ADAM13, immunoglobulins back, and we restore the immune and coagulation homeostasis. There's a lot of interest throughout the world right now in plasma exchange. And again, I'm really proud to say that Manitoba is at the forefront of this again. And whereby Sylvain Lother and myself are studying therapeutic anticoagulation. Emily Rimmer and myself and others are now studying plasma exchange within Canada. And we are randomizing people to therapeutic plasma exchange or usual care. Our goal initially is feasibility, and then we'll focus on mortality in a larger trial. We have 9 sites participating, and the trial is currently open at HSC and St. Boniface. So in summary, novel therapies in sepsis, steroids we use in septic shock in majority of patients, and we are starting to use it in severe community-acquired pneumonia. More randomized trials are needed in CAP on the ward. We're studying therapeutic dose heparin on the ward and plasma exchange in critical illness. So back to this case, this patient who presented with their chest X-ray, what was the diagnosis? Community-acquired pneumonia. How would you treat it? Resuscitate, give antibiotics. There's some standard antibiotics. It would change if you were worried about MRSA or Pseudomonas. And maybe therapeutic heparin or steroids. I don't know, but the only way we're going to find this answer is to enroll in a clinical trial. Those are the objectives again, which I think I covered about sepsis and corticosteroids and emerging therapies. And here are some reference materials, and please feel free to reach out if you have questions.
Thank you very much. So hopefully, Barry, Patricia, and Ryan are still on. We have some questions. So one of the first questions for Patricia is, does Peru have a human papillomavirus vaccination program?
Yes, we do. The vaccination program for HPV started in 2011, but because of some anti-vaccines movements, which were very rare in our country and in South America in general, it stopped and it was restarted. It started through schools for girls, and in 2016, we had a catch-up, okay? And just recently, we have started vaccinating boys, And a new law to vaccinate adolescents up to 18 years old has been just released a week ago. Having said that, okay, I think vaccination and the government is trying to push the coverage up, but I don't know if anybody follows the politics, but my country is very unstable politically, and that means that things don't move as we would like in any of the sectors. However, as I was saying, this is going to benefit young women if we are able to reach very good coverages. But in the meantime, we have cohorts of women that are suffering, that are already infected, and that's why it's quite important to really give them something that could decrease the risk of cancer. And that's why HPV sampling plus adequate treatment is critical, especially in those regions in which we know that there will be an additional effort in order to really reach the vaccination rates that we need.
Thank you. Next question, still on human papillomavirus. Is there evidence whether human papillomavirus vaccine is effective in preventing cervical cancer in women who are no longer sexually active?
Yes, of course, because one of the things is that this is kind of like a roulette, right? It's not like when you have sex, you're going to get infected right away. There are studies that have shown that even in female sex workers, where there has been they have been tested for HPV, they may not be infected yet. So the likelihood, it is not that the vaccine is going to have an effect on the virus if you are already infected, is that you may be sexually active, but because it's a package of viruses, you may not have had the infection, and you can still have the effect and the protection of the vaccine. So that's why the idea is to try to catch the girls earlier as possible, but it is important also to vaccinate the rest of the women because they may not have been infected, and we can decrease their risk.
Thank you. So a question for Barry LaValle, if Barry's around.
Yeah.
For Indigenous
I'm
harm
here.
reduction. Thank you, Barry. For Indigenous harm reduction, are you employing people from the communities, from working with Indigenous people? Some do not want to receive care from their communities because they know or are related to a lot of people who work there. Great question. So how do you overcome the issues of familiarity amongst
It depends, really. That's a really great question. I mean, the move during the last few years is really not to rely on services in Thompson or Winnipeg, because the communities just don't see a lot of benefit by sending people out. So a few of the communities said, we want to get beds in our community, like 12 beds, to support people who might not need medical intervention. It's been a bit of a tricky road because the autonomy that communities want, they want to take care of their own people, right? And work in collaboration. So it still is a struggle. We have one community that has 12 beds, and there's been little uptake within the community. Now, we helped them put the beds together, like this system, but that was from leadership. And I think the rapidity with which our needs for harm reduction are there, we didn't engage to details with the community about their wants and asks. So this is actually a significant question, but no, not all Indigenous people are not afraid. They're not afraid to be treated by their own people. There's just some communities. I mean, it's just, I suppose, like anywhere else, but that's a great question. Thank you.
Thank you. So a question for Ryan Zarachansky. In the future, do you see a single treatment for sepsis, or is this a collection of treatments that are all tailored to the individual? You know, obviously antimicrobials are required, but is there going to be the menu of you give A, B, or C, or is it A, B, C, and D? How do you perceive sepsis management looking into the future?
Well, thanks, John, and those who asked the question. Well, I think I see bundled care that's tailored toward the pathogen and the patient's risk profile. I think we're going to see a lot more exploration of heterogeneous treatment effects in trials. COVID really got us onto the fact that you could have one therapy that could act differently based on your clinical or physiologic profile at the time. And so I think we're going to see therapies develop that are not only pathogen specific, but patient specific, depending on their comorbidities and severity of illness.
Thank you. Barry, another question for you. Where do you see your dispenser? How do you see it being used? Where do you see the future for this device? Or is this a nice device, but we're not there yet?
Well, you know what? That's a really great question. I think at this point in time is a bit of a struggle and disappointment. We were unaware of bringing that technology even into Winnipeg, and Southern Manitoba, and and Churchill, that there are actually a lot of issues in terms of connectivity as well as process and then community engagement. So it's set up in Churchill. We may have 1 or 2 people on the machine. We have it in like one community, particularly on the eastern side of Lake Winnipeg. And it's really the fact that the connectivity is a real challenge. And you know what, guys, during the pandemic and afterwards, there's a high changeover of staff in these positions. So again, it requires us to do education, on-site support, etc. So it might have been, in my mind, the wrong time to bring the kiosks in, but they were brought in as a matter of urgency with the needs. But that's a great question.
Thank you. I unfortunately don't have any more questions. I hope that this was a good session for everyone. Certainly a variety of different topics. And another HPV question: does Peru test for which strain of HPV an individual test positive for?
In general, in 2017, when I was Minister of Health, actually, we released the guidelines for the very first time for HPV testing, okay, in general, for molecular testing. And unfortunately, since then, although the guidelines were there, the country had a struggle with all this political instability. And that's what when I left being minister, I continued doing the research to try to see if I could create a path for the implementation. But the country didn't bought the tests. So actually, if somebody asks the country is testing, the country is not testing yet. The government just bought some tests, okay? Right now they bought the Roche tests that could allow to define different types, mainly 16 and 18 types of HPV. But for example, the test that we were using in these studies is the HPV Care, that will test for the 11. So it will give you just a positive if you have one of the 11 types that are high risk for cancer. Actually, for the management, probably when we talk about public health, and the difference in prices is very important also when you are thinking about implementation at the country level. For the management, in general, what you need to know is probably if a woman is positive or not, especially if you know that several times, and when you are working in remote areas, women will come only once for the health center, and it will be very difficult to follow up. So that was a long answer, but in general, what I'm saying is like, it's not like Peru is testing, even in the private sector, only in a few places, HPV molecular test, it's being used. So this is something like a process that is just starting to happen.
Thank you. Someone inquired about the harm reduction movie that Barry LaValle talked about. And Barry's comment was, if anyone wishes to watch the movie, contact him at his office by email at barry.lavalle, LAVALLEE, at KIMINOAYAWIN.com. I think with that, we'll wrap things up. And we've got a 15-minute break. We'll see you back at 10:15 with breastfeeding in women infected with the human immunodeficiency virus. Thank you very much for all of our speakers, and we'll see you at 10:15. Thank you. Welcome back after the break. So our first speaker of this group of three, and remember we're grouping three presentations together with the questions and answers afterwards. Our first speaker is Dr. Vanessa Poliquin. Vanessa is an obstetrician gynecologist who has a specific interest in reproductive infectious diseases. Vanessa is the head of the Department of Obstetrics and Gynecology and Reproductive Sciences at the University of Manitoba and the provincial specialty lead for women's health. Vanessa is going to cover the concept of breastfeeding in women infected with the human immunodeficiency virus. Thank you, Vanessa. Take it away.
Thank you so much for the introduction. I'm just going to share my screen here. Here we go, and it should be up. So good morning, everybody, and thank you so much for inviting me to speak on the topic of infant feeding in HIV. As you're going to see over the next 15 minutes, this is an evolving topic that is presenting new challenges for both expectant parents living with HIV and their healthcare providers. I have no conflicts of interest in relation to this presentation. Several source documents as well as my slides use the terms women and mothers. Certainly this talk applies to all parents living with HIV who are making decisions about infant feeding, including transgender and non-binary individuals. As advertised in the Bug Day program, these are my objectives. The term mother-to-child transmission of HIV refers to vertical transmission of the HIV virus from an infected woman to her fetus or infant. Vertical transmission can occur during pregnancy as a result of transplacental passage of the virus, during labor and delivery by exposure to maternal blood and vaginal secretions, or during infancy through exposure to breastfeeding. The table on the right presents generalized estimates of the magnitude of the risk of transmission for each perinatal stage if an HIV-infected woman is not receiving antiretroviral therapy. The table also demonstrates in the last three rows the overall risk of transmission for HIV with and without breastfeeding, again in the context of no treatment. Fortunately, with the advent of combination antiretroviral therapy, being pregnant with HIV in 2023 is a much better news story than it once was. This is the data from the Canadian Perinatal HIV Surveillance Program, CPHSP, which collects data from 22 HIV referral health centers from across Canada, including from Manitoba. With the provision of combination antiretroviral therapy to women during pregnancy, combined with IV zidovudine during labor, 4 to 6 weeks of oral zidovudine prophylaxis for the newborn, and exclusive formula feeding, you can see that vertical HIV transmission is dramatically reduced from nearly 30% to less than 1%. This demonstrates that with effective virologic suppression, the risk of HIV transmission from mother to child can be virtually eliminated. There are, of course, missed opportunities to prevent transmission in Canadian cohorts, and these continue to be related to factors that lead to late diagnosis or late treatment initiation in pregnancy. And I want to take a moment to acknowledge that factors leading to missed opportunities to prevent transmission of HIV perinatally continue to be associated with structural racism and the lasting negative effects of colonialism. And there is an ongoing disproportion in the burden of perinatal HIV transmission that is carried by our most marginalized residents in Manitoba. Virologic suppression of HIV with consistent use of antiretrovirals also eliminates the risk of sexual transmission. In 2013, Lutfi et al. Conducted a systematic review of studies that considered the rates of sexual HIV transmission between heterosexual serodiscordant couples. This group found a zero risk of sexual HIV transmission when the HIV positive partner had full virologic suppression on combination antiretroviral treatment. So this data helped to propel the U equals U movement, distilling that undetectable virus is untransmittable. These findings also help to underline the importance of HIV treatment as prevention. So this brings us to our first multiple choice question. What is the risk of transmitting HIV to an infant through breastfeeding if the breastfeeding parent has an undetectable viral load? We'll cover the necessary content to answer that question over the next few slides. Before we dig into whether U equals U holds true for breastfeeding, let's talk a little bit about the components of breast milk. It's these components that both make breast milk a powerful infection-fighting substance, but also present unique challenges where HIV is concerned. Breast milk components have evolved over time to protect infants from enteric pathogens. A unique mix of non-cellular components like cytokines cause bacterial inactivation and lysis, boost cellular response to bacteria, block pathogen entry into host cells, and mitigate gut inflammation in the infant. Maternal leukocytes in breast milk are distinct from those in peripheral blood. They're mostly memory T and B cells, which have previously encountered antigens and express high levels of activation markers, meaning that they're primed to respond to antigen exposure. Similarly, maternal neutrophils and macrophages in breast milk behave differently. They have higher phagocytic activity and more cell-to-cell signaling. These characteristics of breast milk reinforce the idea that human milk provides neonates and infants with supplemental, highly immunologically active components designed to protect the infant from potential pathogens. Nonetheless, the same cells that provide these functions are also ideal targets for HIV infection and transmission. They are memory cells of mucosal origin with a high level of activation and abundant cell surface expression of HIV co-receptors. In fact, latently infected resting CD4 T cells in the breast milk are the sanctuary from which the HIV virus can be released after activation in the mammary gland. These cells that are latently infected have a half-life of 44 months, and the virus within these cells is not affected by current treatment regimens. So even when the cell-free HIV viral load in breast milk is undetectable, cellular activation of latently infected CD4 T cells in breast milk can be 17 times more effective at producing HIV antigens than their counterparts in the blood. So how big is the risk of breastfeeding if a mother has an undetectable viral load on antiretroviral therapy? The risk in high-income countries remains unknown, but the data that we have is derived from low and middle income study settings. We know that antiretroviral therapy reduces the risk of transmission through breastfeeding significantly. Without treatment, the risk of transmission through breastfeeding is about 5 to 20%. We know from a 2017 meta-analysis looking at studies of breastfed infants whose mothers were on antiretroviral therapy that there appears to be a 1% transmission risk at 6 months and just under a 3% transmission risk at 12 months. In 2018, the PROMISE study was published. This was an RCT that compared maternal treatment to infant nevirapine as prophylactic strategies in the context of breastfeeding. The PROMISE study saw such low rates of transmission, less than 1% in both arms, that in fact they weren't able to compare the two prophylactic strategies to one another. What these studies tell us is that the transmission risk through breastfeeding while on antiretroviral therapy may be less than 1 to 2%, but is not zero, owing to the reservoir of HIV in latently infected CD4 T cells that can become activated in the mammary gland. Certainly, the risk can be higher if there's mastitis, cracked nipples, high viral load, or non-adherence to antiretroviral therapy. So the risk of transmitting HIV to an infant through breastfeeding, if the breastfeeding parent has an undetectable viral load, we think is about 1 to 2%. In addition to the risk of transmitting the virus, the other considerations for breastfeeding relate to the exposure of the infant to antiretroviral therapy through breast milk. The bioavailability of combination antiretroviral therapy in breast milk is variable. The end result is that where mother-to-child transmission through breastfeeding does occur, the virus that the infant becomes infected with often demonstrates multi-class drug resistance. This is especially problematic, as our pediatric infectious diseases colleagues know very well, because there's a very limited number of antiretrovirals that are available in liquid formulation for young infants. Additionally, pharmacovigilance of infant exposure to drugs through breast milk is poor, and it is unknown whether some of our newer antiretrovirals are compatible with breastfeeding. So this brings us to our next MCQ. Where a breast milk alternative cannot be safely prepared or reliably accessed, what is the recommended infant feeding strategy? Let's start our discussion in a part of the world where not having a safe alternative to breast milk is a common reality. In sub-Saharan Africa, 1 in 10 infants born will not see their first birthday. Pneumonia, diarrheal illness, and malnutrition together account for 37% of infant mortality in sub-Saharan Africa. The survival curve on the right demonstrates the risk of not breastfeeding in sub-Saharan Africa. If an infant is not breastfed, they have an odds ratio of 13 for mortality by age 2. The morbidity and mortality of not breastfeeding, where safe alternatives are not available, underlie the WHO recommendation for infant feeding in the context of HIV. WHO recommendations are developed for settings where the prevalence of diarrhea, pneumonia, and undernutrition are high, and the WHO recommends exclusive breastfeeding for 12 months at least and up to 24 months, while HIV-infected mothers are fully supported on antiretroviral therapy. The WHO states that mixed feeding is not a reason to stop breastfeeding, and that some breastfeeding is better than no breastfeeding. So where there is no alternative that can be safely prepared or reliably accessed, exclusive breastfeeding, regardless of the viral load, is the recommended feeding strategy. Of note, this recommendation is paired with the WHO urging countries to enable access to antiretrovirals for pregnant and breastfeeding women. Our last multiple choice question takes us to Manitoba, where we can and do provide free formula to breastfeeding parents living with HIV. In this context, what is the recommended method of infant feeding? Certainly, decisions about infant feeding are becoming more nuanced in high resource settings. While we worry less about infant mortality from pneumonia and diarrheal illness, the power of breastfeeding to mitigate the risk of allergies, atopy, and chronic diseases like diabetes is becoming increasingly recognized. Further, mothers living with HIV continue to face stigma of not breastfeeding. They express grief and sadness. Social media knows no international borders, and therefore there's information sharing across the world, and there's confusing mixed messaging where high and low income recommendations differ significantly. All these feelings are valid. However, so are the realities of caring for a child or adolescent who's been infected with HIV. As I've mentioned, there's a very limited variety of antiretrovirals that are available in liquid format. And the reality of a chronic and lifelong medical condition can't be dismissed. Lifelong, there's a risk of developing antiretroviral resistance, and there's certainly important disclosure implications during childhood and adolescence, and a real risk of non-adherence, which peaks in adolescence and young adulthood. In 2022, the Canadian Pediatric and Perinatal HIV/AIDS Research Group, CPARG, in association with the CPS, AMI, and the SOGC, published a consensus statement on infant feeding in the context of HIV in Canada. This consensus statement affirms that exclusive formula feeding is the recommended method for feeding infants born to women with HIV in Canada. The consensus statement also states that free formula should be made available for all infants born to mothers living with HIV for the first year of life, which it is in Manitoba, and that all women living with HIV should benefit from detailed multidisciplinary counseling about infant feeding, which we provide through the Manitoba HIV program and its affiliates. Certainly, the consensus statement does underscore that service providers should not report a person living with HIV to Child Protection Services or the police for breastfeeding. In the interest of time, I invite you to read the consensus statement for details on what to include in counseling and specific information to provide to parents who choose to formula feed. This is certainly what the vast majority of our patients choose to do after multidisciplinary discussion in Manitoba. For a parent who may choose to breastfeed, the journey is not easy, and it requires close engagement with their healthcare provider. In order to even consider breastfeeding, there are strict criteria that have been outlined in the consensus statement, including full adherence to antiretroviral therapy with sustained virologic suppression, regular follow-up visits, monthly blood work, and a clear understanding that's typically documented in writing of the potential and real risk of transmission. The road to breastfeeding for a baby is similarly arduous, with more medications and more blood work required if the idea of breastfeeding is to be considered. Triple therapy is recommended for the first 4 to 6 weeks of life as opposed to monotherapy, and monotherapy should be applied for the entirety of breastfeeding. Total duration of breastfeeding should be minimized, and weaning and the mixed feeding that occurs during weaning should be minimized to less than 2 weeks. Blood work is recommended to be drawn monthly or every 2 months to ensure there's been no infection or development of drug-related toxicity. So for parents living with HIV in Manitoba, the recommended infant feeding strategy remains exclusive bottle feeding with an alternative to HIV-infected parents' breast milk. In conclusion, HIV therapy reduces the risk of postnatal transmission through breast milk, but even with a fully suppressed viral load, the risk is not zero. The recommended strategy for infant feeding in Canada remains exclusive formula feeding or an alternative to breast milk from an HIV-infected parent. And every parent living with HIV should be afforded the opportunity to have a multidisciplinary discussion about infant feeding. I think that's time. So thank you, everyone. I look forward to questions after.
Thank you very much. So let's turn our attention to vaccine preventable diseases in the aftermath of the pandemic. And anyone who's got children, I'm sure will remember getting a letter from Manitoba Health about the vaccines that their children missed during the pandemic. So our speaker is Santina Lee. Santina is a pediatrician and pediatric infectious disease specialist and a public health physician. So this is the perfect combination to address this this topic. Santina, you're on.
Hi, thanks for having me here. Let me just attempt to share my screen here. Can I just check that you're seeing the full screen here?
Perfectly. Thank you.
Okay, thanks. Okay, so let's get right to it then. As mentioned, the title is Vaccine Preventable Diseases in the Aftermath of the Pandemic. I don't have any specific conflict of interest or disclosures related to my presentation today. And so the objectives I realize are quite ambitious for this particular discussion in 15 minutes. So I will do my best to provide a summary, but by no means am going to be able to cover all the specific details. But by attending this session, the attendee will be able to state the impact of the COVID-19 pandemic on routine immunization programs, to state the impact of the pandemic on the incidence and prevalence of vaccine preventable diseases, as well as perhaps any changes to your practice that you might consider in implementing to help with these immunization rates. So the context, this is not new information to anybody listening today, I'm sure. On January 30th of 2020, the WHO declared that COVID-19 outbreak was a public health emergency of international concern. This has since been rescinded this year, but it has taken up basically our last 3 years, and pretty much all of our day-to-day life was revolved around this outbreak and this global emergency and the response required. And specifically in Manitoba on March 20th of 2020, a state of emergency was declared. And so related to this, with COVID-19 and the increasing number of cases, especially in those early months when the virulence of the virus was particularly severe, there was a lot of strain on healthcare resources. So there had to be a shift of resources in order to manage this new organism that had suddenly emerged on the scene. And so there were a lot of disruptions in our day-to-day life, but these disruptions included some of our routine public health programs, such as the vaccination programs. So early in the days of the COVID response, I recall hearing that there were calls to action and concerns about some of these programs that were being paused or left behind for a period of time. And in particular about the vaccination programs. And I wondered, of course, this is definitely a concern. And we, at least from a provincial and national perspective, but also from a global perspective, there has been so much concerted effort over the last number of decades to try to decrease the number of vaccine preventable diseases and also work towards elimination and eradication of some of them. And so I personally wondered, how much of an impact is this shift in resources going to have on vaccine preventable diseases? So this was from July of 2022, a joint statement from both the WHO and UNICEF, really just sounding the alarm for concerns. And what was the specific concern? That this was the largest sustained decline in childhood immunizations in about 30 years. And typically, when we're looking at immunization rates, one of the vaccines that we look at is the diphtheria, tetanus, and pertussis vaccine. And to look at a single dose of that, and by looking at that, we can get a sense of, are we on target with our goals for vaccination? And in July of 2022, WHO and UNICEF realized that we had fallen really far behind. In fact, 18 million of the 25 million children had not received a single dose of diphtheria, tetanus, or pertussis vaccine during the year. So this was really definitely concerning. Some of the factors that they pointed out leading to access challenge include increased number of children living in conflict and fragile settings, as well as increased misinformation and COVID-19 related issues such as service and supply chain disruptions. And then related to the pandemic, as I've mentioned before, resource diversion, as well as some of the containment measures that pause these programs or decrease the access to immunization programs. And what about a little bit more close to home? So the PAHO, the Pan American Health Organization, this was in April of this year, 2023. They reported that as of in 2021, more than 2.7 million children under 1 year of age did not receive all their vaccine doses against diphtheria, tetanus, and pertussis. Prior to this, Americas was the second region with the highest reported vaccination coverage. Now, even before the COVID-19 pandemic, some of the regions within the Americas had already started having some challenges, particularly related to vaccine hesitancy and misinformation. So rates were slipping. However, this was further exacerbated by the pandemic response. And so now the Americas, PAHO reported as being second in the world with the worst coverage. And so they pointed out some of the factors for this as being inadequate sustainable financing for immunization, as well as increase in vaccine hesitancy, and then of course, everything related to the response for the pandemic. So here I just wanted to quickly show a few graphics because pictures really do say more than words can sometimes. So this is looking at the global immunization coverage, specifically DTP1. It refers to the first dose of the diphtheria, tetanus, pertussis vaccine. DTP. 3 is the third dose, and then MCV1 is at least a single dose of a measles containing vaccine. And so what we can see here is that in 2020, 2021, there were definite dips in the rates of global immunization coverage for these particular antigens. In 2022, we started to see a bit of a recovery, but still those levels had not reached yet to the pre-pandemic coverage rates. And then one of the goals related to DTP third dose is to reach 90% coverage in every single country. And so you can see in the decade leading up to, pre-pandemic, that there were slowly increasing coverage rates in countries who had achieved at least 90% coverage. However, in 2020 and subsequent years, that rate has definitely declined. And so again, concerns of, we were getting close to herd immunity, but not quite there. And definitely that has slipped. So what about locally then in Manitoba? Overall, rates have decreased across all childhood routine immunizations across all regional health authorities. So I'm just going to quickly show a few graphics and again, looking at just like specific antigens to help give us a sense of overall what's going on. And this was data from the Public Health Information Management System poll as of January 17th of this year. This is specifically related to meningococcal C vaccine. So this is by birth cohort. The 2018 birth cohort would be the unaffected cohort. And so you can see there's a bit of variation in the percentage of coverage. However, mostly in the mid to high 80%. But as you get through 2019 and 2020 and definitely in 2021, we definitely see those slips. And this was not isolated to meningococcal C vaccine, which that one's given at 12 months of age. But here showing the Haemophilus influenza B vaccine, which specifically this is given at 2, 4, 6, and 18 months of age. The Haemophilus influenza type B vaccine comes together with the diphtheria, tetanus, pertussis, and polio. And again, you can see that the rates decreased, especially in 2019 and 2020 across the regions. And yet another example, this time looking at the third dose of pneumococcal conjugate vaccine, which that one is given at 2, 4, and 12 months of age. And again, we can see that there was definitely impacts and decline in the rates across the board. So we are nowhere near the national immunization targets at this point. They are very ambitious goals because it's really modeled, particularly for the infant and childhood goals. It is modeled after the fact that for measles, you need a population coverage of 95% for herd immunity. So even prior to the pandemic, if we're in the mid to high 80%, we're not quite there, but it's definitely dropped in the last few years. So then have we actually seen increase in vaccine preventable diseases? Overall, it's too early to tell. We're really going to see in the next number of years what this impact has been. But at the same time, of course, we're already starting to do some catch up. So hopefully we're going to not see as big of an issue as if we didn't do any of these catch up. But particularly in Manitoba, the main vaccine preventable disease where we've had outbreaks is pertussis. So in June of this calendar year, a pertussis outbreak was specifically declared in Southern Health, where the majority of pertussis cases have been reported for this calendar year to date, although they have been reported in other regions as well, just not as many as in Southern Health. As you can see here, even in September, we continue to have cases of pertussis. So overall, this number is higher than in any of the calendar years prior to the pandemic. So that's why an outbreak specifically was called. Across Canada, the main vaccine preventable disease that has been seen in outbreaks and clusters is pertussis as well. Both in Alberta and in Ontario, there were either clusters or outbreaks that were declared, and they continue to be ongoing at this time as well. From an international perspective, there are other vaccine preventable disease outbreaks that have been occurring. I wanted to particular mention a few of them: measles, and I'll show a graphic related to that; polio from both a wild type and vaccine-derived perspective; and then diphtheria, particularly in Europe, including in the UK and Germany, as well as in Nigeria. They've had lots of cases. And so those are just a few of the vaccine-preventable diseases that are experiencing outbreaks since the pandemic and the decline in overall immunization rates. So just quickly, this is from the WHO showing top 10 countries with global measles outbreaks. This is not inclusive of all the countries that have ongoing outbreaks. And then in polio here is just showing some of the countries. The majority is the vaccine-derived type that is causing outbreaks, but there are some wild type outbreaks as well. So a lot of you are already aware of some of these provincial efforts. As Dr. Embo mentioned, there were letters that were sent out to families, particularly to those who have children born in 2019, 2020, and 2021 that were overdue for immunizations. And at the same time, letters were sent out to healthcare providers to let them know about this and ask for assistance in catch-up. And then Public Health regionally has been doing catch-up both from a school-based immunization campaign, but also for the early childhood campaigns by doing things such as increasing vaccine clinics and extending hours. So rates have improved. As you can see here, this is for the meningococcal C vaccine, but we're still not to the same level. Most regions are under 80% coverage. And here just shows the difference between January and October of this year. So we definitely have increased in our immunization coverage rate, but we still have room to improve. And I just wanted to end off with some resources. Even before the pandemic, there was, especially with social media, there's just so much out there with misinformation. And sometimes it's just really challenging to know where to even begin with families in our conversation about vaccine hesitancy. And vaccine hesitancy really is a spectrum. So the Canadian Immunization Guide, as well as the Canadian Pediatric Society, they have a lot of really good resources that can help. BC also has a really great immunization communication tool that you can access. And they have a section about motivational interviewing as well. So I would really recommend that you check out these resources as well. I think I am over time, so I'm not going to go through the assessment questions. Don't hesitate to reach out if you have any questions, but just in conclusion, the publicly funded immunization campaigns were disrupted due to the COVID-19 response. However, before the pandemic, there was already a decline in immunization rates. This is not specific to Manitoba, just like as a general statement, globally, nationally, and so related to that, there was increase in vaccine preventable diseases already happening in some parts of the world. However, this has been further exacerbated by what happened with the pandemic and the response that was necessary for the pandemic. But this does mean that we have increased the vulnerability of our population in terms of vaccine preventable diseases. So there have been some efforts already in the last number of months to catch up immunization in Manitoba. This has helped, but there is definitely still more room to improve. And we can see this by the fact that we have had an ongoing pertussis outbreak in the province. So everyone has a role, and I really encourage you to consider how you might help to improve immunization rates in your specific patient population. Thank you.
Thank you, Santina. We're going to quickly shift gears and turn the conversation over to Jared Bullard, who is a pediatrician and also a specialist in pediatric infectious diseases and the Associate Medical Director at Chatham Provincial Laboratory. Jared has joined us on many occasions over the past few years with regards to COVID-19. So this is another topic that is similar to COVID-19 in that we have an outbreak, a pandemic of sorts of syphilis, and Jared will talk to us about an update in congenital syphilis. Thank you, Jared.
Thank you very much, John. Pleasure to be here. I just want to confirm my microphone is working and that I have the correct display for the presentation.
Perfect.
Jared, just switch your slides. The display.
Always, always. All right. As John said, I usually am here and I'm talking about COVID. This is the first time in a long time that I'm not speaking about COVID, which is rather exciting, even though I still have lots of opinions about COVID to share. I have several conflicts of interest that I'm putting up here, and not that it's so much a conflict of interest as in they're going to inform what I talk about, but it's not directly like I'm being paid by. The objectives are pretty straightforward. We're going to talk about how we got here, what we do about it, and then ultimately what we've learned as well, because I think that over the past 8 years now that we've had a lot of cases of juvenile syphilis, we've learned a lot, and I think we have a lot to contribute. So it's important to start with a few cases, and this is not unusual to see, and even all three of these cases I'll talk about in the course of one day on pediatric infectious disease. So you have a term infant born to a 22-year-old G2P0 by spontaneous vaginal delivery, and she was found to have syphilis at 18 weeks with an initial RPR of 1 in 32. That's pretty typical. She was staged as having primary disease, and she was treated with a single dose of IM penicillin. She was followed throughout the pregnancy. The serology responded beautifully, and at delivery, her RPR was 1 in 2, while her infant was non-reactive, 0 deletion. You can contrast that with a different case. So same woman to start with, but there was no prenatal care throughout the pregnancy. Either she couldn't access it or she was not able to. And she also had the new diagnosis at delivery of syphilis with an RPR of 1 in 32. And lo and behold, the infant RPR is also quite elevated at 1 in 32. Final case, same 22-year-old. This time though, we did find her early at 18 weeks and her RPR was 1 in 32. She was treated for primary syphilis with penicillin as well, and the RPR decreased on subsequent serological follow-up. But when she came for delivery, we find again it's back up to 1 in 32, and we also see that chlamydia has been acquired during that time frame as well. The infant RPR is 1 in 64. So having that information is often helpful in terms of trying to figure out, well, what is the risk? And one of the most important risk factors relates to what stage of disease we're talking about in mom. And so if mom has primary or secondary, so she has lots of prepneums around, this is the significant risk. And so she can transmit this something like 90 to 100% of the time. Whereas we're talking about latent syphilis, it's a lot less likely. So we can get to 40% in early latent, and then less than 10% if we get to late latent. What do we see? Well, we've had a lot of experience. We've seen close to 1,000 syphilis-exposed infants, and a significant portion of them do have higher risk. Most of the time, however, in early congenital syphilis, there are no symptoms to behold. So these babies look entirely normal on their physical exam. When we do find things, it's often things like a rhinitis. So we have really thick, copious nasal secretion with blood and a whole bit. Sometimes we'll see lymphadenopathy as well, particularly on the elbow or the epitrochlear area. And skeletal abnormalities are also quite common. Late congenital syphilis, we have been lucky. We have not seen any of these cases, knock on wood. And those aren't necessarily related to the acute infection. It's more related to persistent inflammation from the early infection. It has several classical signs that we think of historically. So things like Hutchinson's teeth, perforated hard palate, Pudden joints, gumas, and all of those things aren't reversible. And that's if we are failing to identify these children early on. As mentioned, syphilitic rhinitis or snuffle is one of the more common things we see, and this actually usually occurs in the first week. And knowing that, particularly working in the lab, we realized that if we were to do a nasopharyngeal swab and send it for syphilis PCR, maybe we'd be able to find them. And so this discharge has lots and lots of spirochetes or treponemes. So that actually is a pretty viable option. It's something that we've introduced. Rashes are also not unusual. We see a diverse array of different rashes. Sometimes it's maculopapular. I'd say the most common one that we see is a desquamation of the hands and feet in particular. Long bone abnormalities have come a long way. And so when we first started looking at infants who were exposed and diagnosing them, we would see things that we thought were consistent with congenital syphilis, but our radiology colleagues have become a lot better, I think, a lot more nuanced with that. So sometimes you would see pathological fractures. So the manifest as these kids weren't moving their arms. A lot of the time when we're thinking about the X-ray findings, they're bilateral and symmetric. And so our radiology colleagues have become a lot better at saying, yeah, the lesions that we're seeing, they do have that hypodensity to it, but they're unilateral, they're not symmetric. They're really in just one bone. And that's not nearly as consistent as a Wimberger sign, for instance, that we see in kind of the longer bones in particular. So what are we seeing here in Manitoba? Well, we would consider certain things low risk. So if you think about that first case, this was a young lady that we picked up early in pregnancy. We treated with penicillin well before the delivery, so at least 4 weeks before. She got the appropriate treatment for primary disease in a single dose versus latent disease, which requires more. The exam on infant was reassuring, and we have paired serology of mom and baby that are also reassuring. So baby's serology is less than mom. High risk is also characteristic of our second case. So this is a woman who didn't have access to prenatal care or wasn't able to access care. And so we can sometimes also see, like in the third case, a reinfection. So we find them earlier in pregnancy, but subsequently they are in a high risk scenario and they can get infected again. And in particular, we notice that if we find another STD-DI, like chlamydia or gonorrhea, and on occasion we'll find several of them. In fact, we sometimes have women with 4 or 5 different infections. HSV lesions at delivery were one of the more interesting things that we also came across, in that a lot of the time our obstetrical colleagues would comment that there is a lesion that looks just like herpes, and they would send a swab for herpes, and it would come back negative. And in fact, it was syphilis all along. When we have these infants, we really are pretty comprehensive. The single most important thing that you can do as a practitioner is make sure that we have a paired infant maternal syphilis serology. Unfortunately, all of the labor and delivery hospitals here in the province provide that already. And then a comprehensive head-to-toe exam. So that's looking at the baby from head to toe. A head ultrasound is often done, but not always. We do, in fact, have universal newborn hearing screening in this province. Sergio Pinella, we just learned that recently. Ophthalmological assessment is also important, as is the ENT that I mentioned. And screening blood work is helpful. Abdominal ultrasound is helpful, as is a lumbar puncture where we're looking for all the signs of infection. So a cell count, differential, protein glucose, VDRL, and syphilis PCR, and of course, long bone x-rays. Unfortunately, partly because we're seeing so many of these instruments, we're starting to learn about the necessity of some of these. So our ophthalmology colleagues have yet to find anything when we're looking for eye findings. We also know that the LP may not be as helpful down the road to repeat, which we'll talk about in a second too. The treatment is pretty straightforward. So treponeme continues to be universally susceptible to penicillin, and so this is our treatment of choice. And so often we admit these children for investigation and treatment, and it's a full 10-day course of IV penicillin, which comes with all the issues related to that, including trying to ensure that we have adequate intravenous access. And so that often a PICC line has to be inserted. Now, we can also give a single dose of IM penicillin, and we've kind of come full circle on this, or at least I have. I used to say I'm not going to bother doing it. If I'm going to treat, I'm going to treat. But on occasion, I'll have an infant that I see where there was a risk factor in the last week, even though everything was good. And sometimes I'll go ahead and do that. Syphilis serology is essential for the follow-up, and it's probably the most important component, in addition to a physical exam as necessary. Now, keeping in mind that we see infants at 2, 4, and 6 months, we're looking to kind of harmonize the syphilis serology, because what's most important is that we have serial follow-up to ensure that we're seeing an appropriate drop. Now, the LP repeat when we had a child who appeared to have neurosyphilis was something that we struggled with for a long time too, because to try to LP a 6-month-old is very impossible. Not very impossible, it's very challenging. They're little muscle balls. And so they can basically fight, and you have to give them conscious sedation and to repeat it. And what we found was it never really changed our management, because if our serology was reassuring, the LP wasn't changing what we would do. Likewise, we used to repeat x-rays really early, and we found that virtually all of these kids had, in fact, all of the children had full resolution. So what's going on in terms of why are we seeing this? The most important thing to take away is that across Canada, the cases of infectious syphilis are increasing. And most notably, it is in female patients. So that rate has increased by about 730% from 2017 to 2021, compared to 96% for males. And it's also important to note this is in women of reproductive age. And currently, of course, we have an increase in congenital syphilis rates as well. And you can see that over the course of that same time frame, the increase has been almost 1,300%. So what does that look like in Manitoba? These are the figures. So typically, we're seeing between 200 to 250 syphilis-exposed infants I would say about a third of those end up being what we consider high risk, while the others are low. And you can see here too, the rate per 100,000. Now, how does that compare to other countries? Well, in most developed or most resource-rich countries like the US, we're doing significantly better than them, which is not something necessarily to be proud of, of course. And I think this is an important point, especially when we think about what population we find this in. Even more, the number would be higher. We do have some discrepancies as well. So on occasion, you will see that public health reports, and that has to do with the reporting structures that we have, and ultimately what confirms a case and makes it go from probable to that confirmed case. And it's important to include that we don't actually have syphilitic stillbirths in this categorization yet. But we're working on that and have been for the past couple of years. So that data will be forthcoming. As mentioned, we've learned an awful lot about congenital syphilis because of the experience that we have here. Unfortunately, we've been able to publish this data to help inform our colleagues across the country about how to best approach that. Syphilis is not benign in any way, shape, or form. And when you think about it from the perspective of even congenital syphilis, we're doing a lot of screening in women during their pregnancy, and it's just actually cost effective. And so Carl Budman, who is an exceptional ID Mid-Micro fellow here, looked at this very question and found that even though we were spending all of this money on screening, it really had a cost avoidance ratio which was significant. But here's the other important thing is that when we have these infants and we're treating them for congenital syphilis, the whole thing is costing about $18,000 per case. And so when you think of 2021, that's adding up to about $1.5 million to the healthcare system. So what have we learned? We've learned a fair amount. And so from our participation in the Canadian Pediatric Surveillance Program, we are seeing that the prairies are disproportionately represented in the cases of congenital syphilis. And in particular, this is linked very, very closely to the crystal methamphetamine epidemic that we have in those prairie provinces. All of these social barriers, racism around Indigenous people has led them to have a disproportionate proportion of syphilis as well. And that is not unique just to the Western provinces. We're trying to do a little bit more as well in Ontario. The Canadian Pediatric Society has actually leveraged Dr. Fanella's experience in drafting some new guidelines. So we're expecting those to come out once they finally do get clear. And then we're also looking at aligning the various different testing algorithms that we have, both for prenatal and congenital testing, to make sure that we're all saying the same thing. It's also essential that we're counting the number of kids that have congenital syphilis, and we're all speaking the same language. And so Dr. Lee and I have been working very hard to revise the case definitions to make sure that that's happening. And one of the major questions that we have relates to how long the treatment needs to be. As I mentioned, 10 days of penicillin treatment is kind of our standard of care, or at least that's what we think. Now, fortunately, we had a very gifted medical student, Jennifer Simone, who has a headshot, professional headshot that looks like this already as a med student, which blows my mind, a comprehensive review of evidence. So she was sitting there and looking at, well, what is the data to support the standard of care? And most importantly, what's the quality as well? And so with the help of a librarian, she went through a variety of articles and found that overall, there is really limited evidence. When we're looking at kind of the quality of that evidence, it's level 5. There is no randomized controlled trials. And a lot of the evidence that we actually have is expert opinion. So it's like Dr. Lee said, this is the way I treat congenital syphilis. And I say, I would add this in, and we agree, and that becomes a standard of care, which really isn't acceptable. And I think that we're hoping here in Manitoba to help figure out exactly what would be the most appropriate treatment course, because having children away from their homes, especially from our rural and northern communities, can be improved upon. So hopefully we've had a chance to answer these objectives. A bit of a whirlwind there, and I apologize for that. And in terms of the questions, I will skip over those. There's adequate time for questions for the 3 groups. Anyway, thank you very much. And I'll just close, but this is a picture of the Honorable Jean Augustine. Had the pleasure of presenting at the inaugural Black Physicians of Canada conference in Toronto this past weekend. And so she is the first Black woman MP who introduced Black History Month. She's a lovely lady, gave me a big hug, and I was like, kind of shocked by it. So I was like, don't touch me. But anyway, that's all I have for you today. Thank you.
Thank you, Tara. Thank you to all our speakers. We'll open up the questions. So the first question is donor breast milk recommended / available? as an alternative to formula feeding for infants born to mothers living with HIV. And of course, the question of donor breast milk comes with its own collection of questions. But Dr. Poliquin, your thoughts?
Thank you. Providing the appropriate infrastructure, donor breast milk could be considered an alternative. Currently in Manitoba, there is donor breast milk collection that goes on. My understanding is that it's largely directed at our NICU population. Certainly, none of my patients have accessed this resource, but it's certainly a theoretical option.
Thank you. So the next one is a great question because we're faced with nonstop back orders or just absences of different antimicrobials, either based upon manufacturing issues or availability of the raw material. And one question is, it was recently announced that penicillin G, the treatment for syphilis, is back ordered until at least February 2024. What are recommended alternative treatments? And this, of course, is quite problematic. And Jared, thoughts?
I'm familiar with the idea that there is a back order of penicillin G, that it might not be available. But keep in mind, when we're talking very specifically about congenital syphilis, and we're talking about infections in pregnancy, penicillin G is really the only appropriate treatment to give. So ideally, those therapies should be reserved for those cases as necessary. Now, there are a number of other agents that are available, like doxycycline we can use as well, for instance, right? And those are available for other populations that we might not have. We don't have the appropriate supply. But remember, when we're talking specifically about pregnancy and prevention of congenital syphilis, penicillin G is the only option we have.
Thank you. So another very important question. This is a Santina question. There is a huge drop in vaccinations in Manitoba. Is there any move by the Manitoba government to increase funding to public health to address the need to catch up? I suspect there's multiple components to that answer. And Santina, your thoughts?
Yeah, so I mean, I can't specifically directly answer that question. I don't know the answer to that question. But as we can imagine, the immunization program is just one of many priorities that require funding at this point, right? Even if we think about from a healthcare system perspective, there are just so many things that got paused or left behind. So really the point of my presentation today is just really, I wanted to bring awareness and particularly to what our local situation is. And I think really, I truly believe that we all have a role in this. Yes, I totally know and understand that in some regions that public health is the primary immunizer. But I would really strongly suggest that all my colleagues consider how they might be involved in providing and assisting with the catch-up immunization, regardless if you are a primary care provider or if you are a subspecialist, because I personally do take the opportunity to review immunization records for patients that I'm seeing in pediatric infectious disease clinic and try to help catch up because I think I'm part of the solution that is required as well. We have finite resources.
Another Santina question. Brace yourself. Are you ready? We noticed a surge in vaccine hesitancy during COVID. Does this also trigger or play a role in further delaying vaccination in infants born in this period? And that's actually a great question. So what have you observed?
Yeah, I think that's an excellent question, that we need more data to fully understand this. And I know there are a number of studies that are not just locally, but nationally and internationally that are looking at the specific question. Because as I mentioned, some of this vaccine hesitancy was already there and increasing to a certain extent prior to the pandemic. With the vaccine mandates that we did see in a lot of jurisdictions related to COVID, I know that did push a lot of people to feel like they were backed in a corner and had some people starting to question immunizations for other vaccine preventable diseases. So it became, I do feel that, at least anecdotally, and here we're going to what Dr. Bullard was saying, some expert opinion, but here it is that I do think that anecdotally there is some rollover of that hesitancy from COVID into other vaccine preventable diseases. However, what the true extent is and how much of a role it truly plays is something that we'll need to keep an eye on the evolving research.
Two Jared questions. Do we have any concept of the prevalence of congenital syphilis in Manitoba? And are we higher, lower, or the same as the rest of the country, or do we even know?
Right. So here in Manitoba, to give you context, we have about 15 to 16,000 live births per year. And we have about 200, 250 syphilis exposed infants across that timeline as well. When we compare to the other provinces, that is very similar to what we see in Saskatchewan. Alberta is only slightly behind when we're looking at that particular rate. Ontario at this point is not seeing as many cases, but that being said, I think syphilis has made its way into a number of larger centers like Toronto. So we can expect that there are going to be more cases there as well. We're doing our best to try to drop those numbers. I don't think we've quite seen that effect fully yet, but soon I think that we may.
Excellent. And the next question, and it's sort of a laboratory data interpretation. Can an infant that is whose serology is non-reactive for Treponema pallidum at birth become reactive later on, I guess with serial testing? And would the non-reactive infant be given prophylactic or preemptive antibiotic? I'm presuming that the person asking the question is that this infant was born to a high-risk person.
Right. So this is a good question overall. So I think that we have seen infants, and we've seen one in particular. And in this particular case, we had a lady who didn't know that she had syphilis, and she actually screened negative at delivery, as did her infant. But then she also had a high-risk exposure literally in the weeks preceding her delivery. And so what we found in the follow-up of this infant over the course of several months was that the RPR, in fact, did become reactive, and we did ultimately have to treat this child. Now, that is far from common, but the key thing I like to say, if you call me, I'll talk to you. What is the clinical context of the lab result? You have to have that. You can't just base it on the lab result only. So you have to ensure that you actually have something that makes you think this is a high-risk scenario. So in that scenario, had we had that piece of information at delivery, knowing, yes, this woman was in fact exposed to syphilis in the preceding week, we probably would have ended up giving the infant a single dose of IM penicillin. So it doesn't happen very often, but I can think of one case in the 100 where it has been the case. The other the possibility is that, of course, this infant will become an adolescent at one point, and we will definitely do and have seen children and adolescents who become sexually active and acquire syphilis, HIV, and a host of other STIs. So it's important that we're comprehensive in our evaluations and normalizing STI testing in that population too.
Thank you. And the last question for this section of the symposium, has there been any drug-resistant development in syphilis?
Again, so no, not in terms of penicillin, but there are other markers that we use that, from a clinical perspective, you wouldn't usually treat them with those agents anyway. If penicillin is still your drug, use it.
Thank you. And thank you to all our speakers. We will now move to the next section. And it's interesting because the next three speakers are all members of the Public Health Agency of Canada from different branches. So our first speaker is Logan Van Diga. Logan is a research scientist in the Special Pathogens Program at the National Microbiology Laboratory, where his lab studies high containment organisms like Ebola virus and Marburg virus. And Logan's going to speak to us about the persistent threat of filoviruses. And I can tell you, it is truly a persistent threat, certainly for us at the Health Sciences Center. as we are always on high alert if there are travelers returning from endemic areas or scientists at the National Microbiology Laboratory working with high containment pathogens. So Logan, the floor of the screen is yours.
Oh, thank you so much, John. I hope that you can hear me, see me, and see my screen.
Perfectly.
Okay, great. Yeah, well, thanks again for the introduction and thanks for the opportunity to give this talk. I should say off the bat, the only thing I really ought to disclose is that I am not a physician, unlike all of our earlier speakers. And so I'm really, for better or worse, I'm going to approach this topic from the perspective of a scientist and not a healthcare practitioner. What I want to talk about today is the persistent threat of filoviruses. And I know that this can kind of seem like an esoteric topic for healthcare providers in Manitoba. But I think, as John mentioned, there are certainly some factors related to filovirus disease that might be relevant to you. And at the very least, I hope you find them as interesting as I do. So I've got 3 objectives today. Just briefly, one is to sort of introduce or maybe reintroduce you all to the family Filoviridae, then describe some of the threats that are posed by these viruses, and then hopefully highlight the gaps in our understanding. And then along the way, I want to do this all under the theme of persistence, and we'll see whether or not I'm successful in that. And then I also want to take a bit of time to highlight the role the contributions that NML has made over the past several years, the study of filoviruses. So likely you're all familiar with Ebola virus, and maybe you've heard of its cousin Marburg virus and its sister Sudan virus. But actually, this is a really large virus family that contains 16 distinct viruses organized into 8 different genera. And I don't have time to talk about all of them, but I do want to focus on the 6 filoviruses that cause disease in humans, or known to cause disease in humans. So the 4 viruses in the orthoebolavirus genus cause Ebola disease. And this was formerly often referred to as Ebola hemorrhagic fever, although I think that's a bit of a misnomer. And the 2 viruses in the Marburg virus genus cause Marburg disease, which also used to be called Marburg hemorrhagic fever. And the important thing to note about these viruses is that they are all distinct, and the disease that these distinct viruses cause are themselves distinct. And so they all have separate names. For example, Ebola virus causes Ebola virus disease, Sudan virus causes Sudan virus disease, etc. And if you only remember one thing from today's talk, what I want you to remember is that, like I said, these viruses are all distinct. Ebola virus is not Sudan virus, is not Bundibugyo virus. They all cause similar but distinct diseases, and countermeasures against any one of these viruses may not necessarily work against the others. So for now, let's just focus on Ebola virus disease. And I'm going to give you a really brief rundown of what this disease is, which will probably not satisfy the clinicians in the audience, but I think it will do the trick. So this virus really starts with infection of innate immune cells, so macrophages and dendritic cells. And these cells travel to the draining lymph nodes, where you get rampant virus replication, and then that virus spreads from those lymph nodes essentially to every tissue in the body. And so it's really this systemic and robust virus replication in combination with an aberrant immune response. And so what I mean by an aberrant immune response is really high levels of production of inflammatory cytokines and chemokines, which drives a really aggressive inflammatory response, but it's not accompanied by any kind of immune regulation or really a helpful B or T cell response in most cases. And so that's really, those 2 factors together, the virus replication and the unhelpful immune response, are what really produce tissue organ destruction that leads to multi-organ failure and in many cases death. And so the average case fatality rate for Ebola virus is now understood to be about 40%, although it has been as high as 90%, which sort of depends on the outbreak. And there have been many outbreaks. They are a persistent problem. And so these outbreaks are sort of represented on this figure as different sized bubbles in time along the x-axis, and with sort of the rough size of the outbreaks shown on the position on the y-axis. And the size of each of these bubbles reflects roughly roughly the absolute number of individuals who died in each of these outbreaks. So we've known about Ebola virus disease since 1976, when the first outbreak was documented in Zaire, which is now the Democratic Republic of Congo. And this was considered for a long time to be a relatively large outbreak of Ebola virus disease. But of course, that all changed from 2013 to 2016, when the world faced the large epidemic of Ebola virus disease in West Africa, which resulted in at least 28,000 cases and over 11,000 deaths. And that was followed really quickly within 2 years by the second largest outbreak of Ebola virus in the Democratic Republic of Congo, which resulted in over 3,000 cases. So these viruses, or Ebola virus, is thought to circulate in bats, particularly frugivorous bats, although definitive evidence for this doesn't really exist. And so the virus circulates in this reservoir host, perhaps not really causing disease in these animals, or not significant disease. And every now and then it periodically pops into humans, either through a bite or a scratch, contact with urine or feces from bats, or something similar. It causes disease in humans, and then you begin to get human-to-human spread, which really stems from close and prolonged contact between individuals, and in particular contact with body fluid. The virus can also hop out of its reservoir host and into intermediate or amplifying hosts, essentially wildlife like gorillas and chimpanzees. And it can replicate to really high levels in these animals. And so, as the name suggests, they serve as amplifying hosts, which can then lead to infection in humans, through hunting practices or consumption of bushmeat. And so, if there was a silver lining to the West African and then the DRC outbreak a few years ago, it was that it really provided not only the public health impetus, but also the context for driving countermeasure development, running clinical trials, and eventually providing some solutions to this disease. And so we now have a vaccine for Ebola virus that has been clinically approved. It's known as VSV Ebola virus, or VSV-EBOV, or the trade name Ervebo, which is produced by Merck. And we have two treatments or therapeutics for Ebola virus, which are essentially monoclonal antibody therapies, one called Ebanga from Ridgeback Therapeutics, and one called Inmazeb from Regeneron. And I think many of you will be aware of this, but I do have to point out the fact that VSV-EBOV was developed right here at NML by scientists at the Public Health Agency of Canada. And I think the use of antibodies in the treatment of Ebola virus was really pioneered by scientists at the NML in the form of the antibody cocktail ZMapp. And although this one has not and likely will not receive clinical licensure, I think it was critical for helping the second iteration of these therapeutics reach clinical success. But although we have a vaccine, we have treatments for this disease, we haven't actually quite solved it. And we learned that, I think, the hard way, again, during these two outbreaks a few years ago, because we learned that Ebola virus can persist in immune privileged sites, such as the testes, eyes, brain, and other components of the central nervous system. And this was really not well appreciated prior to these epidemics, but then it became quite obvious following them. And so what we learned, thanks to persistence of Ebola virus in the testes, is that Ebola virus can be sexually transmitted, and it's not uncommon for this virus to be passed from male survivors to females. But we also learned that Ebola virus disease can actually reoccur. And so someone can get sick with Ebola virus, recover, and then several months later get sick again, either from something that looks a lot like Ebola virus disease or something that is sort of like a kind of an atypical presentation of disease. And this can and has led to subsequent chains of transmission, just like sexual transmission. So I want to spend just a minute or two talking about a few case studies of Ebola virus disease reoccurrence, which I think really highlight the issue here. And so you might be familiar with the case of the Scottish nurse, the American doctor, and perhaps even the Congolese taxi driver. So the Scottish nurse became ill with Ebola virus disease in West Africa, and then 9 months after her recovery developed a severe meningoencephalitis. that actually almost killed her. And evidence of Ebola virus was found in her CSF, although interestingly, nowhere else. The case of the American doctor, he also contracted Ebola virus disease in West Africa, and then 3.5 months after recovery, developed a severe uveitis. And actually, infectious Ebola virus was isolated from the aqueous humor of his eye in this case. And then the Congolese taxi driver was a young man who had actually been vaccinated against Ebola virus disease, developed Ebola virus disease anyways, recovered, and then 6 months later developed Ebola virus disease again. And unlike the other two cases, this person unfortunately died and led to 91 additional cases. So when you think about this kind of persistence, which is still rare, and recrudescence or reoccurrence of disease, which is especially rare, in the lab, you try and figure out how you might be able to understand these phenomena, especially when all of the animal models that we have are uniformly lethal. So one option, obviously, is to develop new models from scratch. And I think there's a lot of work, both in my lab and other labs here, to develop in vitro and in vivo models of persistence. But I think your other option for addressing this problem is just to pay attention to the outliers. Because occasionally, in our hands, we will have animals that survive, only then to develop disease and succumb, much later. And I say almost always, but actually in our hands, this always seems to occur after we had treated these animals with antibodies. And intriguingly, these 3 cases, human cases, were also treated with an antibody, a monoclonal antibody or an antibody product. And, I think the issue here is complex, and I don't want to conflate human Ebola virus disease with what we see in these animal models. But I do think what we're seeing in the animal models is reflective of some aspects of persistence in these human cases. And I think there's an argument to be made that while these antibodies are really good at treating acute Ebola virus disease, the combination of an antibody treatment plus Ebola virus in particular may predispose a certain number of people to developing persistence and then maybe disease recrudescence. And this is actually something that we're working on quite hard in the lab right now. We have a ferret model that recapitulates just this, persistence and disease recrudescence following monoclonal antibody treatment. But I don't want to talk about that much more because I'm slowly running out of time. So I want to move on from Ebola virus and just briefly mention the other 15 filoviruses, which are often called the neglected filoviruses. And I want to focus in again on those viruses that we know cause disease in humans. And there's still a problem. So if we go back to my bubble plot, we can see that Marburg virus, a close relative of Ebola virus, has caused 15 outbreaks over the past 60 years, including the very first recognized filovirus outbreak, which was occurred in Germany and what was then called Yugoslavia, following the importation of monkeys from Uganda. And Marburg virus is also responsible for the latest outbreak of filovirus disease, which just wrapped up this summer in Equatorial Guinea. Sudan virus has caused 8 outbreaks over about 50 years, including one that occurred at the same time as the first outbreak of Ebola virus disease. And in fact, these 2 outbreaks were thought to be caused by the same virus, although it was later determined to be a unique virus called Sudan. And Sudan virus recently reappeared after almost 10 years last year in Uganda to cause a rather large outbreak in that country. And then there have been a handful of outbreaks caused by other filoviruses, Raven, Bundibugyo, and Tai forest, although we really haven't seen anything of these viruses in the last 10 years. But the point I want to make is that we're still seeing outbreaks of Ebola viruses, of filoviruses, not just Ebola virus. And we're not really prepared for them in the sense that we have no vaccines or therapeutics licensed for these neglected filoviruses. We still have an incomplete understanding of virus pathogenesis and in human patients as well as in our animal models. And I think this is true also for Ebola virus, not just the neglected filoviruses. And we still don't really understand how these viruses exist in nature and spill over into humans. Of course, at the NML, we're actively working on developing and testing novel countermeasures with a particular focus on broadly cross-reactive vaccines and therapeutics. So therapeutics and vaccines that would be effective against a number of different filoviruses, not just one. As I alluded to, we're characterizing new animal models and hopefully using those to evaluate our countermeasures and understand pathogenesis. And in the last couple of minutes, I want to talk about a relatively recent project, which is really focused on understanding how these viruses persist in nature. So in this map of the world, you can see the countries highlighted in red are those countries that have had documented outbreaks of filovirus or have originated outbreaks of filoviruses. And just for context, in pink here are the countries to which filoviruses have been exported, so notably not Canada.
It's completely virtual.
And in purple are countries where we have found other filoviruses, primarily in bats, so Spain, Central Europe, and Hungary, and also China. And just to give you additional context, outlined in yellow is the range of the Pteropus genus of bats. So these are fruit bats, also called flying foxes, also called megabats. There are a number of different species, but they sort of occupy a really broad range. And right in the middle of this, excuse me, is the Institut Pasteur de Laos, a research lab in Laos, sponsored by the Institut Pasteur in France. And we recently embarked on a collaboration with this lab to investigate and respond to emerging viral pathogens, including filoviruses, but not just filoviruses, in an effort to better understand the reservoir hosts in which these viruses hide and perhaps identify in advance viruses with pandemic potential. So I'll leave it there with my thanks. I'm happy to answer questions at the end of this session. You can also email me, and if you're interested in some of the literature that I cited in this talk, just take a snap of this QR code. I'll leave it there. Thanks.
Thank you, Logan. We'll now switch gears to the Global Public Health Information Network, GFIN, an essential tool for early warning. And this is certainly a very important topic given what we've endured for the past 3 years. Cass Taylor will present, and she is a manager of the GFIN program. She is an epidemiologist with a long career in public health surveillance across multiple continents. So Cass, take it away.
Apologies, I'm just having some technical difficulties. I will be with you in just a second. Can you tell me when you can see my screen? Can you hear me?
Yep, your screen is on.
Oh, excellent. Okay, let me put this in the right mode here. Okay, start my video. Oh, you don't need to see me. Okay, anyway, so we're here to talk about GFIN, the Global Public Health Intelligence Network. So a quick overview. I'm going to tell you a little bit about what is event-based surveillance, what is GFIN, how GFIN works, what products we produce, who's using us, and our modernization initiative. So starting off, what is event-based surveillance? It's the organized collection, monitoring, assessment, and interpretation of information about events that may pose a potential risk to public health. So what's different here is this could be rumors, it could be ad hoc reports, it could be media reports, and it can be transmitted through formal or informal channels. Events included can be related to the occurrence of disease or potential exposure, so things like adulterated food or medicines. And it's quite different from the traditional kinds of surveillance, things like notifiable disease reporting. That's referred to as indicator-based surveillance, and the two of them together combine to contribute to the early warning function that's critical for early detection and prompt response. Event-based surveillance significantly increases the sensitivity of the surveillance system by collecting information before an event is detected and or reported through the conventional methods. It's also good to note that some countries that don't have a good solid public health system might not have a choice and may rely on things like low cost sources of unstructured information, such as internet news and online discussion sites. So EBS can be really useful in many, many different circumstances. So about GFIN. GFIN was one of the earliest of the computerized event-based surveillance systems established in 1997. And I'm sure you're all aware how much the internet has changed since 1997. It relies on publicly available information sources. GFIN is an all-hazard system, so though we most often report on infectious diseases, we're also looking out for environmental events, substance-related harms, chemical or nuclear events, among many other things, to provide early warning of potential public health threats. Though, of course, there's a great emphasis on early warning, say, to prevent the next pandemic. On a day-to-day basis, much of the information that we find and share through reporting is actually used for situational awareness. There are two critical components of GFIN. One is the analysts who are doing the monitoring. We monitor in 10 different languages: English, French, Spanish, Russian, Farsi, Arabic, Chinese, both traditional and simplified, Portuguese, and Hindi. And the second part is our information management platform that brings in the information and makes a first pass of the articles, weeding out duplications and irrelevant articles. So this slide gives you an overview of how it works. I'll gloss over the data collection a bit, other than to say our main source is through Factiva, which is a news aggregator owned by Dow Jones. We get over 33,000 titles from that. And that's brought into the system, but then you have to cut it down because you can't read 33,000 articles a day. We get about 7,000 that come in through the pre-processing. And from there, there's relevancy scoring. Actually, I will go to the next one because it gives you a little bit more. So in this part, we do deduplication. We gather the metadata, we tag things, we look at our taxonomy for the different languages. We categorize the different information coming in, putting tags on. We also use machine translation. So all the articles are translated into English for review, and the relevancy scoring also helps to bring down our noise ratio so that we are looking most at the most important articles. Every day, about 1,000 to 1,500 articles are entered into the platform, and from those, about 10 to 15 are put into our daily report. So our products, our main product is our daily reports, which is a summary of relevant public health articles from around the world on key topics. They are all open source, both official and unofficial. They're sent by email to our Canadian subscribers. It comes out at about 8:30 in the morning, and is often the first thing a lot of our colleagues at the Public Health Agency read. Our second most important product is our alerts, which are going to be renamed to early warning notifications. They're a copy of an article about a health event that meets certain criteria and may merit closer attention. They include a caveat about the confidence level because GFIN is early warning only. We don't do verification or risk assessment. We're passing the baton to our partners so that they can do the further analysis for preparedness and response. Those are also sent out by email from the GFIN system, and they go to both our international and Canadian users. And then there's our platform. So we're reporting on 10 to 15 articles in our daily report. An alert will involve one article, but you have at least 1,000 to 1,500 articles every day. So specialists that have a particular information need that want to do more specific searches can use the platform to query and find out more about the issue that they're looking for. We also create some special reports upon request. So alerts, as I said, they're only produced when somebody discovers something that they think ought to be reported upon, that is considered a threat that requires immediate response or immediate attention at the least. As you see, they don't actually get issued all that often. And this year so far, we've had 6. One of them on the death of cats from avian influenza. This points towards our all hazards in the sense that this is more of a One Health issue. we don't care that much about the cats ourselves, but cats have quite a bit of contact with humans. So we were concerned about this possibility of transmitting to humans. Another one was a mysterious disease whose symptoms resembled those of Ebola. So we did an alert on that. And then a child in Israel who was diagnosed with polio. Those are the sorts of things that we alert on. And we're actually more than daily reports and alerts. So there's the platform, as I said, that you can come and do queries on yourself. But there's also specific topics. We do special reports on request usually by our colleagues within the Public Health Agency, but sometimes from WHO or PAHO, they'll request a special report. Or if there's a mass gathering event, we'll do some surveillance around that. We did mass gathering surveillance for the COP15 in Montreal, for example, at the end of 2022. And during the pandemic, there were many special reports to do with COVID, things like public health measures that were being instituted in different countries. We were doing regular reports on that. We also have started doing reports for mobilization of FAC employees to other countries for response with the Global Outbreak and Response Network. So we had someone in Malawi. We were sending reports every day what was happening on the ground in Malawi, because news isn't always available for those who are mobilized. Next, so GFIN doesn't just serve the Canadian public, we serve the world. We have more than 1,700 subscribers around the world. About half of those are within Canada and the other half are international. We have over 1,000 recipients of the daily reports. Everybody, unless they opt out, receives alerts, and everybody has access to the platform who's eligible to receive GFIN. We only include people who are public health professionals in access to GFIN. That's partly because of our Factiva contract. We have a limited number of users for any of the sources because of copyright issues. We also provide a significant contribution to the WHO's event-based surveillance system, the Epidemic Intelligence from Open Sources, EIOS. So even people who've never actually touched the GFIN system themselves may actually be using some of our information. So you may be aware, you may not, there was some significant criticism and attention paid to GFIN early in the pandemic in the media. This resulted in an independent panel review of the system, and it was very thoughtfully done and we were given some very useful recommendations for the modernization and improvement of GFIN. The recommendations have broken down into 4 different areas, one being the clear mandate and strong linkages to fact surveillance and risk assessment. One being the state-of-the-art system. We needed to modernize our IT system because IT never stops changing. Then increasing the strength of our team, so creating better recruitment and retention and development plans for our staff, and then strategic partnerships and connections. So establishing more collaborations with GFIN for external partners and within FACTS so that our signals are getting into the hands of those who can use them. So that's that. If you have any questions, please let me know.
Thank you very much. Stay on. We'll have the question and answer session at the end of this block of 3. And now I'd like to introduce Chan Mangat, who is a research scientist and head of the National Microbiology Laboratory's Wastewater Surveillance Unit. Dr. Mangat currently surveys for respiratory viruses, monkeypox, and antimicrobial resistant microorganisms in Canada's wastewater to better understand the burden and trajectory of disease. He'll be speaking today about Canada's approach to monitoring infectious diseases through wastewater surveillance. Chad, you're on.
So I'm trying to get this screen sharing all working. Hopefully you can all see my slides. Yeah, okay. Okay, so thanks to the organizers for inviting me to really give the dime tour of what's happening here at NMLB and across the country with regards to wastewater surveillance. I'm just one part of the program here on the left, enjoying Winnipeg's wonderful summer. My colleagues are Dr. Crystal Landgraf, who really apply wastewater surveillance in the genomic context, and Dr. David Champerdon, who looks at our data and tries to understand the trajectory of signals through their risk models, and Dr. Michael Becker, who's serves under Dr. Paul Sandstrom, who many of you I'm sure know, who's extended our capabilities to First Nations. And I know conflicts to disclose. So, first slide, this is a wastewater treatment facility. It's the opportunity that we are trying to leverage. All of the waste in certain communities boils down to facilities like this. And the opportunity presented is to get sort of community-wide surveillance of infectious diseases. So just an overview or objectives are to go over the benefits and the application of wastewater surveillance for public health, what's the structure of our program, and some data around SARS-CoV-2 and other disease indicators that we developed. Okay, so what are the benefits? Well, you alluded to earlier, we can get trends and in some cases early warning of disease incidents, and we can do that in an equitable fashion. So it doesn't matter if you're able to present to the healthcare machinery to get counted and tested. So long as you can, use the facilities, we can track you and have your signal be part of a larger disease management framework. This sort of application of surveillance is not new. It's been well established for polio since about the 40s, and in certain instances for enteric diseases, and in a research context for AMR. There's been a long-standing, let's say 6 years, surveillance program for illicit drug use that was led by Statistics Canada. So really the thing that we sell the program on is that from a single sample, there's the potential for many answers and applications. So how do we rationalize what the benefits are for wastewater surveillance? Well, one of the benefits is that you can sample at multiple scales. So just to go from the left of this slide, looking at the institutional level, all the way to a whole metropolis, and down to the, let's say, intermediate neighborhood level, we can scale at all of those sampling points and really get pointed questions that is fit for purpose. So on the left, if you're doing something like institutional testing, it's highly specific. It's not representative of the entire community, but it's a very dynamic signal. And what that allows you to do typically is to organize direct action because of the signal's specificity, and that's how it's typically been applied here in Canada. So in smaller catchments, for instance, in the high north, there's been, for instance, the allocation of resources based on these sorts of signals. Public health measures have been instituted based on these signals. At the larger sampling scale, it's not as representative, and it's sorry, there's a bit of a typo there, but it's a less dynamic signal. And so it really just serves to be one of the many signals that we use for the management of disease, and serves a more of a public health intelligence role. Used recently for the domestic detection of poliovirus in the context of an international outbreak by scientists in the enterovirus section here at NML. So what are the some of the benefits? I think just in a pointed way, the traditional clinical surveillance model requires that an infected individual, with symptoms becomes motivated to interact with the healthcare system, then their case becomes counted. But in wastewater surveillance, all that's required is a interaction with the sewage collection system. And so some of the benefits are that we get a population burden of disease, and that burden is independent of symptoms. So how are we structured right now? Close this. So on the left is a map of Canada. The red dots indicate communities for which wastewater comes to NMLB for testing. In the broader context, many of the provinces and territories have, either been engaged in this activity since the beginning of the pandemic or taken it up over the course of the pandemic. Certainly significant areas of expertise, let's say in BC, Alberta, and Ontario, and a tremendous whole of system application in Quebec. A big part of the surveillance network is maintained by a good deal of academic partners, particularly in Ontario. And I should again acknowledge that FACTS program was really seeded by the illicit drug surveillance that was initiated by Statistics Canada, really motivated by the legalization of cannabis and to understand some of the impacts. So where does our data go? That's on the right side. So significantly, it goes to 3 different places. So publicly, there's a couple of dashboards where the signal intensity and its trajectory, so that's by qPCR, is sent to our InfoBase dashboard. To the NCCID a website, you can get an idea of the genomics or the balance of lineages in communities, and also some of the disease modeling. We send also to the site level to our stakeholders standardized reports that outline many of the same things. And then internally, many things go back and forth between different offices here, but I think most significantly, it would be RT estimations and case projections by our colleague, Dr. David Chevrenon. So just to have a look at some of the signals. So on the left is some of the data from our group looking at the SARS-CoV-2 signal in purple against hospitalizations in one city. This signal's well geolocated, so those cases are specific to the signal, and we can see at least for hospitalizations for this point in the pandemic, a good degree of forewarning and tracking of hospitalizations for both of these sewer sheds. Our colleagues at the University of Waterloo and Mark Servos's group has elaborated this really over a significant part of the pandemic, and shown that a really good correspondence between the SARS-CoV-2 signal in red and the COVID-19 cases in blue for 2 of their catchments. And one of the benefits, I think, of this methodology is really outlined here, where we do see a one-to-one correspondence, and then we see a divergence, right? And this divergence is explained really by a change in our testing approach. And so I think what this highlights is that wastewater surveillance really gets at the burden of disease within communities. And what I think is that ultimately, if we take a long view of things, hopefully wastewater can be a way to evaluate, let's say, our public health surveillance sensitivity, our infection control measures, really the equity of application of healthcare, across the country. So again, from David Champernon's group, how they're using it really is to augment a traditional SIR model, a compartment model of disease, by trying to get a more accurate understanding of the replication number. And so really what he takes is, our data from wastewater RNA concentrations. He's got a model for shedding, and then I just call it a machine, and he can crank out these forecasts. So on the right is an example of that data. At the bottom is the wastewater trace, very similar to what I showed you before. At the top is the clinical signal. And so in blue is what is implicated by the wastewater signal as far as what's happening in the community, and then projections by the clinical signal are shown in the chat. And so, I think as far as one of the questions goes, one of the biggest limitations from his perspective is an understanding of precise shedding. I know there's a lot of clinicians on the line today. If there's one message I want to get to you, if you are doing things like qPCR of clinical samples, if you could report precise quantitation that relates back to either a volume or a mass, that would help disease modelers, in their application of this technology, not only for SARS, but for other things more broadly. This is work out of Crystal Landgraf's group, where she's tracking the transition between the Delta and Omicron variants. So it's possible to go into wastewater, get an understanding of the lineages that are circulating. This follows the clinical signal quite well. She's led the way on applying this to an airport monitoring program so that we can get a sense of what's coming into the country. That's a partnership with some of our provinces, where we've applied it to airports with significant international arrivals. And she did lead a tremendous airplane monitoring program in response to the loosening of public health measures in China to understand what might be coming into the country, during that period. Here's some work from Michael Becker's group. A big gap is applying this technology to remote communities, to First Nations communities. It's a logistical problem. It's hard to get samples from the far reaches of this country, to a central lab for testing. So what he's done is repurposed a point-of-care test, the GeneXpert platform, that can be used in field laboratories. And we're showing one example here that was self-reported by a community in northern Quebec. So they repurposed a drinking water testing facility that wasn't being used, and they have pretty much real-time understanding of SARS-CoV-2 prevalence in their communities. The way the cartridges work, they get an understanding of flu A and B and RSV as well. Just some of the data at the bottom. The top is a clinical trace. I think this was Yukon, and the top is the wastewater signal, and the bottom is the clinical trace. And in this instance, I think this was year one of the pandemic. We had a significant 4-1. So what are some of the extensions? So in our lab, we've now expanded to influenza A and B, RSV A and B. Here's a look at one locale, the influenza A wastewater signal against the influenza A cases at actually the provincial level. So this is a city's response in blue and the province's surveillance in orange. And we can see weak signals that foretell the coming influenza A season. We've seen a fairly good correspondence across several provinces when we look at clinical positivities at the provincial level against the wastewater concentration. Where are we taking a lot of this? So my interests are in antimicrobial resistance. There's been a significant gap in community surveillance, and we think that wastewater can fill that gap. And there's certainly interest from the AMR task force, here at FAC, to look to monitor antimicrobial use. So that's looking at chemical indicators. Okay, so I'll just quickly go over this, but one of the consequences of our work was to develop a significant data model. Everybody's hot on One Health for decades, but we don't actually have a way to curate, to control all of the different data streams that you would need for a fulsome application of our resources in a One Health framework. So that's looking across multiple compartments. They have all their own needs. And so just because, in wastewater, we have to have an understanding of the collection structure, the city's structure, demographics, and our signal against clinical signals, we think that this really sets the stage for widespread application of One Health, not only for SARS, but for many clinical problems. So I'll just conclude with where we're going. So I didn't get to go into Mpox, but we've seen pretty good sensitivity, let's say, with applying this to Mpox. And research programs are underway for Enterix, in Crystal's group, AMR in my group, and Michael's had some good success with some STIs. I did talk about the recent application to a domestic detection of poliovirus. Really, the work I think that's coming is to develop baselines for a lot of these pathogens, multiple years of surveillance to inform some of the use cases, and then hopefully have those feed risk models so that we can identify significant, let's say, control points. And there's a good amount of work, developing novel detection platforms. So it's tough to work in a central lab model and have really good representativity across the country. So we need new solutions, things like, let's say, robotic detection platforms that could be in the field and send you data in real time. And there's still a large challenge ahead in, let's say, the standardization of approaches and getting some of this technology down to the PT. And that's it for me. Thanks.
Thank you very much. 3 outstanding presentations. We'll open things up for questions. So this is a Logan question. Have we had versions of Ebola in Canada or Manitoba?
So no, thankfully, we have not ever recorded a case of filovirus disease in Canada or Manitoba, but I think that doesn't mean that it can't or won't happen in the future. And as I showed in that map towards the end of my talk, filovirus cases have been exported multiple times outside of Africa where they occur, including to the United States and other Western nations. So it's not out of the realm of possibility, certainly when the outbreaks get large enough, but even if they go undetected, for something to show up on our doorsteps.
Excellent. Okay, there's a question for Chand. If we can monitor and survey the prevalence of diseases in sewage, what happens to the communities who don't receive or have issues getting clean water to their communities? Would the prevalence of illness be higher in those communities?
I certainly project that you would. I mean, like, water surveillance isn't a part of what we do, but certainly for remote communities and First Nations communities, it's top of mind, right? So when we come to them with our program, the first thing they ask is, can you tell us what's the risk of looking at, for instance, alternative water supplies, right? And natural, drinking water supplies, rivers and lakes that are around them. Certainly that's something that can be monitored, the risk there. The issue is scale, right? Like, how do you scale that to all of the communities that want it? And so that's where some of the thinking is around getting some of the testing in the hands of communities, so that they can really be advocates for themselves. Yeah.
Excellent. And one for Cass, and I'll read it exactly as written. There is a definite increase of COVID in Canada. With your ability to, I guess, monitor, or with your surveillance activities, is there a similar increase being observed through the rest of the world? And if you are, is it worse than Canada? Because we're in reality, we're not a major destination, and everything eventually ends up here. But when can we expect it, based upon what you're seeing, if you're seeing any difference?
I don't think I can really answer that. And not because I don't want to, but because we are looking at open sources, right? So we're seeing what people are reporting in the media. So there may or may not be reports. There's certainly reports of COVID in different media around the world. Whether it's worse than Canada, I couldn't really tell you. And I have to admit, we've been putting a lot more emphasis on keeping track of the avian influenza pandemic that's happening all around the world in birds and other animals. So we've been publishing a lot more of those than we have been of COVID lately. I think you'd have to go to the COVID specialist for the interpretation of the signals that are seen.
Excellent, thank you. And then one last one, and we might just call it lunch. Is wastewater being monitored in northern Manitoba and fly-in communities?
We do have monitoring Flin Flon in Thompson. That data isn't made public, and that's at the behest of the communities, but no flying communities at this point. Yeah.
So the question for you, Chand, if you had all of the money that Mr. Trudeau could give you, how would you roll out a national wastewater surveillance program to include all of our communities? or would you use sentinel communities? Because
Yeah.
prior to the pandemic, we never thought of wastewater as a warning of what lay ahead.
Well, I mean, I think the first thing I need to acknowledge is that there was a lot of profile brought to this area because of COVID, right? And I always say that we're upside down and that we need to validate some of our approaches, right, before we start to spend a ton of money, developing surveillance sites across the country. Some of the things we do know is that urban sites are more or less equivalent. We've seen that in an AMR, but rural sites are unique, right? They're more isolated. Diseases pop up at a different cadence over there, but that presents a big problem in how do you apply those resources, because it's a tough thing to do. It's a uniquely Canadian problem. And I mean, one of the tremendous research projects that I've heard of is that, prophylactic therapy for RSV is being, at least in a health economics model, being trialed to see if wastewater guided its delivery, would you get any savings there? And what I'm hearing is that you would, right? And so I think we need more use cases like that to define what the network should look like. And then we have to understand what's happening at the provincial level to see where the feds can either fill gaps, or serve programs for their own needs. Hopefully that is.
Thank you. Since I don't see any other questions, and since I can't think of any others, I think we have all found 10 minutes in the day that we didn't otherwise know we had. So we'll see you all back at 12:45. Now, for those who registered online with the Department of Continuing Professional Development, please ensure that you've checked in and recorded your attendance in Slido. This will allow you to download your certificate and claim credits for attending today's event. So we'll see you back at 12:45. Thank you. So here we are. I hope you get the sense that there are themes with each block of 3 speakers. We've tried to group the topics as closely together as possible, or topics that are closely connected. So the next 3 topics have sort of a public health feel to them. Our first topic is the major accomplishments of public health over time. And Tim Hilderman is our speaker. Tim is a specialist in public health and preventative medicine with a special interest or a specific interest in vaccines and drinking water. Tim is no stranger to the Bug Day stage or screen, as it may be. Tim has joined us numerous times, and today's topic will be a very important one, because we can do heroic things, but what do we do for the community as a whole? Tim, your thoughts?
Excellent. Thanks, John. I'll just get my screen up here. Okay, it looks like we're good. Can you hear me okay, John?
Perfect.
All right, thank you. Well, thanks very much. Good afternoon, Bug Day. Thanks for coming back from lunch. I kind of feel like I'm the warm-up act for Dr. Rusin, but I think we'll get through this, and I think it'll be really interesting and a lot of fun. You know, when Dr. Ebel first suggested this as a topic, I thought this was going to be simple. But when I dug in, I realized this is actually quite complex, and it really depends when we're looking at the major accomplishments of public health. You know, what time frame are we looking at? Are we talking about the 20th century, the 21st century? What populations are we looking at globally, nationally, locally? And you know, a lot of what we come up with on this list is kind of dependent on the lens that we're going to take. So the other thing I think we have to address right off out of the gate here is that the major accomplishments of public health don't benefit everybody equally, even within a population. So I think that's really something we have to keep in mind when we go through this exercise. Okay, I'm trying to advance this now. And it isn't, oh, there we go. So these are the objectives. I don't have to spend any time on those. What is public health really? So who and what is public health? I love this definition from the Public Health Agency of Canada. Public health can be defined as the organized efforts of society to keep people healthy and prevent injury, illness, and premature death. It's a combination of programs, services, and policies that protect and promote the health of all Canadians. This moves beyond the traditional definition of public health, sort of bricks and mortar public health, the nurses, the epidemiologists, public health inspectors, public health physicians, policy analysts, et cetera, and it more accurately reflects the complexities of public health. So what is it that we're trying to accomplish? What do we mean by keeping people healthy? Go back to that World Health Organization definition from the 1940s. In 1948, according to the World Health Organization, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And social well-being is an important aspect of this definition that we don't always, doesn't always occur to us when we're thinking about our health. So many criticize this definition, to be fair. It gets vague, it's frustrating. And for the purpose of this discussion today, it's true that most of the things we're going to talk about as far as accomplishments can be measured in terms of the presence or absence of disease. But I believe they contribute significantly to physical, mental, and social well-being as well. So what are the determinants of health? Having defined what we say public health is and what we're trying to achieve in terms of keeping people healthy, I'd be remiss if I didn't touch on the broad range of personal, social, economic, and environmental factors that determine individual and population health. Familiar, but they bear repeating. Income and social status, employment and working conditions, education literacy, childhood experiences, physical environments, social support and coping skills, healthy behaviors, access to health services, biology and genetic endowment, gender, culture, race, and racism. So this is what makes us healthy as a population. Okay, now normally, as John knows, I have some audience participation elements to this discussion. And when I realized we were doing this on Zoom today, I realized that the typical running up and down the stairs throwing out Halloween treats wasn't going to work. But I do have Skittles, and our communicable disease control team is just down the hall. Give me 5 seconds, John. It won't take more than that. I'm just going to send some Skittles out. Hold on. Got some Skittles. Skittles. Thanks, everybody. Skittles. All right.
Thanks, Tim.
All right, thanks. Okay. So I think I just pulled a hamstring there, and man, do I ever have to up the cardio. But seriously, where we're going here is I chose to look at public health accomplishments over the last 100 years or so, and I took that North American perspective and used one of my favorite texts by Dr. Q Young, his population health concepts and methods, plus some CDC articles that's really looking at this as a way of kind of generating some ideas. Immunization and immunization programs, fundamental public health. Vaccines have played a major role in eradicating smallpox, elimination of polio in the Americas, control of measles, rubella, tetanus, diphtheria, Haemophilus influenza type B, invasive meningococcal disease, Hep B. Public health-led school-based immunization programs are a cornerstone of Manitoba's childhood immunization program, providing an opportunity for catch-up as well as new program implementations, like, say, the HPV program. And a prominent infectious disease physician from the Mayo Clinic called me up a couple of years ago, right actually when we were launching our HPV program at schools. Could not believe we were able to achieve this, you know, with the education system, the health system, providers, the vaccine supply. She actually asked to fly up and talk with us, and he was envious of our program. And I think that made me really quite, it made me feel proud, and that's something I don't think we often feel in public health a lot. But I'm still in awe of this program today. All right, motor vehicle safety. So decrease in motor vehicle related deaths due to engineering improvements in vehicles, like think airbags, highways, barriers, change in personal behaviors, increased use of seatbelts, decrease in drinking and driving, all combined to this dramatic decrease. In 1923, when we first started measuring deaths per mile driven, 1923, 18.65 deaths per 100 million miles driven. In 2021, that drops to 1.50 deaths per 100 million miles driven. So that's a 92% reduction, due in large part to a lot of these safety innovations, as well, of course, to improved emergency medical and trauma care. Safer workplaces. So one of these achievements, major achievements, control of pneumoconiosis through dust suppression and PPE, control of silicosis, reduction in lead exposures, an overall reduction in workplace fatalities, do a lot of these workplace safety and health safety measures, prevention. Although it's still unacceptably high, in 1921, we had about 70 per 100,000 population workplace deaths annually. 2019, that's dropped to 50 per 100,000. As I say, it's still unacceptably high, but a significant change. Improved sanitation, this is one of my favorites. Waterborne typhoid and cholera outbreaks were a regular occurrence in urban areas in the mid to late 19th century. Chlorination of public water systems began in England in 1905 in response to waterborne typhoid fever epidemics. In Canada, chlorination of drinking water began in 1917. As far as wastewater sewage treatment goes, the removal, what we're doing here is removal of impurities from waste before they hit the aquifer, before they hit the rivers, the lakes, etc. This really came of age in the late 19th century, early 20th century. You have construction of these centralized sewage treatment plants. Instead of discharging sewage just into the closest body of water, okay, which was the previous sort of 100 years or actually thousands of years, now we're using physical, biological, and chemical processes to remove some, if not all, of the pollutants. And we had a reminder here in Canada, you know, in 2000, their Walkerton tragedy in Walkerton, Ontario, where we had several thousand people that became ill, 60 to 70 hospitalizations and 7 deaths, when we had a failure of the sanitation that allowed unchlorinated water that had been contaminated by animal waste during a heavy storm event to be circulated through the community of Walkerton, causing devastating illness. And a reminder that even today, these systems, how important these systems are, and that what the consequences of them not being monitored and failure. So, oh yeah, risk factor modification. So here we're getting into that public health function of health promotion, disease prevention. And of course, public health doesn't do this alone. There's providers and nurses, docs, and pharmacists, all members of the healthcare team that participate in modifying risk factors, but recognizing the importance of risk factor modification for the prevention of chronic disease. Smoking cessation, blood pressure control, lipid management, diet, exercise. It's interesting, in 2000, there were, the year 2000, 2001, 217,000 Canadians, roughly, were diagnosed new onset coronary artery disease. In 2017, 2018, that number dropped to 162,000. So from 217,000 to 162,000 against the backdrop of increasing population. So really significant gains here. Clearly lots more work to do, but significant gains. Deaths per 100,000 with coronary artery disease dropped 21% in the period of time. Moving along, safer and healthier foods. More than 100 years of legislation, inspection, and enforcement led to huge decreases in microbial contamination of food, while increased nutritional content has led to virtual elimination of rickets due to vitamin D deficiency, goiter, iodine deficiency, pellagra, vitamin B deficiency. Maternal and child health, better hygiene and nutrition, antibiotics, better access to care, advances in neonatal and maternal medicine. You get your infant mortality rate in Canada dropping from 41.3 per thousand live births in 1950 to 3.9 per thousand live births in 2023. Family planning is the cornerstone of our public health programs. Rebecca Allen in 2007 in the Journal of Obstetrics and Gynecology wrote, family planning plays a pivotal role in population growth, poverty reduction, human development. Robust family planning services improve maternal and infant survival, nutrition, educational attainment, and socioeconomic status. Recent data of the United States, access to contraception leads to increased college enrollment rates for women, increased hourly and annual income, increased workforce participation, and decreased the poverty rate overall. I like this one because it's a smiling tooth. So in 1945, Grand Rapids, Michigan became the first community in the world to fluoridate water. Drinking fluoridated water reduces cavities by 25% in children and adults. Just think about what that means at the population level. Finally, tobacco control, changes in social norms. The Canadian Community Health Survey in 2020, 13% of Canadians aged 50 and older currently smoke. In 1950, and I still shake my head when I think about this. 68.9% of males and 40% of females over the age of 20 regularly smoke cigarettes. So Canada's tobacco strategy, monitoring tobacco use and prevention policies, protecting people from tobacco smoke, offering to help people to help quit, warning about the dangers, enforcing bans and tobacco advertising, promotion, sponsorship, as well as raising taxes, all play a role in driving this number down and keeping this number low. So that's quick. I think I'm under my time here, Dr. Emble. Thanks again to all for allowing me to spend some time with you this afternoon. And while I think this list is defensible, it's clearly incomplete, and I look forward to your suggested additions or deletions, and not to mention the free hugs. Thanks, everybody.
Thank you very much, Tim. So don't go away. We'll have you back in about half an hour to do the questions and answers. So now, Brent Roussin is our Chief Public Health Medical Officer, and he's a specialist in public health and preventative medicine. So if we don't learn from an event, we clearly failed as humans. And what Brent is going to talk to us today is, what did we learn, or what did COVID teach us? And hopefully we learned something, because I don't think we could ever do what we did with COVID ever again. So Brent, your thoughts?
Good afternoon. Yeah, thanks for having me back at Bug Day, everyone. And I'll just share my screen here. Is that coming across okay?
Not yet.
Okay. It looks like my face is frozen there.
Perfect.
There we go. Okay, perfect. So just go into this mode here. So again, thanks for having me back here and talk about what COVID taught us. But again, no way of framing this that we're done learning. I think we'll be learning lessons from the pandemic and our pandemic response for years to come. But we have learned a lot, and we'll continue to learn. So I have no conflicts to declare. And again, just like the pandemic is a very broad impact on society. Many of the lessons learned are very broad. So I'm going to try to touch on a number of issues in a very short period of time. And we'll look at that role of public health. So again, just like other public health emergencies, public health was brought to the forefront. But the longer that the crisis remained in effect, the more and more blurred the role of public health became over time. One of the highlights of the pandemic is certainly the learning the effectiveness and the safety profile of mRNA vaccines, which are the next frontier of vaccines. And moving forward, we look forward to seeing what can be accomplished in that realm. We saw a tremendous burden on the healthcare system, a lot of it driven by pre-existing health inequities. And then we see now, and always knew, there were going to be these indirect health effects, which are having a tremendous burden on society, on our response to the pandemic. One such thing is the proliferation of misinformation and disinformation, and all of the divide that has caused, and all of the negative impacts on public health practice and in healthcare practice. So if we look at when we first became aware of the novel coronavirus, early January of 2020, we struck the Special Advisory Committee of the Council of Chief Medical Officers of Health to begin planning for a pandemic response for what was, likely to become a pandemic. We knew at that time that these population level events, there's much more to them than the pathogen itself. And so when we're setting goals, we knew at that time we needed to set the goal of reducing severe outcomes and death from the virus, of course, but we needed to keep in mind we needed to minimize societal disruption as much as we could, because those have health impacts as well. And then we're looking at protecting the overall health of the population. And so when doing so, we always had to stick to the least restrictive means, which is not only part of our ethical framework, but it's in the Public Health Act, it's in the Charter of Rights. So we knew there was dramatic impacts from these population level interventions, and we needed to take those in consideration as we respond. So the Public Health Physicians of Canada released a report, a very good read on the public health lessons learned and they had a number of points that they highlighted, and I'll highlight a few of them here. Of course, we saw that public health systems were chronically underfunded, which overwhelmed the public health response early on in the pandemic. We had to prioritize response to the pandemic, which left other public health interventions delayed, and we're starting to see the effects of that. They mentioned defining the role of public health. You know, the public health physician is really an expert in integrating medical information with broader societal impacts, right, which what you need at population level events. We can't plan a pandemic looking only at viral transmission dynamics. There's a much broader impact on health, and our interventions impact health. So they saw in this report, they commented on that there was many times in the pandemic where expertise was attributed to non-public health physicians when speaking about population level events. And they comment that that's often led to misguided advocacy, which sometimes impairs public health's ability to message. We saw gaps in our ability to surveil disease, both provincially and federally, which again, many lessons learned on trying to fill those gaps, trying to have better national connection on reporting. And then they mentioned reformer, and really they're mentioning here is the underlying determinants of health. We saw the negative impacts based on poverty, racism, especially amongst our Indigenous Canadians, and really to address further pandemics, we need to address these underlying determinants. The effectiveness and the safety profile of mRNA vaccines were really a breakthrough of the pandemic. It is really the next frontier of vaccine technology, and as Tim mentioned, it's one of the greatest impacts on public health, and I think this is the next level of that. And then looking for evidence to show the effectiveness. I mean, the hardest thing is just trying to find which study to show in in such a short presentation. This is a relatively new study, a very well designed test negative design study, included Manitoba data. This graph is a pooled result. If we look at the mRNA vaccines here, 112 days after the second mRNA dose showed a 98% reduction of severe outcomes, hospitalization, death, with a very tight confidence interval. So, you know, the effectiveness of these, certainly the COVID mRNA vaccines were clear, and we can see that when we're looking at our epi curve. I'll show that a bit later. And then excellent safety profile. You know, you look at this, 99 million COVID doses administered in Canada today. And it's just so remarkable, and the post-market information you get from this many doses administered in such a short period of time is quite remarkable. Certainly saw adverse events like we would expect. 57,000 adverse reported events. These are mostly local reactions, mild events, but there were over 11,000 serious events. And obviously, to those individuals and their families, these are quite significant. But when we look at a population level, we're speaking about less than 1/100% of these severe outcomes. So that safety profile is certainly demonstrated. We all heard of the reported cases of myocarditis and pericarditis. Again, almost all of these have full recovery. And then we know, of course, COVID infection itself has a greater degree of myocarditis and pericarditis. We had to ramp up vaccine mass clinics quite quickly, and by operating those for years, we've learned a lot, which we're taking away to improve a lot of our efficiencies. So things like inventory management and shipping have improved much of our vaccine program. The use of non-traditional immunizers, dramatically increased our capacity to provide immunizations, and many analogies to these we're going to be carrying forward. For instance, responding to our STBBI epidemic. Other things there, scheduling, using the call center. All these, again, we were able to perfect those over the years of the pandemic, and really going to lean a lot of our response in public health going forward. We look at this truncated epi curve of our pandemic here in Manitoba. on 2020 here, we see this is actually our second wave, and then in 2021, this is our alpha wave here, and so you can see that dramatic decline in the deaths after we started rolling out the vaccines in early 2021. And if we have a chart that is plotted against cases, you can see even more dramatic event with that, and that's carried on into the Delta wave, which comes later that summer, which truly was the pandemic of the unvaccinated at that time. If you recall, vaccinated individuals were essentially living restriction free, and we had very low case numbers. And unfortunately, anyone in ICU at that time was unvaccinated. So it was a very troubling time to see the truly unnecessary severe outcomes during that wave. What we also see here is that the dramatic impact on the healthcare system on all of these waves. Here, ICU admissions, hospitalizations, a lot of delayed care in things other than responding to COVID. Much overwhelmed staff, combine that with ill staff, as we're seeing a lot of transmission in the community, and we all know during the alpha wave here in 2021, we truly overwhelmed the healthcare system. We had 57 ICU clients that needed to be transferred out of province to receive care. So we see that the already strained healthcare system received a burden that it's really overwhelmed it. We know health inequities driving much of the ill health period in Manitoba, but certainly drove a lot of the cases, hospitalization, and ICU admissions in Manitoba. And a lot of this information it comes from Dr. Marsha Anderson's work with the REI team, which is still ongoing. It's still going to be bringing us a lot of great information on how to respond, but we could really see that impact on BIPOC Manitobans. We saw the 10-year gap in ICU admissions really drove changes in our vaccine response. But again, these pre-existing social inequities are really driving ill health in Manitoba, and certainly saw it in the pandemic. But you can list almost any health outcome and see much the same pattern. And then looking at the indirect health effects of our non-pharmaceutical interventions, which are quite vast, right? So these are certainly unintentional impacts, but not unknown, right? We knew from the beginning that we couldn't focus only on viral transmission dynamics because we knew doing so also impacts health in other areas. So we saw delayed care due to hospitals being overwhelmed by the virus. We saw avoided care, possibly due to the non-pharmaceutical interventions, but we see those social and economic impacts on health, and they can be quite significant, and we're seeing more and more evidence to that. And again, we're going to see what the long-term effects are, over time as we learn more and more. So Statistics Canada released a report there March 22nd, looking at a lot of the impacts overall of the pandemic. And you can see things like self-reported mental health had declined quite significantly. There certainly were excess deaths, especially early on in the pandemic, where we saw many deaths in personal care homes, which was really one of the largest tragedies of the pandemic. But as we see, as time went on with our response, we started seeing excess deaths in younger Canadians not related to COVID-19, which is also a tragedy. If we look at this from the same report here, you look at those younger age groups, the excess death that are unrelated to COVID, and so things like unintentional poisoning, overdose led to much of this. But again, no less tragic than the direct effects of the virus, and we'll be seeing more and more evidence of this as time goes on. And then just a few examples of some of these impacts of our non-pharmaceutical interventions, right? Exacerbation of intimate partner violence. Again, quite tragic. Some of the most at-risk individuals having such negative outcomes. This was a recent publication in the CMAJ. Again, increase reports of self-harm in children and adolescents, which you know is tragic, and this we don't know what the long-term effects of those of taking children out of school for the better part of 2 years and seeing this. So these are no less tragic than the effects of the virus itself. And so we saw a proliferation of misinformation and disinformation. You know, I think this certainly pre-existed the pandemic, but it certainly grew quite a bit during the pandemic, having a much negative impact on messaging, on you know, the work of public health and the healthcare system. It drove wedges in society, between colleagues, even within families. We've heard stories of this, and so it's really hard to measure. But the Council of Canadian Academies released this report. They performed surveys as well as modeling, and you can see here that if those Canadians that reported COVID-19 as a hoax were vaccinated, we'd see over 2 million more vaccines administered, tens of thousands less hospitalizations, thousands fewer deaths, $300 million saved. So quite a significant impact, and you still see this. You still see the remnants of this, and this is going to be ongoing. So as a healthcare system, we really need to come together to battle this misinformation and disinformation era. So really, to summarize, we saw the effects of the chronic underfunding of public health and the healthcare system. You know, both got overwhelmed when faced with a crisis, and will take some time to recover from that. We need to continue to define that role of public health and differentiate, you know, public health's role compared to the acute care system to ensure messaging is consistent, because messaging at that population level, especially during a crisis, dissension often causes, you know, a lack of that message getting out and impairs public health's ability to function. mRNAs, we're at the new frontier of vaccines. Had the chance to demonstrate their effectiveness and safety, and looking forward to the many new mRNA vaccines that are in the pipeline right now. We discussed the significant direct and indirect health effects, and then addressing those health inequities. You know, if we really want to decrease the burden on the healthcare system, if we really want to prepare for the next pandemic, we need to address those issues such as poverty, racism, homelessness. Or else we're going to continue to find ourselves right back to where we are. So thanks again, everyone, and happy to answer some questions later.
Thank you very much, Brett. That's outstanding. So we'll now switch gears and turn to Dr. Ayush Kumar, who is a research scientist at the University of Manitoba, who has a specific interest in antimicrobial resistance. Ayush has spoken at Bug Day in the past, and it was outstanding. So we expect nothing less than outstanding today. Ayush, the floor is yours.
Thank you, Dr. Embel. Thank you very much for the invitation. I'm just going to start sharing my slide. And hopefully you see the actual presentation and not the notes page. Dr. Embel, can you confirm what you're seeing right now?
We have a presentation, then we also have the notes. So
okay, I will just change the settings here. Okay, maybe this is better.
Yes.
Okay, perfect. Okay, well, thanks again for the invitation. It's great to be here today. And as Dr. Embel said, my interests are antimicrobial resistance bacteria. So I'm going to switch gears a little bit, but there will be some similarities to the talks that you've heard earlier in the session today. So I'll be talking about antimicrobial household products and good and bad and unknown things about them. So I won't spend too much time on this slide because Dr. Hilderman actually did a great job summarizing how things have changed with the discovery of antibiotics and use of vaccines. So what I'm showing here is if this is data from Boston comparing causes of mortality over 100 years. So in 1900s, you'd see that most of the deaths were caused by infectious diseases, versus in 21st century, we don't really see that. And this is for our, a town in first world country. Things are still similar to this in global south, but the some of the most common things that have sort of led to this change are vaccination, antibiotics. We of course have access to clean drinking water, but this sort of gives an idea of how much of an impact medical advancements like vaccines and antibiotics have played in our lives. Now, with antibiotics, they've been, or they were classified, called as wonder drugs. But the problem with antibiotics is that the more we use them, the more ineffective they become. And here what I'm showing is these colors basically represent different classes of antibiotics. And 1928 is when penicillin was first reported. And you can see that right after their clinical use, resistance becomes quite evident as well. So as we use more and more of these antibiotics, we start seeing resistance in bacteria, and these antibiotics become ineffective. And we are going through a period which is now referred to as antibiotic discovery void. So in the last 30 years or so, we haven't really been able to discover any new classes of antibiotics, particularly against gram-negative bacteria. So when it comes to AMR, we just heard about just some wonderful data that Dr. Rosen discussed about COVID, but AMR is a silent pandemic that's ongoing. Recent data shows that almost 5 million deaths per year can be associated with AMR in bacteria, and about 1.27 million deaths. Of 1.27 million of those deaths are directly attributable to AMR. So there is concern. Antimicrobial resistance is now leading cause of death worldwide. Millions of people dying, and then health inequities play a big role here, especially the impact on global south. So in global south, the impact of resistance is manyfold higher than what we see here. But we also know that infectious diseases, they don't really follow international borders. This is truly a global problem. So what can be done to address antimicrobial resistance? WHO has come up with a 6-point plan, asking countries to come up with a national plan for management of antimicrobial resistance, increasing surveillance programs. So something that we heard a little bit, not from AMR side of things, but from Dr. Chan Mangat before lunch, how surveillance can be helpful, looking at access, providing access to people around the world, regulating and promoting rational use of medicines, antibiotics across different sectors, enhancing infection prevention and control practices, and of course fostering innovations and research. So my focus today will be on regulating and promoting rational use of antimicrobials. So I won't be talking about antibiotics. I'll be talking about antimicrobials, but I'll try to show how these problems are linked. So this brings me to a compound called triclosan. So triclosan, if you are out shopping, if you look for antibacterial products in your toothpaste aisle or hand soap, you will notice that a lot of those products actually contain a compound called triclosan. So triclosan was first sort of put into use as an antimicrobial in early 70s in hospitals only. In 1977, the production of triclosan was about 1 million pounds. But then around this time, what happened was people started thinking, well, you know what if we start putting triclosan in domestic products? And since then, the use of triclosan in domestic products has just has ballooned. So in 2011, the global production was about 14 million pounds. And in 2009, FDA estimated that 93% of antibacterial soap that were being sold in the United States actually contain triclosan. So most common antibacterial agent that was used in soaps. And the use of triclosan is not limited just to soap. You can find cutting boards that have triclosan embedded in there, school supplies, keyboards, actually my little mouse pad here has antimicrobial products in there as well, shopping carts, you name it, and it's all there. Now we are using triclosan so much that the study about this is not a very recent study, it was carried out 15 years ago, but actually found that about 3/4 of adults in the US had triclosan in their urine. So there's just so much of triclosan that we're consuming that it is in us now. And interestingly, the concentrations of triclosan were highest among people with high household incomes. So one thing with use of antimicrobials and antibiotics is that they do lead to weight gain in animals. So antibiotics now, of course, it's common to see fast food places selling their meat, declaring that their meat was grown without any antibiotics in their feed. And the reason is that at least in animals, so here if you look at this this study, this mouse was given regular feed, and here is a mouse that was given feed that contained antibiotic, and you can see that there is higher deposition of fat in the animal that was given antibiotic. So weight gain in animals it's clear that antibiotics can actually lead to that. And then a recent study also showed that that might also be mediated by use of household disinfectants. So we know that especially during the pandemic, the use of disinfectants was very, very high. So what would be the impact of that in long term? It remains to be seen. But I will share some of the data from our lab, which sort of shows why we should be thinking about using antimicrobials at home. So I'll tell you a little bit of the work we did with an organism called Acinetobacter baumannii. This is a gram-negative bacteria, and it is commonly, at least in hospital settings, found to be multi-drug resistant, so resistant to more than 3 classes of antibiotics. And it is one of the leading causes of death around the world. And that's the reason why WHO has classified Acinetobacter, carbapenem-resistant Acinetobacter, as priority 1 pathogen. And in fact, during pandemic, CDC reported that incidences of carbapenem-resistant Acinetobacter went up by almost 80% in the States. So antibiotic resistance is a big problem when it comes to Acinetobacter. So what our study involved was actually, we wanted to look at what triclosan does to Acinetobacter. So this was an in vitro study where we took Acinetobacter, which was susceptible to antibiotics, and we exposed it to triclosan. We were able to isolate a mutant of triclosan or a mutant that was triclosan resistant. So you can see here, this larger number basically shows that it requires higher concentration of triclosan to be killed. So highly resistant to triclosan. But interestingly, what we also noticed was that this particular isolate was also displaying lower susceptibility to a whole group of different antibiotics. So these are antibiotics that belong to different classes, but they were all less effective compared to the wild type here, against this mutant. But this mutant was only exposed to triclosan, not to any of these antibiotics. So that actually led to the question, what is causing that? And we started looking at some of the resistance mechanisms in bacteria. So the resistance mechanism that we are interested in our lab is something known as efflux-mediated resistance. So these are proteins that are found on bacterial membrane. They basically capture the antibiotic molecule before it reaches the target and pump it out in an energy-dependent fashion. Now, what is interesting about these proteins is that they are not very picky about their substrate. They can pump out any molecule that they don't like outside the cell. So one protein can pump out a variety of molecules. So when in our data, when we saw that our mutant was actually showing lower susceptibility to a whole range of antibiotics, we started to look at whether it's the activity of these pumps in Acinetobacter, which is showing us what we are seeing. And these pumps in Acinetobacter and other gram-negative are quite effective, because what they do is they can pump out the drug molecule right from inside of the cell directly into the external environment. So the effective concentration of the drug inside the cell never really gets to a level where it can kill the cell. So when we looked at the expression of these multiple efflux pump genes in Acinetobacter, we found that there was one particular gene, it's called ADEJ, which was highly expressed in our mutant. So it was this expression of this gene which was actually resulting in not only lower susceptibility to triclosan, but also to lower susceptibility to a variety of antibiotics. So when we looked at what the mechanism of that was, we found that there's actually a regulator gene for this efflux pump. This regulator acts as a switch for this efflux pump. So basically, when the regulator is on, the pump expression is low, but when the regulator is off, then the pump expression goes off. And what we found was that this regulator was basically just disrupted. So the gene that encodes for the regulator was completely disrupted upon exposure to triclosan. So this is what was leading to lower susceptibility of this isolate to variety of antibiotics. So since this study, FDA has actually banned triclosan in antibacterial soap. This ban is only in the US, not in Canada. So Canada, you can still buy soap that contains triclosan, and basically right now triclosan is considered a safe molecule in Canada. And one of the reasons is that what is leading to this is that it is said that there's no evidence to suggest that triclosan exposure leads to resistance to antibiotics, which is true, because the decrease in susceptibility we are seeing is not to the level where you would classify an organism as resistant to antibiotic, but we are seeing lower susceptibility, which actually in the long run can certainly lead to clinical level resistance. And that's something that we need to look at, whether we are looking for clinical level resistance upon exposure to triclosan or lower susceptibility, which at least in our mind, is equally important, if not more. So to summarize, triclosan resistance in Acinetobacter can result in reduced susceptibility to antibiotics, primarily efflux-mediated. Stay away from antimicrobials from household. There's no benefit. That is actually shown by FDA as well, no additional benefit. And I'll just end with acknowledging my wonderful lab group here and the funding sources.
Thank you very much. We'll open up the question and answer session. We have Doctors Kumar Rusin and Hilgerman all ready to answer questions. I suspect some of these are going to be tough. Okay. So here's one. This is, I guess, a Brett Rusin and Tim Hilgerman question. Is there any chance that public health will change their messaging from hand washing to mask wearing to a general campaign of airborne disease transmission, and how immunity debt from mask wearing isn't a thing? Does public health have a plan to educate the public to protect them. Brent, your thoughts?
Yeah. So I mean, I think that's our whole campaign this year is the tools that Manitobans have to protect themselves. And so number one is vaccines. So we're recommending all Manitobans get to the COVID and influenza vaccines. Certainly things like hand washing and good cough hygiene and staying home when ill or other tools, as are mask wearing. So we certainly recommend that people who are higher risk can wear masks. Anyone who wants to further protect themselves can wear masks, but the times of mandating mask use in the public settings are not with us anymore.
Excellent. Okay, next question. Again, another COVID question. The COVID numbers have been increasing. Is this occurring worldwide? Would it ever be called a pandemic again? Let's hope not. Healthcare workers are being mandated to wear masks again in workplace. Will this be recommended to the public? What I'll say, I'll speak to the workplace. Certainly for healthcare workers, it's public-facing healthcare workers. So those that have direct patient contact, which given what we've just endured for the past 3 years, knowing where we've come from, knowing where we could go, it's not an unreasonable, very simple measure in conjunction with hand hygiene and staying home if you're ill. Brent, now the COVID numbers worldwide and, public health's vision for the future.
Yeah, so we're certainly seeing the COVID numbers increasing, like other respiratory virus illness is in the northern hemisphere. Certainly the southern hemisphere already had its season. And so we do see that in many jurisdictions. In Manitoba, we haven't seen a dramatic climb, certainly not in severe outcomes at this point. And so no, we're not certainly looking at a mandating mask wearing in public at this point. Again, it's all about messaging, multiple tools available to protect ourselves, and we're dealing with a much different virulence of this virus than we first did.
Excellent. An Ayush Kumar question. So are any measures being taken to rein in the rampant use of triclosan?
Honestly, I'm not aware of any measures that are being taken. The major measure that was taken was south of the border, banning triclosan from soap, but you can still buy triclosan even in states, mouthwash with triclosan. And I think, once again, we're just looking at, I think we're looking at it the wrong way. We are looking at development of clinical level resistance to antibiotics. I think we need to look at lower susceptibility to bacteria, because that can easily lead to resistance to antibiotics.
Sure. Tim, we know where we've come in public health. What do you see for the future?
John, say that again. I'm looking at the question.
Oh, sorry. We know where public health has brought us. What do you see for the future of public health? I know it's more a philosophical question than a hard scientific question.
No, excellent. I mean, when you asked about this topic originally, I thought, one of the things perhaps that might be the biggest accomplishment of public health in the future is actually to change the mindset of people when we think about health from this sort of the hard outputs of our healthcare system to actually how we effectively address those broader determinants of health. Because I think that therein lies the way forward that's going to get us out of this ever increasing pressure on our healthcare system, older population, sicker patients, more complicated, more complex care, shorter, smaller workforce to deliver that care. And I think we really need to start taking a harder look at all of those elements of those broader determinants that I mentioned that we can actually impact, not just at the public health level, but actually at that societal level, that responsibility. I think there is a way forward, and I think it's going to require a further mindset change, John.
Thank you. And then this is sort of an Ayush Kumar question. Can the excessive use of antiseptic hand wash lead to antimicrobial resistance? Well, I'll begin by saying that it's an alcohol-based antiseptic. So unlike what triclosan did to Acinetobacter, the alcohol will kill the bacteria. There won't be any survivors. Ayush, can you elaborate?
Exactly. So one of the reasons that actually led to rampant use of triclosan in domestic setting was in 70s, late 70s, early 80s. People believed that triclosan didn't have a specific target in a bacterial cell. So it was basically melting out the membrane, which is what it does, but it targets a specific enzyme. And so any compound that has a specific target in a bacterial cell has the potential to select for resistant mutants, whereas alcohol-based disinfectants or sanitizers, they just melt the lipid layer of the bacterial cells. So there's no specific target. So you don't really get to see, however, you don't really get to see resistant bacteria. However, it is very, very important to ensure that the hand sanitizer you're using is not very old, because studies have shown that when hand sanitizer sits on the shelf, so like the one I have here, if it's sitting here, alcohol evaporates. And when the alcohol concentration goes below a certain percentage, so it was around 55%, there was certain bacteria that were found to be growing in there. So Pseudomonas, for example, can grow at 55% of alcohol. So it is important that you're using not too old package of your hand sanitizer.
Fantastic. Just look at the questions here. Okay, so a Brent Rusin question. Speaking from your Manitoba experience, knowing, in retrospect, that excess mortality in young people may have been driven by the response to the pandemic rather than the pandemic itself, how would you handle the next pandemic differently to minimize this excess mortality and DALYs lost?
So this is a really well framed question and a really difficult question. Because it all comes down to balance and really a societal choice, right? And it's very difficult to come up with the trade-offs. We know that with any pandemic, with any pathogen, there's going to be individuals that are more at risk. We saw in this pandemic that was the older age groups. So, at a societal level, are we willing to trade off more impacts in that one group to impact another group less? Where is that balance? And so it really is, these are societal level questions that public health can provide the expertise on, what the parameters are and what the outcomes may be. But ultimately, it's, these are decisions that, where we're willing to put our trade-offs. And it's a very difficult question, but a very well framed one.
Thank you. So Brent, just looking to the future, what's the first thing that public health did after the pandemic? When we were students in university, after you finished exams, well, I'm going to get a haircut. I'm going to cut the grass. So what's the first thing that public health did once you put away the binders and the Zoom conferences for the pandemic? What are your priorities going forward?
Well, right now we see an epidemic of sexually transmitted bloodborne infections, and a lot of it, again, driven by events of the pandemic. Hard to know pinpoint what those are, and again, driven by those same inequities that we discussed, and much of our work is the same in it. So we have a number of challenging years in public health and the healthcare system, and really in society. To recover from this pandemic has taken on us, and we're going to see the effects of this play out over the next number of years.
Thank you. Well, I think since there are no other questions, we'll wrap up this session and move to the next one. So thank you, Brent, Ayush, and Tim. Thank you very much.
Take care, everyone. Bye-bye.
Thank you. And now our next speaker is actually two speakers. It will be Ken Casper, who is a specialist in infectious diseases at the University of Manitoba with a specific interest in infections in the human, or in persons with infection with the human immunodeficiency virus. And Kimberly Templeton, who is the program lead for the Manitoba HIV program. And Kimberly has years of experience in health program administration and health promotion. And I think we need to stress the health promotion, because once the disease has begun, the horse is out of the barn. So it's preventing the disease to begin with, which is all about public health. And so Ken and Kimberly, take it away.
Great, thanks, John. You guys can hear me okay?
Perfectly.
Awesome. Kim, are you managing the slides, just so I know?
Okay,
awesome, thanks. Thank you, everybody. Thanks, John, and for everyone for inviting me back. Really going to use this 15 minutes to kind of give you the state of the nation with regard to HIV, a really good segue from what Dr. Roussin just said. And we're going to talk a lot about the crashing syndemics that have really affected what we are now seeing in the clinic and what our future lies. And I really thank Kim, who's our program lead, who you'll hear about in about 5 minutes or so. Kim, next slide, please. I have no disclosures or no conflicts of interest. Next slide, please. I think it's important to just get an idea where we are in Canada with regard to HIV. And I think you can see the role potentially of the pandemic in this as well, as there for the first time was a slight increase in cases in Canada. This is driven, though, as you're going to see in a moment, really by what's happening in the prairie provinces. You can sort of see the sort of burgundy darker colors in Manitoba and Saskatchewan, where the case rates are much higher than the expected national rate. And we're going to see, unfortunately, this trend is going to continue. Next slide, Kim. Over 40% of the cases in this recent increase occurred on the prairies. Next slide, Kim. As I mentioned, in 2021, we had 170 cases. You can sort of see in 2022, which is not included in that slide before, we had 270 cases. This is the population we're just looking at right now at the moment, and should have some data in no time. You can sort of see our case rate is now very close to Saskatchewan's, close to 20.0, or 5 times the Canadian rate. And really, since the virus started in Manitoba in 1985, you can sort of see a steady increase in HIV incidence in Manitoba. But really, the effect potentially of the pandemic and other factors like crystal meth introduction and needle use as a main driver has really changed the case dynamics that we're seeing in our population. Next slide, Kim. This is just looking at all the data between our prairie provinces. You can sort of see Saskatchewan, where the epidemic started much earlier in 2006. Those are the red dots. You can see Manitoba in the purple dots. And then we put a line there for when COVID hits. And you can sort of see the changes that Brent just spoke about potentially playing a big factor in what we're seeing today in our clinics. Again, the Canadian rate is slightly increased. That's the black line there at the bottom, but really Manitoba and Saskatchewan are driving the pandemic at the moment. Next slide, please. Before we look at our 2018 to 2021 data, which we wanted to just frame the findings, and Dr. Roussin has mentioned a lot of this already, but the health disparities in Manitoba are shaped by the structural and social determinants of health. It's the convergence of houselessness, mental health concerns, substance use, the socioeconomic factors in COVID-19, which is really driving a syndemic of HIV and other STBBIs that a lot of my colleagues have already spoke about. And the Indigenous people of Manitoba are disproportionately impacted by this syndemic due to the ongoing impacts of colonization, structural racism, and intergenerational trauma. So Kim, let's look at some of the quick findings of our data from 2018 to 2021. This is looking at 517 new Manitobans who were diagnosed with HIV, not including the 2022 data yet. But you can see around 50% of the cases are female. That's at the top of the slide. We'll go down the slide. You can see heterosexual sex and injection drug use were our most common modes of self-reported HIV acquisition. And you can sort of see 8 in 10 people had at least one STBBI prior to their diagnosis with HIV. So, obviously interventions where we want to help with primary care to make sure these individuals have tools that they don't have to acquire HIV in the future. One of the big drivers is houselessness. You can see almost 50% of our new cases were female or houseless, while 25% of males are houseless. Again, the important role of heterosexual transmission in Manitoba being a major player of HIV acquisition. When we look at our female population, of the 517 cases, almost 65% are self-reporting injection drug use. A huge change in demographics and factors for us in the program. Crystal meth, unfortunately, is the mostly used product that patients are currently using. And I think probably the most important factor, when we look at our 517 cases, 70% self-identified as Indigenous people, reminding you that Indigenous people make up approximately 18% of our population, but 70% of the new cases between 2018 and 2021. Next slide, Kim. And again, just to bring home the fact that this is different than the rest of Canada. Again, our case rates are much higher and are unfortunately continuing to escalate. We have many more females being diagnosed with HIV than what we expect in Canada. Very similar to what the developing world is also seeing. And we're seeing 80% of our cases self-report heterosexual transmission as the main mode. Very different from what's happening in some of the other big cities in Canada. And again, the role of injection drug use, which seems much higher than you'd expect. And in our population of the 517 Manitobans that we looked at, 60% of the females who acquired HIV were self-reporting injection drug use. So really complex factors here at play. Next slide, Kim. Because of these complex factors, traditional type of clinic structure just doesn't seem to be engaged or working enough with the kind of population that we're currently working with. I will say to our team that these are 517 very complex patients. When you look at the last bubble there, almost 60% had an undetectable viral load, really suggesting the clinic structure still works for a number of patients, but clearly there are people falling through the cracks, and this is a population that we need to find solutions for. And Kima is going to be talking more about that in a moment, but almost 20% are not engaged in their HIV care, and you can see they sort of fall off along the cascade of care. But again, these are ongoing challenges. I'm afraid to tell you that 2022 and the 2023 population are even more complex, and we're probably having even less success in our clinics, unfortunately, which means we're going to have more virus out in the public that's not being suppressed by HIV medications. Next slide, Kim. If we do nothing different, if we don't improve PrEP, if we don't change some of our clinic structure, if we don't engage people to what they need, if we don't work on the socioeconomic determinants of health, if we don't work on houselessness and other factors as main priorities going forward, this is what the modeling suggests. And thanks to Dr. Ryuta and Dr. Keenan who put this modeling data for us. Just to orientate you, these are the years since the pandemic has started, and I've circled 2024 there for you. If we go up that red line, you can sort of see, and it looks like based on the 2023 data, where we're going to have almost 350 new patients living with HIV in Manitoba, that we're probably following the red or the purple model, which would suggest by 2024, if we do nothing different, that we potentially could be up to 500 new cases in Manitoba, which would put us at least 10 times the case rate nationally in the rest of Canada. So I really wanted to just get across to you that we are in a problem and we have to find some urgent solutions. The new government is well aware of this. We are working with them. We really hope we'll have some solutions in place. Kima is going to talk about what we think is a model that may work for us going forward. At least it's going to help with some of these patients who are disengaged with our current team and clinic structure. So Kim, I'll let you take away. Next slide.
Thanks, Dr. Kasper. So yeah, as Dr. Kasper mentioned, I'll be talking about some of our plans moving forward to help try and curb what Dr. Kasper has just presented to you. So in conversation with the members of the Manitoba HIV program leadership team, as well as extensive engagement with our community partners and provincial leaders, some calls to action were generated in response to the findings from our latest report for 2018 to 2021. At the forefront and what spans across each call is to strengthen Indigenous leadership across each call to action and to support an Indigenous-led HIV strategy. Other calls include to enhance transdisciplinary STBBI strategies in the province, the prioritization of appropriate housing for people living with HIV who experience houselessness, and the expansion of harm reduction strategies for people at risk of and living with HIV. I'm going to speak more specifically to the calls to action that the Manitoba HIV program is leading and supporting in the path forward. The first call to action is that the Manitoba HIV program is leading is to maximize treatment as prevention in Manitoba, or TASP. TASP is the well-documented concept that maximizing coverage of antiretroviral therapies can prevent and reduce illness and death due to HIV and can lead to the elimination of HIV transmission. This has been well demonstrated at the population level, as well as in cohort studies, including with people who inject drugs. We are implementing and proposing expansion of a program we have named PATHS, or the Program to Access Treatment for HIV and Support in Manitoba, which is adapted from the evidence-based TASP STOP model in BC. And the goal of this program is to provide wraparound care with psychosocial supports to people living with HIV, offer and link to Indigenous-led and culturally safe care, support people living with HIV to access and adhere to HIV treatment medication, and in the longer term to support people living with HIV to transition to long-term primary care services. Thus far, we have implemented one PATHS pod at Nine Circles Community Health Centre in the WRHA. This was done with federal funding that ends in March 2024. A PATHS pod is made up of an interdisciplinary team of a social worker, nurse, and outreach worker who work in community to provide intensive case management for people who are not linked to care meaningfully in the clinics in Winnipeg or outside of Winnipeg. We currently have a proposal, as Dr. Casper mentioned, to Manitoba Health that is asking for ongoing funding to expand these pods in Winnipeg and across Manitoba in locations where the biggest need has been identified. The other call to action the Manitoba HIV program will lead and support is to enhance primary care capacity for HIV testing, prevention, and treatment. The Manitoba HIV program has HIV testing guidelines available on our website. We recommend routine HIV testing in the general population 12 to 70 years of age once every 5 years. And for those 12 to 70 years of age with additional risk factors, we recommend routine testing every year. If a patient tests positive, it's the testing practitioner's role to notify them of their positive HIV test result and provide education. The HIV program has a pocket brochure on our website that can be printed off in-house and can be provided to patients who test positive for HIV in your practice. All patients who test positive should be referred to the Manitoba HIV program using the Manitoba HIV program referral form that can also be found on our website. The HIV program will also support primary care capacity for HIV prevention. We have HIV prevention guidelines available on our website as well, which include recommendations for the management of pre-exposure prophylaxis, or PrEP. We encourage prescribers to consider becoming a PrEP prescriber and have been working with the province to simplify this process. Prescribers need to register themselves as a prescriber on a form found on the Government of Manitoba's website. Note, this is not an application process. You don't need approval to start prescribing. You just need to fill in the form. Review the eligibility criteria for PrEP as outlined by Manitoba Health and read the HIV program prevention guidelines. All of these links that I've included in this slide here can be found on our website. And just to note that as of 2021, there is expanded coverage for PrEP. And as I understand, the new physician services agreement also includes a new tariff for PrEP. So healthcare providers' engagement in HIV testing and prevention activities will be essential to drive short and long-term change in the HIV trends we are seeing now in Manitoba. The HIV program is also actively working to enhance primary care capacity for people living with HIV in Manitoba. This includes, in the short term, identifying more specialized sites for care, including Indigenous-led sites, as well as building the capacity for primary care to provide primary care to people living with HIV and capacities to support HIV care in the primary care setting. So stay tuned for new primary care recommendations for adults living in Manitoba, which will identify the primary care provider's role in the HIV care cascade, as well as the role that the Manitoba HIV program will play in supporting healthcare providers to provide care. Some key takeaways, key takeaway messages for healthcare providers to support the path forward for HIV in Manitoba. First and foremost, to understand how and why Indigenous people in Manitoba are disproportionately impacted by HIV and facilitate culturally safe and trauma-informed care in your practice. Use the HIV testing guidelines in your practice and know the HIV STBBI status of all people in your care. Normalize HIV testing when testing for one STBBI, test for all. Notify, educate, and refer all people in your care who test positive for HIV to the Manitoba HIV program. Use U equals U language for people who are newly diagnosed with HIV, and use the Manitoba HIV program prevention guidelines to support people at risk for HIV and offer PrEP for eligible people in your care. And thank you for your attention to our presentation. And if you have any questions, we encourage you to be in touch with the program.
Thank you, Ken and Kimberly. Outstanding. Now, you'll notice that there's a theme here, because the next presentation is by Stu Skinner, who's an infectious disease physician in Regina, who has a specific interest in HIV, syphilis, and other communicable agents. But now we're going to get the Saskatchewan experience with Stu's presentation entitled HIV, Hepatitis C, and Syphilis Outbreaks in Saskatchewan. What can Manitoba learn from the Saskatchewan experience? I'm actually afraid of what we're going to learn from the Saskatchewan experience. However, Stu, the floor is yours.
Thanks so much. Maybe while I'm just kind of getting this set up, one question, Ken and Kim, you guys do great work. One of the biggest challenges is that the assumption that people will show up to a primary care provider. So what do you have thoughts, or what are you guys doing there to help or to reach out to people who don't have access or can't get access to primary care?
Yeah, so that's really that. Kim didn't mention this, maybe you know that word, but we're trying to really the whole idea of the PATHS team is that they will go into the community to find the patients in their homes, draw the blood, do all the things they need to do, and work with the specialists over the phone, and hopefully not use the brick and mortar clinic as the way to address their clinical needs. So that's sort of the goal of the PATHS program. And since we've had it started, so far so good. We've been doing some of that care in people's homes.
Is that throughout the province, just out of curiosity?
Well, we're going to start with those 6 pods is the hope, if the government is able to fund them for us. And then, as we show success, we hope we'll be able to do this in more situations is the hope.
No, that's great. Can you guys see my screen? Is that working?
It's working, yep.
Okay, thanks. No, thanks so much. It's actually, this is kind of brings me back home. I did my fellowship in Winnipeg in 2005, 2007. So Dr. Embel was my program director, and Dr. Casper was one of my clinical leads. And I learned so much from there. And there's a lot of overlap, and it's great. Thank you for inviting me. I think Bug Day when I went was like the 5th or 6th Bug Day or something, the first one. So this is actually really neat for me. So thanks, Dr. Embel. I'm here to probably make you guys feel better. Really talking about HIV, hepatitis C, and what's going on in our province. And it's not just really what learning goes both ways. So I am the section lead here in Regina. I was the COVID chief of staff here in Regina. Assistant professor at the U of S. I was assistant professor at UVM for a long time. And then I'm also run a program called Wellness Wheel, which is focused on a change in how we look at healthcare delivery, predominantly for First Nations or Indigenous communities, but also smaller centers and towns. that it's often easier for us to take what we do and take it out to community rather than having 20 or 25 people come in. Now, Saskatchewan's a bit different than Winnipeg or Manitoba, because you have one large center versus where we have two. So it's a little bit easier in terms of travel distance, but you've got to take care of the community. And that's always been kind of my focus. And so I'm an infectious disease doc, but I would say 80% of what I do is in Indigenous communities. I'm on Treaty 4 land right now in Regina, and I recognize that as well as the homeland of the Métis people. But the land means more than just saying that. I get my zen from going out to community, because community gives 100 times more back to me than what I give. And there's a big difference what is happening in the prairies than anywhere else. Sure, there's a little red line on a map that says that's the difference between Manitoba and Saskatchewan, but we know that actually is just a red line on a map. And we have to realize what is going on is extremely different. And I would assume what you guys go through is the same as what we go through in terms of healthcare resources, number of providers, number of people available to support. And that's very different than, say, Toronto or Montreal or Vancouver, where they probably have more providers than all of us combined. And so we've got to work together to build collaborations and share ideas. And what's happening here is completely different. And that's the prairies, that would include northern Alberta and even southern Alberta as well. And that's why we all have to partner and work together. So I'll just kind of run through quickly kind of what we see here. Here's the objectives. My conflicts of interest, sorry, I forgot to put a slide in, but I get some grants through a few pharma companies, but it will not affect this talk at all. And this slide was shared, and yay, Saskatchewan, we still have the highest rates of HIV in 2021, and Manitoba much higher. If you were to break down Alberta from northern versus southern, you probably would see similar numbers to Manitoba, but because it's provincial data, that's how it gets broken down. Our numbers, so we have had the highest rates in the country forever, 15 years, I think now. You see the numbers, say early 2011, and then it dropped because there's a much more intensive focus, but then it relaxed and the numbers went up and they've stayed steady, and then it's increased after COVID, but things have shifted and I'll show you why. And so that's what we struggle with personally, and this is a great question for anybody out there, is I think once you have a certain amount of viral load out there, a certain amount of prevalence, that once the cat's out of the bag, you can't bring it back. And so for Manitoba, maybe you guys are close, but now would be the time, because it doesn't matter what you do once the numbers are this high. There's just too much virus or too much bacteria or too much whatever. That's my theory. And there's a lot of good people in this province doing everything they can, and we've 15 years highest rates in the province, and 2022 has gone up, and 2023 is going to be just as bad. Certainly the burden, the proportion of infections are in First Nation communities or Indigenous populations, both with HIV and hepatitis C. And the reason for that is because what we've experienced up until maybe 2020 was this was all injection drug related. So it started with Downs, morphine, etc., and then shifted to crystal meth, and then it's shifted now into a different epidemic, but it's still predominantly in the Indigenous populations. I think one thing that's really important to acknowledge, and the reason this is important is from a government perspective, the way they look at things would be on versus off reserve, but it's not on versus off reserve. Patients are very mobile. It's a government definition, and the reason it's easier to get on reserve numbers is because that's through Indigenous Services Canada, which is federal, versus provincial. But so even though if you were to look at this numbers and say, yeah, it's much, much higher for on reserve populations, it's much, much higher for Indigenous people as a rule, whether you're on or off reserve. And that distinction can be important because we do a lot of work with First Nation communities, and that if we take this and just say, oh, it's on reserve, it leads to a lot of bias, and it leads to a lot of stigma towards First Nation communities, even though actually the outcomes are generally better. And that's, but when you see this, that's what you're seeing, and that's why. But it's really the same, because people are on and off. It just depends on where you put your home address, on where you get tested. What's shifted in the last couple of years, you can see this is, and Dr. Casper mentioned syndemics, and that's what we've seen is a complete change in HIV. So the rates are a bit higher, which is the red number, but you can see the syphilis numbers are really out of control. And the syphilis is probably really driving the shift of what we're seeing. And what we're seeing is it's gone from west to east, meaning this, I think, really started in northern Alberta, and it's spread through, sorry, I don't have a graph on this, but it's spread through the northwest of our province, and it's coming down. And just, Dr. Casper probably mentioned what they're seeing, but it's going to get a lot worse. And this is really driven by syphilis. I can't explain why, other than the same concept of once you get so much out there and people can't access care, it's about a 10% increase in HIV rates with your syphilis rates. And if we broke down our province, west versus east, you'd see a big difference, but it's moving, and it's coming Manitoba's way. But this has been a huge shift. And the hepatitis C numbers you see going down, and that's a really good indication of injection drug use spread, meaning the IDU spread, because there's less hep C, is coming down, and the syphilis is going up. That this is a change into heterosexual transmission. The other part we're looking at, so this is our data. This is our, so I'll explain in a minute, but Wellness Wheel, which is our outreach to First Nations to about 19 different communities, is a huge shift into younger, particularly women, younger age groups. So 12% now are under the age of 20, and you can combine that 31% would be under the age of 30, and most of these are women, pregnancy age groups, young women, vulnerable, and it's a big change that's happened. And then you can, this is another way. So there's two pieces on this one slide. One is Saskatoon. So PLP is the provincial, or so the Positive Living Program, which is an ID clinic. WSCC is Westside, which would be inner city primary care clinic. And on the right is our Wellness Wheel data. And you can see consistency, meaning this is not rural versus urban. This is everywhere, where there's a huge shift, almost like it's flipped right into women, and they're young women. And the risk factors, and this is consistent with what you would look, seeing just even your hepatitis C rates, your syphilis rates, is that it's a flip into sexual transmission. And similarly, the graph on the left is Saskatoon, the graph on the right is our outreach. So it's not one site versus the other. This is consistent with what we're seeing across the province. And similarly, the rates of co-infections, the hepatitis C has dropped significantly, but STI co-infection rates have massively increased. And you know, it's not uncommon for me to see someone with a new diagnosis of HIV who has syphilis, gonorrhea, chlamydia, and hepatitis C, and probably HPV, and probably HSV as well. So multiple co-infections. I don't, we do a lot of peer work, we do a lot of community-based work. I don't understand exactly what has shifted or why, but this shifted during COVID. And like I said, I don't know. And then if you look at syphilis in Canada, 2021, so we had 1,346% increase. I would say it's uncommon for me to see a new HIV who does not have syphilis, and it's everywhere. And we're dealing with a population that's hard with homelessness, the social determinants, right? Homelessness, poverty, food, etc., or sex trade work, that they're really hard to find. They're really hard to test. They're really hard to follow up with treatment, and then they just get reinfected. And that's really, it's an incredible challenge that is unbelievably difficult. One of the things we're doing is called the Shiver study. This is based on Dr. Singh's work in Northern Alberta and the work in Nunavut doing point-of-care syphilis testing. So we offer point-of-care syphilis, point-of-care HIV, or point-of-care both testing with the intention of test and treat. So if they're positive, we treat, we draw blood, and this is run throughout the province now. We're up to 14 sites, including corrections, including pharmacies, including on reserve, including towns, including the clinics. And what we've seen so far is about 14% positive syphilis rates and about 6% positive rates for HIV. How many are new? I can give you the number, but most of those patients would be disengaged from care. So it is an opportunity to engage people in care, and it's a way to look at using different methods or different situations or places to test and treat people. So this is not only, it's as an example, the pharmacies we work with in the inner cities are running this, and might be the only place patient has connection. That's where they show up. And so we utilize that, and then they'll call me and I'll just treat them. I'll start, if they're HIV positive, I'll just start on treatment. Other examples would be community-based organizations. Again, that might be the only place patients engage, and we partner closely, and you trust the people you work with, because we're trying to take this healthcare model and broaden it out beyond just the standard clinic model. So the wellness wheel piece, sorry, I'm running out of time, is really outreach, community led. So what we do is it's First Nations led. When we go into community, we go out, it's nurse led, the nurses do most of the work. Everything we do is that point in time. We draw blood, we do point of care testing, we do fiber scans, ultrasounds, pregnancy tests. My work with HIV and hepatitis C or syphilis is through the yellow areas. So all the way from Big Island Lake in the northwest corner, which is by Cold Lake, Alberta, down to Kamsack, which is 10 minutes from Swan River. And we have, in that work, we have about 198 HIV positive patients and about 500 hepatitis C patients. And then it's expanded into primary care. So this is actually a primary care led model now, which went from 16 clinics 5 years ago to 234 this year. And the point being, go to community. There is a whole health system in the community that is federally led that we're never taught, we don't know about. And there's a whole system where the community can lead it and they can bring in their resources, and it works really well. So let's slip through that. There's media. We need to work together, bottom line, and because there's many things you guys are doing in Manitoba that we can learn, and vice versa. This is a prairie issue. Even though our numbers might be higher, it's coming your way, especially with syphilis. And we have to partner together, especially because we don't have the same resources as the GTA. And we have to do this and pull it all together. There's a big shift here that we've seen from IDU to sexual transmission with a lot of syphilis. The communities know what to do, and there's a huge system and resources that we need to partner with. And they'll tell you what to do. And then you can pull everything else in. And it's those partnerships that make a difference. I can really get a chance to kind of go more into it. I'd probably spend 2 hours, but it makes a difference. It's a real change. And it's all about trust, respect, and relationships. So thank you.
Thank you very much. Outstanding presentation, puts it all in context for us. I think the good, the bad, and the ugly. So we'll open up the session. Oh, we won't open up the session, I'm sorry. So we've got Mindy Goldman joining us from the Canadian Blood Services, changing policies for assessment of sexual risk behaviors in Canadian blood donors. Mindy is the medical director of donation policy and studies at the Canadian Blood Services. She's been active in many facets of transfusion medicine in Canada, including optimization of donor screening processes. So Mindy.
So thank you very much for inviting me to present. These are my conflicts of interest. And I'm going to skip over my objectives and begin. So get ready for something completely different. I'm going to talk about assessing policies for sexual risk screening in blood donors. So blood safety is dependent partly on blood supplier action. So blood supplier would be Canadian Blood Services, and for the province of Quebec, Héma-Québec in Canada. And that is using voluntary non-remunerated donors, which we do. We have a donor questionnaire and a criteria manual. We do extensive testing on each donor sample every donation, including HIV, HBV, HCV, HTLV 1, 2. And syphilis. And we have automation, process control, and quality management. And for some components, but not red blood cells yet, we have pathogen reduction. And of course, we've just been hearing from other speakers that there's also many more broader societal considerations that can play into blood safety, epidemiology of HIV in the general population, public health policies. Do general population people, potential donors, understand the risks of acquiring HIV and other sexually transmitted diseases? Are there places where they can have rapid, accessible testing for HIV so they're not coming in to donate as a test-seeking activity? And finally, preventative strategies and treatment in the community. So this just goes over a little bit how we change blood donor criteria in Canada. So in Canada, blood is regulated by Health Canada as a biologic, and changes that might affect blood safety are submitted to Health Canada for approval pre-implementation. So here on this timeline, you can see our policies for men who have sex with men in our jargon, where a permanent deferral for blood donation was put in place in the mid-1980s when it was noted that this group was at high risk for AIDS, even before we knew it was caused by the HIV virus. And of course, we've made tremendous strides in understanding and testing for HIV over the years, but it was not until 2013 that we actually changed this policy to be a 5-year deferral. So we would ask all men if they've had sex with another man even once since 1977. And if the answer was yes, initially they were permanently deferred. Here they were at a 5-year deferral from last male-to-male sex. And then you can see that this deferral period progressively got shorter until finally we had a pilot project on 2 source plasma sites. And in September of last year, we moved to a sexual risk behavior screening for all donors. So what does that actually mean? Or before I tell you what I mean, why did we do it? So this shortening the time-based deferral period still deferred, of course, sexually active, gay, bisexual, and other men who have sex with men. And we are committed to increasing donor diversity and inclusiveness. while obviously maintaining the safety and adequacy of the blood supply. And asking male donors about sex with other males can be perceived as discriminatory and stigmatizing. So the criteria should allow gay, bisexual, and other men who have sex with men who are in a stable relationship to donate, while deferring others, and indeed any other donor who has had recent high-risk sexual behavior. And we're most concerned about risk in the last 3 months because those would be incident infections that could occur during the window period, and prevalent infections would be picked up by our testing. So we're doing basically a 4th generation test that picks up antibody, antigen, and MAT testing for HIV. Risk is related to the type of activity and the number of sexual partners, and we would stop using sex with another man as a surrogate for high-risk sexual activity, basically. So this is what we're doing as of September of last year. We ask all donors who are donating whole blood or plasma, in the last 3 months, have you had a new sexual partner? All the questions are asked electronically. So if the donor answers no, then they go on to answer one of the other 50 plus questions. If they answer yes, then they'll see another question pop up. In the last 3 months, did you have anal sex? And if they answer yes, that answer is going to be reviewed at the end when they finish the questionnaire, when they go over their answers with the screener. If the donor has had anal sex with a new partner, they're going to end up with a 3-month deferral. And this is the second question that's asked of all donors. In the last 3 months, have you had more than one sexual partner? Same thing. If they answer no, they just go on to the other questions. If they answer yes, they get asked another question electronically. In the last 3 months, did you have anal sex? And if they answer yes, when this is reviewed with the screener, they're going to end up with a 3-month deferral. So how do we assess the safety of these types of changes that we're making? Some of these are, I think, are intrinsically obvious to people. So we do surveillance of known and emerging pathogens. We have an epidemiology department. We do studies to try and assess compliance in our donors. We model the risk increment for proposed changes, and this is part of our submission to Health Canada before getting approval for changes. For this shift to sexual risk behavior deferral, we also reviewed epidemiologic studies of HIV transmission. There was a large cohort study of HIV transmission in the GBMSM population called ENGAGE, which you may be familiar with. That was very helpful. We also did a study assessing the impact on the adequacy of supply of possible changes and looked at the acceptability of changes in various groups, including donors and general population and GBMSM groups. So the federal government funded 2 research programs aimed to generate evidence for alternate screening approaches. And the program was administered by Canadian Blood Services and HEMA Quebec, funded 19 projects in 11 different sites. And the research themes were safety, operational feasibility, and acceptability. I just wanted to add that before implementation, all policy changes have been accompanied by stakeholder consultation with patient groups requiring frequent transfusion or frequent use of plasma protein products, and also with 2S LGBTQIA+ groups and community groups. And these groups also provided advice on communication strategy on implementation. We added information about upcoming changes to our website. We provided donors with the information in their reminder email that we send them so they wouldn't have a shock when they next filled out the questionnaire. And our staff underwent extensive training to be ready for this major change. Post-implementation, we've done all the kinds of surveillance that I mentioned. So we're monitoring infectious disease rates with a focus on HIV. We interview and identify risk factors in HIV-positive donors. We will be starting an anonymous donor survey in a couple weeks to assess compliance. We look at emerging pathogens. We are also testing for the presence of antiviral agents in a subset of samples. We defer donors who are on PrEP or PEP therapy, so this is kind of a measure of non-compliance. And if we have positives, we are sending samples to the National Microbiology Lab for further characterization of the epidemiology and the recency of infection. So our results to date. So this is 1 year post-implementation. So we have seen no change in HIV rates in our donors, which have remained very low and stable. We have had 5 HIV NAT and antibody positive donors in over 750,000 donations screened. I think some of the physicians who just presented see more than this in one morning in their practice. We have had no NAT-only positive donations, which would indicate very recent infections, so maybe sort of a kind of a near miss. Our calculated risk of acquiring HIV from blood transfusion remains less than 1 in 10 million transfusions. The deferral rate in our donors has been lower than expected. It's less than 0.08%. And as I mentioned, we're just going to be getting some compliance studies underway. Internationally, the UK was a leader here and moved to this type of approach in 2021 with no change in HIV rates in their donors. Israel and now the US have adopted the same criteria as the UK and Canada, and the Netherlands is moving towards that approach as well. So thank you very much for your attention, and I'll be happy to answer any questions.
Thank you very much, Mindy, Stu, Ken, and Kim. So let's see what questions came in with Slido. So I have a question for Mindy. So you have donors for whom you find PrEP, or so the question for you is that blood put aside and the donor contacted again in the future, and if you know if everything is, if the coast is clear, the blood is used, or is the blood just automatically discarded?
Yeah, that's a good question. So that is an anonymous survey that's being done, not in real time. And so we're not able to link back to the donors. We are sending samples that are positive for syphilis and HIV. Those donors will be permanently deferred anyway because of their positive marker testing. And then we have some randomly selected young donors that we're also sending samples. So that is not, we're not able to link back to an individual donor.
Thank you. Okay. So is there a possibility that long-acting injectable HIV treatment will be approved in Canada in the near future? Do you see any new HIV treatment option that may produce better adherence and could increase the % of people with undetectable viral loads? I guess that's a Ken, Kim, and Stuart question.
Sure, I can start, Stu, if that's okay. We do have a long-acting injectable already in Canada called Cabenuva, which is 2 drugs. It has to be given every 2 months. Unfortunately, at the moment, it's really only approved in patients who can prove they have an undetectable viral load for a period of time and then can transition over to the injectables. This is the first generation of injectables. I think there's a second generation coming, which potentially could have a longer half-life, up to 6 months. So there is some excitement in the field that things are going to change when it comes to treatment. I think the more exciting, though, promise of injectables is with pre-exposure prophylaxis. It hasn't been approved in Canada as of yet, but that is going to be a possibility potentially in the future. And obviously, as a program and primary care lens, this is going to be a really important new tool that we may have at our disposal. Again, the challenge with these drugs is a certain window period, and you've got to get the team engaged to make sure they connect with these patients again after a certain point of time. Otherwise, you're going to get drug resistance in your population, which for us, having an integrase inhibitor drug resistance be very concerning, because that's our main treatment. Hopefully that answers your question.
Excellent. So the next question is one that's Manitoba specific, but I think we'll throw it open to Stu Skinner as well. With the new government, any signs on the horizon for safe injection sites? And does Saskatchewan have safe injection sites?
Yeah, I mean, we've got one in Saskatoon. I think it's come a long way in terms of safe injection sites. I think the challenge in the prairies, right? So this, and Dr. Casper can comment, but can comment is the population is very different. So with safe injection sites, you need populations like around one specific place, and that is easy, say in Toronto, Vancouver, or say downtown East Side Vancouver. It's a lot more difficult in Regina, Saskatoon, maybe Winnipeg, because the population is very different. So it becomes much more difficult in terms of the practicality of that. But I think we've come a long way. We have a very right-wing government. But I guess the answer is we've got one in Saskatoon, but I think there's much more limitations than the bigger urban centers in Canada.
And Ken, I think it's too early to know where Manitoba is going.
Yeah, I think Mr. Canoe was pretty clear, though, that healthcare is the focus, and I think looking at all means for harm reduction are going to be a possibility with this government. So I think we're encouraged by our initial first looks and conversations.
Fantastic. Okay, so another good question. Given the STBBI rates are higher in the Indigenous population and classically transport to larger centers is extremely difficult, why is Manitoba choosing to create the hubs in the larger centers instead of increasing services to the rural communities and Indigenous communities first?
I can respond to that. Yeah, so related to paths, the outreach model of care that we're working towards, we're planning in the first and second phase of implementation to look at Winnipeg, Thompson, as well as Brandon, and then have a resource that would move around the province into the other regions. And the reason that we placed those pods in those locations is based on the analysis that we did of the number of people who are lost to care and where they are, to the best of our knowledge, currently living according to our records at the Manitoba HIV program. So that's why we've chosen to do it where we have, but we're also working with Indigenous-led organizations to support them to provide the clinical care, but absolutely working with them to lead the culturally informed and trauma-informed care, and understanding, at least in the short term, that the role that the Manitoba HIV program can offer it relates to the clinical care. So those are some of the reasons that we've decided to start in the locations that were indicated.
Thank you. Next question, another HIV question. HIV rates are now higher. Hold on, there we go. HIV rates are now higher in Manitoba and Saskatchewan than they are in developing nations like Kenya, where successful programs have dramatically reduced incidence. Have we looked at the strategies they have used to see how they could be implemented here?
Can I take a shot at that?
Sure.
Question? So I think one of the biggest issues is racism. So one of the biggest problems when we look and we put those rates out, say Indigenous versus non-Indigenous, because most of the decisions are made by non-Indigenous people. And there is a lot of racism, whether it's overt or subvert, in the healthcare system and people making healthcare decisions. If the rates, so here's a question, right? So as an example, monkeypox was declared a public health emergency, right? Even though it affected MSM, but there was like very few cases. Syphilis, which is like, we have a 1,400% increase, is not. Why? The answer to that is there. So that's one of the biggest pieces on that. In terms of looking towards, say the higher rates, that's a great question. Like in Africa and how do we apply some of those pieces? And I think there's a lot we should, and we do try to take from that. Part of that is because there is, we live in our health system, we live in a box. And we can't think outside of it. And so it's very difficult to make some of those changes, but taking those learnings, I think, are really important. So I would agree. It's different populations, different things, so it's not all applicable, but why wouldn't we look at other places with learned experience and learn from them and try to apply it? And these are structural issues of why things don't happen. It's my opinion.
Okay. Oh, Ken?
No, I'm okay with Stu's comment there, John. You can go on.
Sure. Okay, so there was a question. The question is about HIV strains in Manitoba and Saskatchewan, whether these strains are unique and favor heterosexual transmission, or whether there are social factors driving the heterosexual transmission. Thoughts?
Well, I think our data would suggest, and I think the fact that 50% of people don't have a house, that the rates of poverty in this population, I don't think I'm looking for a virulence factor. I think we know the challenges that we have for the future. It's the socioeconomic determinants of health. They need to be fixed. We need to give people opportunities to fix them. I think that's about the only way we're going to get through this HIV epidemic. I don't feel that there's a virulence difference. It really is the population that Stu has talked about as well, where there's overt racism, discrimination, all the other factors that are coming into play right now that I think are the main drivers of the pandemic on the prairies.
Okay. A coworker of mine went to give blood and was given a false positive for syphilis. They were told they could never donate again, even though it was confirmed false positive. They would be willing to be a donor if it weren't for all that. Will they ever be a donor?
Yes, hi. So we now recently started a so-called re-entry program where people who have a false positive test for syphilis can come back in at least 6 months after the initial test and try again. Unfortunately, a lot of people are positive again, and we don't have a smart enough algorithm or a complicated enough algorithm, I guess, where we use a different platform to test people, like they're tested again on the same platform. And so often whatever caused the false positive result, they get another false positive. But there is a route now, so they are able to at least try, if they're 6 months out, to come back. And they should call our contact center to figure out how to do that.
Excellent. Another blood question. A lot of questioning asked during blood donation surrounds sexual behaviors of gay, bisexual men who have sex with men. Now, with a lot of the HIV syphilis cases coming from women having heterosexual sex, will the survey change to reflect this?
Okay, I think by survey, the person is meaning the donor health assessment questionnaire. So it has changed. We no longer ask men if they've had sex with another man, and we ask the questions that I showed about a new partner or more than one partner plus anal sex. We also defer donors who have had syphilis in the past year, or gonorrhea in the past year, or who have used injection drugs ever. So there's a lot of other criteria there that also, I think, would defer a lot of the high-risk population that we've been hearing about.
Another tough question for Mindy. Has the decline in new blood donors led to this policy change, or was the policy change always an evolution?
Yeah, so the policy change has been an evolution for a long time. As you saw with that timeline, each of those changes required a submission to the regulator with data, risk modeling, compliance studies. So it has been a long road. I think a regulated system basically means a slow slow to change is when it comes to making things easier to donate. You know, maybe we add things quickly if we need to, but it's slow to remove things. I think we've been working on it, we and me personally, for a very long time. So I don't think it's related to the decline in donations. We have periodic shortages over the years, you know, this has been though an issue we've been dealing with over decades.
Thank you. Well, thank you to all our speakers of this section, Cam, Kimberly, Stu, and Mindy. Look forward to seeing you at Bug Day in the future. And we now have a break, but before the break, please remember to register. If you haven't registered, please remember to confirm your attendance. And we'll see you back at 3 p.m. for the grand finale. So thank you everyone for attending. Good afternoon and welcome back. So this is the last series of 3 presentations. For those of you who've stayed on to the end, thank you for staying, and the 3 presentations will be phenomenal. So our next presentation is Echinococcus multilocularis, a deadly tapeworm in Winnipeg. Pierre Plourde will give the presentation. Pierre is the medical director of the Travel Health and Tropical Medicine Services at the Winnipeg Regional Health Authority and a professor of community medicine, in the Department of Community Health Sciences and the Department of Medical Microbiology and Infectious Diseases, the Max Reedy College of Medicine at the University of Manitoba. Thank you, Pierre.
Thank you, Dr. Amble, for the invitation. And I know this is a Bug Day 27th edition, but it's my 25th anniversary for Bug Day. So if you can believe it, it's my 25th presentation. Yeah, I thought I would present this, and it's really I think the title had a question mark too, which I deleted here from my title slide, but is there really a deadly tapeworm in Winnipeg? So I have no conflicts to declare, so I'll skip over that. Most of you, or many of you, may be hearing about this parasite for the very first time and have never heard of it. It's known as the fox tapeworm because foxes were historically typically the animal most likely to carry this tapeworm, but around here, coyotes are probably the #1 animal, hence the picture of the coyote on my title slides. But any canine, dogs, domestic dogs included, wolves, and even cats can also carry this tapeworm. This is a northern tapeworm. You know, most parasitic diseases, or those of us who practice parasitology, are tropical medicine specialists, but this is kind of the opposite of the tropics. This is a parasite that lives in northern regions, all over the northern hemisphere, in Central and Northern Europe, as well as in Northern Asia. And in North America, including the Arctic, the endemic region in North America is mostly in the Western Arctic, what we call the Northwest Territories, and extends down into northern Alberta, northern Saskatchewan, and northern Manitoba. And until recently, we thought not really in southern Manitoba. And there are more recent new foci, possibly in southern parts of Canada, with, but I won't get into this, a European strain of this parasite having probably entered southern BC and maybe even southwestern Ontario, but I'm not going to get into that at all. This tapeworm is tiny. We think of tapeworms as things that are meters long, and yes, some human tapeworms are that long, but this one is barely less than half a centimeter long. So, and a full number of segments is only 4, maybe 5 at the most for the whole tapeworm. So this thing is tiny. It's the worm is in the gut of the fox or the coyote, and these segments break off, and the eggs that are in these segments end up in the stool and then in the soil. And the eggs in the soil, in the Arctic soil, can survive for a long period of time, even in sub-zero temperatures, are able to withstand a very wide range of temperatures and can survive easily in our winter climate. So in brief, the life cycle, again, the adult tapeworm is found in the canine, in this case, fox or coyote. The segments or proglottids of the tapeworm that end up in the stool and then subsequently in the soil produce eggs that are found in the soil, and these eggs contaminate the soil, contaminate the vegetation in the soil that might be eaten by rodents, for example. And so pretty well any rodent, beavers, muskrats, field mice, any rodent that will eat consume these eggs, the eggs will grow into a a larval form of the parasite inside, usually in the liver and even other organs of the rodent. It's a very slow growing larva. It doesn't necessarily cause much harm to the rodent, at least in the short period of time for that rodent's lifespan. And that rodent is more than likely to end up being killed by a canine predator than die of any other causes at some point in time. And when the canine, the fox, or the wolf or the coyote eats the rodent and then eats the larval form of the parasite, that metacestode on this slide, then it grows into the adult tapeworm. It becomes the adult tapeworm in the gut of the canine host. So humans, therefore, are kind of accidental hosts, as you can see on the bottom right-hand corner of the slide, accidentally become infected when we eat eggs. And so how do humans eat eggs? Well, it probably starts in childhood. It's more likely children who are going to become infected with this. They're playing out in the dirt that may be contaminated with eggs, or you're gardening in a place on the outskirts maybe of a city where there's infected coyotes, and the stool has contaminated, say, your garden, and there's eggs, and you're not cleaning your vegetables that you're eating raw very well, and not washing your hands. So it's by eating eggs that humans become infected. And when you eat those eggs, you get the larval form of the parasite, just like the rodent does. But in the case of the human, the larval form of the parasite, which could take 10, 15 years to gradually grow to this size that you see here inside the liver on this imaging, they grow into what looks like on a CAT scan or an MRI and behaves like an invasive cancer that can spread to local lymph nodes, that can spread to distant locations like the lungs, bone, and brain. And so this is a parasite that is potentially deadly because it behaves and acts very much like a metastatic cancer. And so early on in the disease, when you're infected in childhood, and you have a tiny larva developing in your liver, there may be no symptoms. There usually are no symptoms in the early stages for years, 5, 10, even 15, even 20 years, you may go without symptoms. And it's only when these things get big, like in this liver here, this very large, disorganized looking lesion with some calcification, it would appear, or actually this contrast medium, so probably with intense inflammatory component in the middle, you end up with symptoms when these things get big. Symptoms could include abdominal discomfort, gallbladder obstruction, bowel obstruction, or if the lesions are in the lung, chest pain, cough, bloody sputum, or in the brain, seizures, paralysis, or in the bone, pathological fractures. And again, with metastases, the disease undiagnosed, untreated, ends up involving multiple organs, and it's a metastatic invasive disease. And because it's silent and asymptomatic for so long, most often it's diagnosed in adults many years post-infection at an advanced stage with a very poor prognosis. Treatment is difficult, often unsuccessful. Surgery is pretty well always needed. These have to be removed surgically, but they're very difficult unless you catch it early to remove it in total, because they become so large and so involved with the blood vessels and bile ducts around the liver that they're often unresectable. You can't totally resect them. You can only take most of them out, but not the whole tumor. And if you don't take the whole tumor out, it'll just grow back, the parasite, like a tumor. And so you end up, even after surgery, usually needing lifelong treatment with chemotherapy of sorts or an anti-parasitic agent. Albendazole is the best one we have, because you only have to take it twice a day to prevent further growth and progression of the parasite. So it doesn't kill the parasite, but it prevents the parasite from growing any further after you've removed most of it surgically, or all of it if you're lucky. But the downside is lifelong use of this drug is associated with a significant risk of drug-induced liver injury. So if you end up having a problem with, very high liver enzymes as a result of being on this medication due to its liver injury caused by the drug, and you can't tolerate the drug anymore, then you're stuck with last resort treatments, which might include liposomal amphotericin B, or you might even end up being a candidate for liver transplantation. So a pretty nasty parasite. And the question, therefore, that we asked a few years ago, just before the pandemic, was, is this obscure tapeworm that nobody's ever heard of, that was known to be found in 25% of coyotes around Riding Mountain National Park 45 years ago, and we've seen in recent years in Manitoba about 1 case a year in humans cropping up out of the blue. Is this increasing? How close is this parasite to Winnipeg? So to answer that question, a fourth-year medical student worked with us, Carmen Say, and did a survey in the spring of 2018. She went out and found 169 stool samples, so coyote, fox poop, and domestic dog poop samples in the spring of 2018, ending up with 44 dog fecal samples, 1 fox fecal sample, 122 coyote samples, and then 2 roadkill coyotes were discovered by our veterinary colleagues, and they sent tissue for us also, all for PCR testing. So the stool was tested for PCR as well, which has a very high sensitivity and specificity. So the accuracy is pretty definitive. And with that sampling, we discovered we can't tell that all 124 coyote samples were from 124 coyotes because we knew there were coyotes around. We knew it was coyote stool by its appearance, but we could not tell how much duplicate sampling there could have been there. So how many coyotes, we don't know for sure. There were 44 dogs sampled though, because we had dog owners giving us this, who were walking their dogs in the dog park, the sample from their dogs. So there were 44 separate dogs, and there was 1 fox for certain that was sampled, whose stool was sampled. And what we found out is there is presence of this parasite. This Echinococcus is relatively harmless in comparison. This is the one, Multilocularis, that causes liver cancer-like disease, and almost 7% of the coyote samples were positive. The single fox one was as well. The only good news was no positive samples in domestic dogs. Now, I've heard subsequently, though, in the last 4 years, there have been a few, 3 or 4 positive domestic dog samples from Winnipeg and surrounding area with Echinococcus multilocularis. So we're seeing a slowly increasing trend of the presence of this parasite in canine, wild and domestic canine species. Essentially, in this survey back in 2018, about 10% of all the locations that we looked at showed positivity for E. multilocularis, including 1 positive sample in Kilkona Dog Park in the northwestern part of the city, and 2 positive samples along a popular trail in Birds Hill Park Village. And these are the spots here. The fox sample is the yellow dot, and then the red dots. There's 2 of them in Birds Hill Park that are overlaid, but you can see from the red dots, all the other positive samples were widely spread enough around the Winnipeg metropolitan region suggesting fairly significant positivity in wild canines in the region with a significant geographic distribution pretty well all around the city. So although this was a preliminary crude survey, this was not systematically done perfectly. It was kind of the best we could do without any resources one spring, and leaves us with some uncertainty. There is certainly a feeling that there is an increasing risk of human exposure to E. multilocularis in the Winnipeg region, and that positive samples in canines were found in areas frequented by both humans and domestic dogs, increasing the chance of coming into contact with infected eggs. So this is a new emerging zoonotic pathogen that imitates liver cancer, liver cirrhosis, and liver tuberculosis, and therefore could lead to improper, delayed diagnosis and delayed testing and treatment, which has dire consequences because mortality untreated is 90% within 10 years of the onset of symptoms. And so really early diagnosis and aggressive treatment improves survival, but you need a high index of suspicion really to ensure that early diagnosis. Here's what could be coming our way. Several years ago, Alberta was where we are, 0 human cases. We are now seeing 1 or 2 human cases a year in Manitoba, so not very many, but in 2017, Alberta only had 5 cases, then 10 cases in 2018, 15, they're now up to 30 cases in 2023. So these are human cases. We're not talking about animals now, we're talking about human cases of Echinococcus multilocularis, this potentially deadly tapeworm parasite. So finally, how do you prevent this? What do you do in the interim? Really, we need to make sure that our domestic dogs, especially those of us living on the outskirts of Winnipeg, walking our dogs in those dog parks, need to prevent our dogs from feeding on rodents or wild animals, because that's how our dogs will become infected. Our dogs need to be not only dewormed, but regular deworming in dogs is against roundworms, not tapeworms. So dog deworming with vets will have to include tapeworms as well as roundworms, and in order to really make sure that our dogs are not infected with this. And the tapeworm deworming medication is praziquantel, as opposed to the ivermectin-based treatments that vets usually use to treat the roundworms. And preventing human infection starts by preventing infection in our domestic dogs, but also by avoiding contact as much as we can with wild canids and their feces, especially in dog parks on our city outskirts, to try and not to encourage, again, wild animals to come close to our habitations or to keep them as pets. Be careful picking fruit in the wild, and make sure that you're washing your fruit and vegetables very well. Anything grown on the outskirts of Winnipeg, I would be very careful with washing and cleaning, and always washing hands after handling dogs and cats whose fur, if they carry this tapeworm, could harbor the eggs that could easily get onto your hands. So not much we can do right now, but a few things that are simple that we could do to try and prevent infection. But I think this non-reportable communicable disease means it's going to continue to be underappreciated. Ontario and Alberta have both made it reportable, and I'm hoping that Manitoba will be heading in the direction of making this a reportable communicable disease as well, so we can keep close track of where it's going.
Thank you, Pierre. So don't go away. Will be some questions at the end. So now, an unwanted souvenir, Chagas on the prairies. Philippe Lagacé-Weens is a specialist in medical microbiology at St. Boniface Hospital. And Philippe's particular area of interest is travel and tropical medicine. So Philippe, you're on.
Thanks, John. The other French name. I was just marveling at the fact that my colleague Pierre has been doing this for 25 years, and this is in fact the first year at Presented Bug Day. So we now have both extremes of the spectrum. I have no disclosures relevant to the content of this presentation, so I'm just going to skip right over that. I do want to talk a little bit about my learning objectives before I jump right in. We're going to talk about the risk factors for Chagas disease in Manitobans, and people will say, well, what about Manitobans? How is that possible? So we're going to learn why Manitobans may need to be screened for Chagas disease, describe the appropriate testing for Chagas disease, and to review the life cycle of Trypanosoma cruzi, and to describe some appropriate investigations and manifestations of Chagas disease. And lastly, we're going to talk about some treatment options. And I have 15 minutes to do this. So my daughter, who reminded me last night while I was practicing that my lectures at dinner time are longer than 15 minutes, we'll have to see if I manage to do it. I'm going to start with this case. This is a case I just saw last year. I've been following her for about a year. A 54-year-old woman with perfectly healthy, no significant medical history, and became a first-time blood donor on June 25th of last year. She just wanted to donate because all of her family was donating and she was healthy and she thought she could make a difference. And she answered yes to some of the screening questions related to birth or maternal birth in South America. And a month later, received information from Canadian Blood Services that she had tested positive for Chagas antibodies and by PCR. So to understand a little bit about what's happened here, some background from Canadian Blood Services, and I'm glad we had Mindy here who can, who, if she's still here, can certainly remember this. In early 2009, they implemented specific risk-based questions for Chagas disease. And very simply, it's, have you ever had Chagas disease? Have you spent more than 6 months continuously in Mexico, Central America, or South America? Or were you born in those regions? Or indeed, if your mother or grandmother were born in those regions? And after they implemented this, they implemented selective donor testing based on risk.
John Enville, talking about one of the key questions we spoke.
John, can you just turn off your microphone, please?
Proposed the material we were going to use for the cabinet.
Donors that answered yes to any of these questions could donate, but they required laboratory testing before the units were released. And what they do with the testing for Trypanosoma cruzi is essentially the same that we would recommend doing for our patients that we would be testing. And so they use an antibody screening assay. So they look only for the antibodies to Chagas disease. And if they find that, they would confirm it with a second assay. And then lastly, for the patients who are positive, they would do a PCR assay as a final confirmation. And those that were confirmed positive by either the 2 serological assays or the PCR were informed and told to get into contact with their physician and recommend management in individualized cases. What's interesting is that at that time, they also did a study. Of course, Canadian Blood Services does a lot of these studies in the background, which is great for us because we learn a lot. And they actually tested thousands of at-risk donors, and they also tested thousands of not at-risk donors just to see, do they really even need to be testing these patients? And they found out that if anybody answered yes to those questions, about 14 out of those 27,000 were testing positive. That means about 1 in 2,000 patients who answered yes to those questions would test positive. So obviously that was a significant risk. You certainly don't want to contaminate your blood products with Chagas disease, and so definitely those merit testing. But out of the 74,000 that were no risk donors, so answered no to all those questions, only 1 was positive. So that translated to a risk of about 1 to 2 in 100,000 in a low risk population. So as a result of this study, they actually went ahead and only tested patients or donors rather that answered yes to any of these questions. And incidentally, that 1 donor that had no risk was a Manitoban who was one of my prior patients as well. So introduction to Chagas disease. Now that you have some understanding about how Blood Services does this and what patients might be at risk, I want you to understand what is Chagas. And it's a parasitic disease. It's caused by a trypanosome. And you can see in my background, the screen here, you can see trypanosomes in the blood smear. That's what they are. And it's transmitted by insects of the subfamily Triatominae. These are called kissing bugs because they have a propensity to suck blood off of your lips or close to your lips and then defecate on your face. And that's why they're called kissing bugs. And they primarily occur in Central and South America. They have a large mammalian reservoir. So we're never going to eradicate this disease because there's too many rodents and mice and rats and rabbits and other rodents that are reservoirs. And acutely causes a non-differentiated febrile illness. But interesting with this particular parasite is it establishes a chronic lifelong disease. The infection is lifelong. It infects all sorts of cell types, but primarily involves muscular cells. And the disease manifestations are caused by chronic inflammation of the affected muscle that leads to damage to that muscle and to nerve tissues around that muscle. And primarily it affects the heart and the gastrointestinal tract. And this is a lifelong disease. Even with treatment, we can't get rid of it. We can mitigate some of the complications, but we can never get rid of it. This just summarizes the life cycle. This is public enemy number 1 here. The insect over here is a triatomine, actually feeding here on somebody's hand. The life cycle, it starts with an infected host. The triatomine feeds off of it and then acquires some of these trypomastigotes from their bloodstream. And then they go through a stage of reproduction inside the vector, inside the triatomine or the kissing bug. And then the kissing bug comes along and feeds off another host, this infected triatomine, will feed off the host, consume a blood meal, and then leaves a little present behind. They have a habit of defecating at the site of their bite. And their stool is actually chock-a-block full of the trypomastigotes that will lead to the infection. So if any of that stool gets into the wound they just created, or if somebody rubs their wound or gets it into their eye or a mucous membrane, it establishes an infection. And acutely typically causes, if it causes symptoms at all, a febrile illness that's undifferentiated, but in a lot of people is asymptomatic. This is the distribution of competent vectors for Chagas disease. So you can see most of them are in South America and Central America. There are some in North America, in the southern United States. However, infections in the United States are exceptionally rare compared to in South America. As you can see from the diagram on the right, red means that there's a lot more infections, and the green color of the United States is a very, very low infection rate. But primarily, this is a disease of the Americas, the South America and Central America and Mexico. So just to summarize some of the clinical findings in Chagas disease, some of the early signs during the acute phase, which really only happens in the first few weeks after your infection. And that's the only time you're going to commonly see positive blood smears or positive cultures in the blood, and a positive PCR result is guaranteed. This is the same time where you see some of the clinical manifestations like the chagoma, which is a swelling around the bite site. You can see in the left side in the middle here, or Romagna's sign, which is a swollen eyelid in periorbital tissues related to the inoculation being in the eye. This happens if you inoculate the stool into the mucous membrane of your eye. And this is the only time where you might see those trypanosomes in the blood using the microscope. If you have later disease, which is manifested by cardiac disease, here you see a right bundle branch block in this EKG, or cardiomegaly in this chest X-ray, or a very, very large esophagus from the parasite's damage to those muscles, or a very large colon in the X-ray on the left-hand side. That's the chronic phase of disease, and you have a negative smear, frequently negative PCR results, but serology is positive, and that's why serology is the mainstay of diagnosis. So if you're concerned that a patient might have been infected with Chagas, the test of choice is serology to look for antibodies against Chagas. To complicate things further, those that are infected, the vast majority, about 70 to 80% of them, will never have significant symptoms and will remain indeterminate forms for the rest of their lives, whereas only 20 to 30% of infected persons will progress to more serious disease. And that's what we're trying to prevent when we treat patients with Chagas disease. A few other forms of transmission need to be mentioned. So remember, Chagas disease can be transmitted through transfusion. That's why Blood Services does this, or through transplants. Transplant risk is quite high. Approximately 20% of transplants will result in transmission. If you have an infected organ, and the heart transplant is the highest risk. Congenital transmission. This is why they ask the questions about your mother or your grandmother. So 5 to 6% of mothers will infect to their children. Oral transmission can also occur, and this is a way that travelers can often get Chagas disease. So consumption of food contaminated with that excrement, the feces from the insects, and a commonly implicated beverage is acai berry juice in Brazil, which is made just by picking the fruit off the tree and then crushing it. So the insects like to live in those farms, and therefore can also contaminate the fruit. And there's no evidence that breastfeeding can result in transmission. So generally, no recommendations are made for that unless there's active bleeding involved. So going back to our patient, how did she get this? And so when I interviewed her, we found out she was in fact born in South America in the Lomo Plata Mennonite settlement in Paraguay. Her mother's family were poor and lived in these classic traditional mud and brick thatch houses, which are classic for the transmission of Chagas disease because the insects love to live in these thatch roofs. She emigrated to Canada in 1972, periodically returned to visit friends and relatives, but has been in Canada since 1981, except for one visit in 1998. It really had no other relevant travel. She's basically born there, and that was her substantial risk factor. She probably acquired it when she was a child, either from an insect or possibly from an infected mother congenitally. And just to remind people and why it's so important to Manitobans is that there are large Mennonite populations in Manitoba, and there are also large Mennonite populations in Paraguay. And the reason for that is many Manitoba Mennonites actually emigrated to South America during the establishment of secular education in Manitoba. So they wanted to maintain their control over their children's education and language. And so many of them actually moved away from Canada to South and Central America. And nowadays there's a lot of back and forth between these colonies. So it's important to recognize that in Manitoba, there's a lot of immigration between Mennonite groups. And we are actually accepting a large number of South American Mennonites into Mennonite groups in Manitoba, and could have a steady introduction of Chagas disease. So it's important to recognize it and know when to screen for it. So when we have a patient with Chagas disease, we need to do a symptom evaluation. We need to look for cardiac disease. That includes palpitations and syncope, pre-syncope, shortness of breath, or dysphagia and regurgitation and constipation for the GI symptoms. I mentioned that these are primarily cardiac and gastrointestinal symptoms. So when we do an evaluation, those are the symptoms that we're going to be focusing on. In our patient, she did report some strange palpitations from time to time. Other than that, didn't really have any significant symptoms, complained of some constipation and a little bit of dysphagia. So she basically earned herself a lot of investigations to determine if she had indeterminate or the more chronic forms of Chagas. On examination, she was well. I really didn't find anything in particular. So when we find these patients that have some vague symptoms and have a really normal clinical examination, we need to follow some algorithms that involve essentially looking for cardiac abnormalities. And for her, any patient that comes in with Chagas disease at a minimum needs to get an EKG and a history and a physical examination. And if any of those shows abnormalities, additional tests will be required. So because she did have some of these symptoms, we needed to perform additional tests beyond that EKG and look at an echocardiogram and some ambulatory Holter monitoring and exercise tests and some barium studies to make sure that her dysphagia and her constipation weren't related to megacolon. And in her case, absolutely no abnormalities on all of these investigations. So she ended up being a patient that ended up having these indeterminate forms, that it's 70% or so of patients that haven't progressed to more serious disease. Last part of my talk is to talk about treatment. There is strong evidence to treat Chagas disease in some types of infections. So all of your acute infections, of course, this patient was not acute, should be treated. All children should be treated for Chagas disease. And all immunosuppressed patients that have a reactivation of Chagas disease need to be treated. Where it gets to be a little bit more muddled is adult patients. So younger adults who don't have any cardiac disease. What we're trying to prevent with treatment is cardiac disease progression. If they already have cardiac disease that's advanced, there's no benefit to treatment. So adults that are less than 50 years should be offered treatment if they don't have cardiac disease. And older adults without significant cardiac disease, it's much more debatable. And in my practice, it really depends on their age and their general health. If they have a long lifespan ahead of them, 30, 40 years potentially, I certainly offer treatment. If they're very ill with other problems, if not cardiac problems, but very ill and may not live very long, it may not be worthwhile to treat them because cardiomegaly and cardiac problems take decades to develop. Regardless of whether or not you treat these patients, they must have annual EKGs for the rest of their life to early identify any kind of cardiac problems. I'm going to skip this. These are the studies that demonstrated that patients with no cardiac disease should be treated because they did not progress as rapidly to cardiomyopathy if they were treated, but I'm not going to get into the details of that. And in synopsis, generally adults with no cardiac disease should be treated. Older adults, there's less benefit, so may or may not benefit from treatment, so a case-by-case basis. And patients with very mild cardiac disease, again, only on a case-by-case basis. Part of the reason that we hedge on treatment is that the drugs are toxic. So nifurtimox and benznidazole are the only available drugs for treatment, and even then have to be accessed through special access. While benznidazole is generally better tolerated, there is a high rate of allergic dermatitis, upwards of half of patients, a high rate of nerve damage from paresthesia is up to a third of patients in peripheral neuropathy, and many patients get anorexia and weight loss, and they need to be taking this for 60 days. Similar side effects, but generally worse with nifurtimox. It needs to be taken longer. So we're trying to balance the benefit, lack of progression to cardiac disease, with the potential side effects that can be quite serious with these drugs. So going back to the patient, we did elect, despite her slightly over 50 years, she was very healthy and had likely a long life ahead of her. We treated her with benznidazole for 60 days. She tolerated it very well with no side effects. We gave her lifelong recommendations for annual EKGs and annual symptoms review. And we recommended all of her children and siblings should be screened in case she got it congenitally. Unfortunately, she did not end up telling her children, and we're still working on that. She's quite reluctant to inform her children as she blames herself because of her disease. But we'll continue to work on that. So in summary, simple screening questions: Mexico, Central America, or South America. Birth history is the only thing I would ask. Those other risk factors are really low risk and really only important for blood system screening. Women of childbearing age and pre-transplant patients are your highest bang for your buck, because women of childbearing age with Chagas can infect a second generation. So definitely worth treating those. Screening is always done by serology. Do not order smears or PCR. For screening samples, and any patients that are positive should be assessed by symptoms in a 12-lead EKG plus other investigation based on those symptoms. And the only treatments we have is benznidazole and nifurtimox, both of which require special access. That's everything.
Thank you very much, Phil. So, and then for the grand finale, we have Manitoba's most unwanted, not most wanted, most unwanted, frequently recovered parasites at CADM Lab. And Paul Vankeseel, the speaker, is the medical director of CADM Provincial Laboratory. He's a consultant on the Pediatric Infectious Diseases Service at Children's Hospital and a travel medicine specialist at the WRHA Travel Medicine Clinic, and a professor at the University of Manitoba in the Department of Medical Microbiology and Infectious Diseases. Paul.
Thank you very much. Just checking that you can hear and see me.
Yes, to both.
Well, thanks again for having me here today, and thanks to everybody who's still here and listening after all the fantastic talks today. So after, let's see, my screen, my slides are not moving here. There we are. That's the trick. So after Dr. Plourde and Dr. Lagacé-Wiens have regaled you with stories of creepy parasites, I'm going to take you down a tale of some of our local unwanted guests. So we're going to talk about some of our local enteric parasites, their treatment and their management, and we'll close with some risks for acquisition of a local dangerous zoonotic roundworm that fortunately hasn't been much of a concern, but stands a good chance to become a bit of a concern. So when you're talking about most common enteric parasites, there's several different ways of looking at it. So when we talk about globally what the most enteric parasites are, the World Health Organization, once it eliminates concerns about tissue and blood associated parasites, divides enteric parasites into the protozoan or single-celled organisms that can cause enteric disease, and the metazoan or multi-celled organisms or worms that can cause enteric disease. And they prioritize the protozoan or single-celled parasites into those that cause the most years of disability and those that have outbreak potential. So they focus in on Giardia, Entamoeba, and Cryptosporidium as the most common or most relevant, if you like, protozoan parasites, with Giardia affecting approximately 200 million persons per year and Entamoeba approximately 50 million persons per year. The multi-celled organisms, or the worms, we divide into nematodes, which are the roundworms, the cestodes, which are the tapeworms, and trematodes, which are the flukes. And the World Health Organization likes to spend most of its time talking about the soil-transmitted or soil-associated, helminths, or also called the geohelminths, which focuses in on Ascaris trichiurus, and hookworm as the most common. And certainly they affect 1.5 billion people between the three of them, with Ascaris affecting approximately 1 billion people. The tapeworms, Hymenolithus, or the dwarf tapeworm, is probably the most common, but the one that probably causes the most disability or years of living with disability is Echinococcus, which we've already heard a little bit about. And Schistosoma is probably the most common of the trematodes, or the flukes, that is. And if you look at that little map I've got just off to the right there, you can see it really picks on the tropical and southern countries, Australia excluded, mind you. And the northern countries really aren't encompassed much by what the WHO is looking at. So how about Canada then? Let's look at what the northern nations have to say. Canada doesn't really measure what the most common parasites are really particularly well. Our information about what parasites are commonly found in Canada is derived from reportable information, and that focuses in on parasites that are transmissible and have high outbreak potential. So thus, like World Health Organization, Giardia, Cryptosporidium, and in this case, Cyclospora, are the more common foodborne associated enteric parasites that we're concerned with. Now, this was a foodborne associated review, but enteric parasites can be picked up from the environment as well, not just from food or water. So looking at Manitoba, we're going to take a different approach to how we look at most common. We're going to look at the most commonly detected, in other words, in the lab. That means that a specimen has to be submitted and it has to be detectable in standard laboratory tests. Now, fortunately, I work at CADM Lab. We can sort through years and years of data. We can extract thousands of lines of data and then break it down into a table. And when we do that, we come up with these being our most common enteric parasites amongst the metazoans across 11 years, 2010 to 2020. Across the worms, Diphyllobothrium, or the fish tapeworm, no surprise really, is leading. Although Enterobius, the pinworm, is a very, very close second, and we know that CADM is not the only place that detects Enterobius, so we expect that pinworm is actually number one by quite a large margin. Hymenolithus, the dwarf tapeworm, is number 3, and then the Geohelminth, the Ascaris, hookworm, and Trichiurus are 4, 5, and 6 at a much lower level, and that's to be expected because they would have a difficult time living in our climate. The eggs and larvae would not survive well in our colder temperatures. Amongst the single-celled organisms, Giardia and Crypto do appear on the list in terms of being number 3 and 4. However, the neglected parasites, Blastocystis and Dientamoeba, which lately are found far more commonly around the world than their cousins Giardia and Cryptosporidium, are by far the more common single-celled parasites that we are seeing associated with enteric disease. So let's quickly blow through some of these. Let's talk about Diphyllobothrium. It's the fish tapeworm. It's among the longest of the human tapeworms, up to 25 meters in length, which definitely catches everyone's attention when it does happen. It's found worldwide, with most cases found in the northern countries, probably due to some cultural cuisine issues. We don't know exactly how many people are affected worldwide, but it's probably around 20 million amongst 14 species. Locally, our species is Diphyllobothrium latum, but there's a whole bunch of different possibilities, both in Canada and around the world. It's acquired, as one can imagine, from eating undercooked or raw fish, such as perch, pike, or walleye inland, but salmonids such as, well, salmon and trout, particularly in coastal areas, are very well associated. And the little troublemaker that we have to keep an eye out for is these little pleurocercoid type worms that you see off to the right, that are really only a couple millimeters in length, that are found in fish tissues, especially in fish muscle. The presentation is usually asymptomatic, with perhaps non-specific abdominal symptoms, pain, bloating, discomfort, perhaps elevated eosinophilia. An unusual symptom ascribed to Diphyllobothrium is tongue pain with eating, although that's a very rare and unusual one to hear about. I've never run across it. Vitamin B12 deficiency is classically described with fish tapeworm and occurs in up to 40%. But you don't actually see the megaloblastic anemia very often. Only about 2% are affected by that. Diagnosis is usually pretty straightforward when you find past segments of worm. First of all, it gets everybody's attention. And then the proglottids or the segments are typically wide with a very circular rosette-looking uterine structure in the middle of it that is very easy to identify. And the eggs are very easy to identify in the lab as well. Treatment is very straightforward and well tolerated. It's a single dose of praziquantel by mouth. It's always useful to look for the expelled head, which is called a strobila, because if the head is left stuck in place, then it can just regenerate the tail and start reproducing all over again. It's a very highly effective treatment. Without it, the adults can last about 20 years, but usually it doesn't cause too much of a problem, so it's nothing to panic over. And I have had a couple of patients that have decided not to pursue treatment. We have had to pursue one case in pediatrics, where we just couldn't get the head loose, and we had to do some work around providing duodenal gastrographin to sort of knock the worm out of place. Now, Enterobius, I think we'll all be familiar with, also called the pinworm or the seat worm. It's also worldwide in distribution in developed and developing countries, and all social classes are affected. It's considered the most common of the nematodes or roundworms, with greater than 1 billion people infected every year. 4 to 11-year-olds, more males than females, are the most common age group. And in the northern latitudes, there's possibly an October to December peak of presentations. Enterobius does not infect pets, and therefore they do not play a role in the life cycle of the pinworm, although they can carry the eggs on their fur and their paws and things like that, and that makes them a potential carrier of eggs. The infection is acquired via anal-oral transmission, usually via contaminated fingers or fingernails, and therefore it's not a foodborne or a waterborne parasite like many of the others that we talk about. The gravid female migrates from the area of the appendix or the cecum to the anus at night and crawls out to deposit her eggs, which elicits some itching in the area, and usually younger kids and toddlers will respond by scratching quite a bit, and that's how the fingers and fingernails get involved. Those sticky eggs stick very well to hands and nails and all manner of surfaces. And you can imagine, therefore, that transmission is strongly associated with poor hygiene, poor hand washing, nail biting, and contact with the perianal area. About 40% of people are asymptomatic or subclinical. And of course, for those that aren't, perianal pruritus that occurs at night is by far the almost diagnostic symptom to keep an eye on. It can lead to bedwetting in up to 50% of children, and of course, sleepiness, irritability, things like this. Rarely, the worms can migrate to other parts of the body when they get a little lost and result in vulvovaginitis or a urinary tract infection, more so in women. Pinworm has been associated with appendicitis in some descriptions, but that is not at all proven as a reliable association. Diagnosis is very straightforward. It's based on consistent symptoms in the right risk setting. In terms of investigation, the standard is the Scotch tape test, in which a piece of Scotch tape, not transparent tape, it has to be Scotch tape, so Dr. Plourde has told me many times over the years. And just dab the sticky side of the tape against the perianal tissues, and put that would be first thing in the morning after deposition, but before bowel movements or cleaning in the area, and put that on a glass slide. That's only about 50% sensitive per se, done once. Stool is not useful, so you'll see some recommendations that suggest 3 times. Treatment is not 100% necessary. Females die off in about 100 days, and therefore it's a self-limited illness. The real trick is preventing reinfection or reinoculation with all those sticky eggs. Thus, most people tend to opt for treatment, but it must be done in combination with an emphasis on concurrent hygiene measures, which requires excellent hand washing, nail hygiene, high temperature washing of undergarments, bed linens, towels, and good attention to perianal hygiene and perhaps even barrier creams for younger children. High likelihood that all household members will need to be treated and sexual partners as well. One of the good news items is the eggs don't last long in the environment. They begin to die off in volume at about 5 days at room temperature, and usually they're all done by 14 days later. In terms of the pharmacologic options, mebendazole, or Vermox is its regular name, or I should say brand name, is probably the best of the possibilities. It's about 90 to 100% effective if given in 3 doses, 2 weeks apart. CDC only recommends 2 weeks apart. There's no reason that we couldn't try that to start with. It is effective both against the adult worms and the eggs in killing them both off, and that's part of why it's preferable. However, it's not advisable in pregnancy, and it's indicated for children greater than 2 years of age. Albendazole is similar in terms of its effectiveness. However, it's absorbed, where mebendazole is not absorbed. Mebendazole is about 9% absorbed. So it's better for extraintestinal infections such as vocal vaginitis. Parental pamoate is excellent as well, and it's got a 90 to 100% effective rate as well, usually in 2 or 3 doses as well. And it is the preferred agent for pregnancy, preferably in the 3rd trimester. One of its limitations is that it does not kill the eggs. And ivermectin, which is a usual go-to for roundworms, for all of the other roundworms, if you like, is not as effective, and it's second line. Oops. So blastocystis is our most common parasite. It's a single-cell parasite, and we don't really understand its taxonomy very well. We think in the most latest iteration of taxonomy, which is an ongoing debate, which is kind of fun, is that it belongs in a totally new kingdom of life, not plant, fungi, animal, protista, but something called chromista. It's found in about 1 billion people, also animals, insects, and birds. Found worldwide, it's more commonly colonizing than it is a pathogen. And that's probably in part due to its many, many subtypes, and some of which are likely worse than others. And the map off to the side there tries to show you all the different subtypes and their distributions on the various and sundry continents, although for some reason we don't have good North American data in this particular, or European data in this particular study. We figure that it's fecal oral spread. It's not been very well studied. Blastocystis, like our next customer, Dientamoeba, is not well studied, so we're still learning. Got a cystic form that's probably transmissible, but it's the vacuolar form that we mostly see in the lab. This bug does not like to reveal its secrets. It's mostly found as a harmless commensal, but it is capable of causing symptoms if it's found in large numbers or if it's an immunosuppressed host, and no other etiology is found. Symptoms are usually low grade, non-specific, like abdominal discomfort, a mild waxing, waning diarrhea, bloating, things like this. And it can be associated with dermatologic symptoms like urticaria, palmoplantar pruritus, or angioedema. Diagnosis, like the others before it, is easily seen on a permanent stain of ove and parasite stool specimens. And this is what it sort of looks like off to the side here. These very round, very typical looking bodies here. The lab has to report out quantity, rare, few, moderate, many, and you would only really pay attention to moderate or many counts. If you only see a rare or a few, chances are it's not what's causing the problem in your patient. Metronidazole seems to be the best treatment. It is not well studied, but I tend to get fairly good response with metronidazole. Failures may need to be treated with combination therapies that include Ceftra or paromomycin, in combination with general hygienic measures, of course. A lot of my patients that come in with this, though, have very tolerable symptoms and are willing to wait and see how it goes over the next 2 or 3 months. And sometimes the treatment can feel worse, so I've had more than a couple say, you know, I wish I just held on instead. Dientamoeba, The last of our locals is actually a Trichomonas type organism, but it's lost its flagellum. It's one of those neglected parasites we were talking about as well. It's got a worldwide distribution and associated with poor hygiene. And for labs that are looking for it, it's often the most common or one of the 2 or 3 most common parasites that is found. It can also infect pigs, rodents, gorillas. Wouldn't that be a fun job, checking out gorillas? And primates as well. Transmission is still a bit of a mystery for this understudied one as well. The cyst form has only been recently demonstrated. We feel it's fecal oral, perhaps person to person and environmental. And it's got the interesting association that it may be co-transmitted with pinworm eggs. Some studies are very strongly supportive of that, others not so strongly supportive of that at all. So that one is still being decided on. Symptoms are very common. That you can have asymptomatic carriage, mind you, but abdominal pain, diarrhea that is either short-lived or in about 1/3 of cases, chronic, extending up to 2 years is possible. Eosinophilia is very common in children, 10% of the time in adults. Diagnosis, once again, is very easy by ovum parasite permanent stains of stool specimens. Some places do use PCR. We don't quite know how to interpret PCR, though, unless we can get some sort of quantitation from it. Treatment definitely improves symptoms and definitely clears the bug when everything's pointing to dientomida actually being behind what's happening. Iodoquinol is the treatment of choice. However, it takes longer to treat and is not as available in Canada, so I tend to use bromamycin, which tends to work quite well, is a shorter course and is very well tolerated. Metronidazole doesn't work quite as well. Tetracycline has barely been studied at all, but is a cornerstone of therapy. Last slide, we're going to talk a little bit about Balis ascaris, which is the raccoon roundworm. So we've heard about scary South American parasites, and we've heard about uncomfortable coyote parasites. Well, this is the raccoon parasites, in which humans can be an accidental host. And when that happens, it often causes a central nervous system larva migrans syndrome with seizures and fever and migrating focal neurologic deficits and an eosinophilic meningitis. Very difficult to treat. Patients, even with effective treatment, go on to have some deficits after. Fortunately, we don't have known cases yet in Manitoba. What you should know, though, is that this rather tough little infection can be acquired from raccoon feces that are found in raccoon latrines, which are communal places where raccoons actually gather to defecate, usually at the bases of trees or on rooftops. Infected raccoons shed millions of eggs per day, and they can last for many years in the environment. So these are actually not good places to drop by at all. And fecal oral transmission is the way that it occurs. Probably geophagia in those under the age of 5 is where it's happening. So in conclusion, thank you. Please wash your hands.
Thank you, Paul. So now, if we can pull up the Slido questions for Pierre, Philippe, and Paul Vacassio, that'd be tremendous. So a question for Pierre. What are your thoughts on empirically treating for someone for E. multilocularis if they have known exposure to coyote feces in their garden space?
Empirically treating with what? You're talking about a very, very long incubation, and we would have no idea. I suppose you're thinking about empiric treatment with albendazole, but how much and for how long? There's even controversy around screening. So instead of empirically treating, what about screening? But screening isn't so easy either. You can screen with serology, but serology will only tell you potentially you've been exposed. A lot of the serology turns out to be false positive. Most people with positive serology with E. multilocularis after potential exposure turn out never to have any disease. So the recommendation for screening is only in situations where there's a high risk. For example, your domestic dog has tested positive and you've had a lot of contact with your dog. Then you might want to screen somebody with serology, but the serology positive screens would go on to having abdominal ultrasound to look for evidence of the disease in the liver. And some are talking about maybe a yearly ultrasound if the first ultrasound is normal. So that's not an easy question, but it's a good one. And no, I don't think anybody would be recommending empiric treatment.
Okay. So if you could have, so are there some areas within Paraguay and Bolivia where there are greater instances of Chagas? Within Paraguay, there are Mennonite colonies in northern Paraguay and eastern Paraguay. Just wondering, is there a higher prevalence from one region to the other?
So the relationship between geography and Chagas is complicated, and it's primarily related to socioeconomic status. So the more impoverished areas are, the more likely they are to get high incidence or high prevalence of chronic Chagas disease. And that relates again to the type of housing that people live in and their access to households that reduce the risk of the reduvid bugs inhabiting those households. So I'm not that familiar with those particular Mennonite colonies within Paraguay, but in principle, instead of focusing on regions, if you're trying to really refine your risk factors, ask what kind of homes they lived in. Were they mud, brick, and thatch houses? Those are the ones that are exceptionally high risk. They've progressively been replacing these homes with metal roofs and standard bricks, which dramatically reduce the risk of Chagas. So it really boils down to the kind of housing that people live in, and that's their highest risk factor.
Thank you. And then one last question. Should we be screening for Chagas in all patients who present with non-specific insect bites and have a positive travel history?
No. Chagas disease is generally really only a risk for people who have lived in those areas, who have very prolonged stays in those areas. And of course, our blood service will ask, have you been there for 6 months continuously or longer? And that's really an effort to dramatically reduce the risk to the blood system. For the average individual who's presenting in Canada and Manitoba, really, it's the birth and residence history that we need to focus on, not so much travelers who have been to those areas, who may have incidentally encountered a reduvid bug. And again, bearing in mind, these things don't behave like mosquitoes. They don't just fly around and bite people. They live inside homes that have particular associated risks. These thatch roofs and mud houses, they're kind of like the bed bugs of the South, and they live in specific areas where there are specific kinds of housing.
Thank you. And then the last question, E. multilocularis has been described in Manitoba and Alberta. Is it present in Saskatchewan?
Yes.
Okay,
short.
so
Yeah.
okay. Well, I think that wraps up the program. So thank you for everyone who stayed to the bitter end. Thank you for our speakers, and we'll see you again next year on Thursday, October 17th. Thank you very much.